Hello. Check. Hello.
Assalamu alaikum, ladies and gentlemen. Kindly please settle down. We will be starting the conference right now. I am Dr. Ariba Qureshi, and my co-moderator is Dr. Myra Khalil, and we will be your moderators today for Rheumacon Pakistan 2024. I'd like to give a warm welcome to our esteemed guests for joining us today on our 5th annual international conference. It is an honor to convene with such a distinguished gathering of experts in the field. Throughout this conference, we anticipate insightful discussions, valuable exchange of knowledge, and collaborative efforts aimed at advancing our understanding and treatment of rheumatologic diseases. Like Rheumacon Pakistan 2023, this conference is going to be held both live and virtually. Ladies and gentlemen, please note that Rheumacon Pakistan this year is dedicated to the commencement of pediatric rheumatology at University of Child Health Sciences and Children's Hospital, Lahore. Previous Rheumacons have been a huge success, and this year we hope that the event is going to be a splendid one in terms of intellectual quality and social gratification. Today, we have 3 scientific sessions with multiple talks from our renowned speakers, followed by a question-answer session at the end of each session. The first scientific session comprises of 3 lectures, followed by an inauguration ceremony. Then we will have 2 more scientific sessions. Moving towards our first scientific session. The speakers for our first scientific session are Dr. Ataur Rahman, Professor Dr. Zina from Brelikos, and Dr. Taqdees Khalq. We will also have a brief discussion with our panelists at the end of this session.
In a nation where healthcare access remains a critical concern, the emergence of biologics and JAK inhibitors represents a significant stride forward. These treatments offer novel pathways to address a spectrum of chronic conditions, promising relief and spectrum improved quality of life for many. However, accessibility issues, cost considerations, and necessity for vigilant monitoring of efficacy and safety profiles underscore the multifaceted landscape we navigate. Our first speaker of our first session is Dr. Ataur Rahman. He is an assistant professor at Faisalabad Medical University, Lahore, Faisalabad. Dr. Atta did his training from Shaikh Zayed Federal Postgraduate Medical Institute, Lahore, and now working as a consultant rheumatologist in Faisalabad. His unit is completely recognized and fully accredited for FCPS training in rheumatology. He is supervisor there, and we congratulate him for this achievement. Please note that this is a recorded lecture, and he may join us online later. Thank you.
Bismillahirrahmanirrahim. My name is Dr. Ataur Rahman. I'm working as an assistant professor in the Department of Rheumatology in Faisalabad Medical University. First of all, I would like to thank the organizing committee of Rheumacon, who has given me an opportunity to talk on the topic of landscape of currently available biologics and JAK inhibitors in Pakistan, unveiling their potential, the limitations, and navigating the monitoring challenges. So as soon as the diagnosis of an inflammatory arthropathy is made, the recommendation is this: you need to start the disease-modifying drugs as soon as possible. So if we classify the disease-modifying drugs, they are broadly classified in 3 categories: the conventional disease modifiers, the biological DMARDs, also known as DMARDs, and the targeted synthetic DMARDs, and labeled as TSDMARDs. So conventional DMARDs include methotrexate, sulfasalazine, hydroxychloroquine, and lefonamide, which are not included into the topic of this talk. And we will be talking on biological DMARDs and TSDMARDs. If we further classify biological DMARDs, biological drugs, these are the proteins that are genetically engineered. They are made inside the cell, and they are targeting a specific molecule, or they're targeting a specific cell which are involved in the cycle of inflammation. So once the cycle of inflammation is broken by these drugs, so there is no more inflammation. more inflammation, no tissue damage, and there is a halt to the progression of the disease. In this way, these act as disease modifiers. So number one class is the cytokine receptor therapies. Cytokines are the various proteins that are made inside the cell to initiate inflammation, to propagate inflammation, and to recruit other cells of inflammation to a specific site which is involved in the disease process. So cytokine receptor therapies include anti-TNF, interleukin-1 inhibitors, interleukin-5 inhibitors, interleukin-6 inhibitors, interleukin-17 inhibitors, interleukin-23 inhibitors. And the second class of biologics, they target the B cells. B cells, they play a very major role in the process of inflammation. And third class are the T cell targeted therapies. And T cells, they also play a major role in regulating the B cells and playing a part in the inflammatory process. And the complement targeted therapies. And the complements, they also play in the antibody mediated damage to the body, to the tissues. And the third class of disease modifiers are the targeted synthetic DMARDs, also known as JAK inhibitors or Janus kinase inhibitors. So first of all, we will be talking about the biological disease modifiers and their availability in Pakistan, and what are the prerequisites to start these drugs, and how to monitor during the treatment of these drugs, and what are the potentials of their use in Pakistan, and what are the limitations of their use in Pakistan. So let's start with the cytokine associated drugs. First of all, we will be discuss the anti-TNF drugs. So anti-TNF drugs, these are the biological agents that target the tumor necrosis factor alpha, a key cytokine involved in autoimmune and inflammatory diseases. So once the TNF is blocked, so the process that is initiated by TNF, the inflammatory process, is stopped at that point. Once the inflammation is stopped, the tissue damage is stopped, and the disease is modified in this way. So there are 5 anti-TNF blocking drugs that are approved for the treatment of various inflammatory disorders. Number 1 is etanercept, infliximab, adalimumab, certolizumab, and golimumab. Only etanercept is marketed by the manufacturer in Pakistan. Infliximab is somehow made available, but it's not registered in Pakistan. The biosimilars, they are recently made available. Same is the case with adalimumab. It is not marketed by the manufacturer in Pakistan. And certolizumab and golimumab, they are not available in Pakistan. So we'll be focusing on etanercept here, which is available here in Pakistan. So these are the anti-TNF drugs with their recommendations in various disorders. So they are approved and being used for the treatment of many inflammatory arthropathies, including rheumatoid arthritis, psoriatic arthritis, and inflammatory bowel disease related arthropathies, JIAs, and in some complications of the spondyloarthropathies like uveitis or in JIAs. So if we see the etanercept, so its use is a little bit limited as compared to the adalimumab, because it is not recommended for use in uveitis, and it is not recommended for use in inflammatory bowel disease and inflammatory bowel disease associated spondyloarthropathy. So it is recommended for use in rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, and plaque psoriasis, and JIAs. So as etanercept is the only drug that is freely available, that is marketed by the manufacturer, so we'll talk about this in detail. It was approved by FDA in 1998 for the treatment of autoimmune disorders. So it has a long data available regarding its safety and complications and many other things. So its dose is a little bit different in pediatric age group as compared to the adult patients. Special warnings and precautions. So what are the precautions we need to take before prescribing this drug? And what are the monitoring challenges associated with this drug? So the topmost thing that should be seen before the starting of these drugs is the infections. viral infections, the bacterial infections, the fungal infections. You need to look and screen for these infections before starting the drug. And the other infection that is very common in Pakistan, very much prevalent, is tuberculosis. So we need to look for tuberculosis before starting of this drug. We need to go for a test for latent tuberculosis even by doing some IGRA test. If it is positive, we need to treat the tuberculosis first, then we start on the drug. And the other two infections, which are very important, that are very much prevalent in Pakistan, is hepatitis B and hepatitis C infections. We need to get the serologies of hepatitis B and hepatitis C before starting the treatment, because it can reactivate hep B and it can worsen the hep C. And we need to look for allergy, any allergic histories of the patient, malignancies, any lymphoproliferative disorder, because as very data is available regarding the little bit increased chance of lymphoproliferative disorder with prolonged use of etanercept. Vaccinations is very important, as live vaccines should be avoided during the treatment with etanercept and other anti-TNF blockers. And you need to complete the vaccinations as a local protocol before starting of these drugs. So this is a list of side effects of etanercept. So the injection site reactions, headache, respiratory tract infections, GI symptoms, neurological symptoms, worsening of psoriasis. And this is the complication and adverse effect that need to be solved before treatment, during treatment, and after treatment of the serious infections. Blood disorders that need to be dealt with accordingly: hypertension, cutaneous vasculitis, liver and renal dysfunctions, and exacerbation of development of multiple sclerosis in a few cases. And the second class of biologic that belongs to the cytokine inhibitors is the IL-1 inhibitors, anakinra and canakinumab, and these are not available in Pakistan, so we won't discuss in detail, but these are recommended for the treatment of rheumatoid arthritis, for CAPS, like cryopyrin-associated periodic syndromes. So these are not available in Pakistan. And in future, inshallah, all these things will be made available in Pakistan as well. And the next is interleukin 5 inhibitors, epolizumab, and interleukin 5 receptor antagonist, bralizumab. And both of these drugs are not available in Pakistan. And these are indicated for the treatment in EGPA, also known as Church-Strauss syndrome, and in chronic rhinosinusitis, and in severe asthma as well. So next class is IL-6 inhibitors. So tocilizumab, sarilumab, and anti-interleukin 6 receptor antagonist is siltuximab. Only tocilizumab is available in Pakistan, so we will discuss it in detail. So tocilizumab, it is indicated in a wide variety of diseases like rheumatoid arthritis, giant cell arthritis, systemic sclerosis associated ILD, cytokine release syndromes, COVID-19. It was widely used in COVID-19 in 2020 and 2021 with variable response, but it was recommended by FDA to be used in COVID-19. Systemic JIA and polyarticular JIA. So how does it works? Interleukin 6 is a pleiotropic pro-inflammatory cytokine. And it has many functions to do in inflammatory processes. It is involved in diverse physiological processes at T-cell activations and induction of immunoglobulin secretions, initiation of hepatic acute phase synthesis. And this tocilizumab is a humanized IgG monoclonal antibody that binds to soluble and membrane-bound forms of interleukin 6 receptors. So once the receptor is blocked, so there is no signal transmission from the interleukin 6 for all these actions. So once these actions are stopped, there is no inflammation, no tissue damage, so disease is modified in this way. For prerequisites, if we see the prerequisites for all the biologics are almost the same. So there are three things that should always be borne in mind while prescribing these biologics. Number one is to screen for infections, look for latent tuberculosis, and do a serology for hepatitis B and hepatitis C. And live vaccines, they should be avoided during the treatment, and the vaccine protocols should be fulfilled before starting of these drugs. So monitoring is very much important to tackle the side effects at an early time, like CBC, differentials, hepatic enzymes, every 1 to 2 months, lipid panel, initially every 1 to 2 months, and once a stable dose is achieved, then after every 6 months. Warnings are the same, the serious infection, the reported infections that have been reported with the IL-6 inhibitor usage is the active tuberculosis, which may present with pulmonary and extrapulmonary disease. So test for latent tuberculosis should always be done before initiation of this drug. So other bacterial, viral, and infections due to opportunistic pathogens. So we need to closely monitor the symptoms and signs of infection before treatment, during treatment, and after stopping the treatment as well. So next class of biologics that target the cytokines is IL-17 inhibitors. So interleukin-17 inhibitors are secukinumab, ixekizumab, but only secukinumab is available in Pakistan. So we'll talk about this. Secukinumab is a human interleukin-17 antagonist indicated for the treatment of active psoriatic arthritis, adults with active ankylosing spondylitis, adults with active non-radiographic axial spondyloarthropathies, and active enthesitis-related arthritis, ERA, in pediatric age groups, moderate to severe plaque psoriasis, and adults with moderate to severe hidradenitis suppurativa. These are some dermatological indications for the usage of secukinumab. In psoriatic arthritis patients, adult patients, the dosage is 150 milligrams subcutaneous after every 4 weeks. If a patient continues to have active psoriatic arthritis, the dose may be increased to 300 milligrams after every 4 weeks. And this dosage can be given without a loading dose and with a loading dose. If one need to give a loading dose, it is 150 milligram weekly for 4 weeks, then shift to 150 milligram every 4 weeks. The same is the dose with ankylosing spondylitis. So warnings and precautions, also the same. The infections, serious infections have occurred. Exercise caution when considering the use of secukinumab in patients with chronic infections or a history of frequent infections. So screen the patient for tuberculosis, look the patient for any history of inflammatory bowel disease, especially if you are treating a patient of spondyloarthropathy, because secukinumab can worsen the inflammatory bowel disease. And the same is the immunization protocol as was with the IL-6 and anti-TNF blockers. Monitoring is the periodic differential counts of CBC, hepatic enzymes monthly until a stable dose and every 1 to 2 months, lipid panel every 1 to 2 months until a stable dose and then every 3 to 6 months. So next class is anti-IL-23. And none of these drugs is available in Pakistan. So now the next class of drugs, that is a B-cell drug. These drugs, they are not targeting a specific cytokine, either they are targeting a typical target cell that is involved in the process of inflammation. So B-cell targeted therapies include rituximab and palizumab and belimumab. Only rituximab is available for rheumatological uses in Pakistan. So rituximab is a monoclonal antibody that targets the CD20 antigen and it depletes B cells. And B cells, they play a very major role in the autoimmune processes, production of autoantibodies. When the B cells, they are depleted, so there are no more autoantibody production. And these autoantibodies, they are responsible for the tissue damage and inflammation in various organs. And it is also indicated in lymphoproliferative disorders. So how does it work? It binds to CD20 on B cells, and these B cells, they are either damaged through apoptosis, and either they engage the complement system, and it's a complement mediated damage to these B cells. In this way, the B cells, they are depleted. So once the B cells are depleted, so there are no more autoantibodies to propagate the process of inflammation. So approved indications in rheumatology for rituximab are rheumatoid arthritis and granulomatosis with polyangiitis and microscopic polyangiitis, classified together as ANCA-associated vasculitis. So we need to screen the patient before starting. So two major screening protocols for is to work up for hepatitis B infection and complete blood counts. HBV infection by measuring hepatitis B surface antigen and anti-HBC antibodies before starting the treatment with rituximab, because there are many cases have been reported in which there is reactivation of hepatitis B with the use of rituximab. So how to monitor it? CBC every 2 to 4 months to monitor for late onset neutropenias as well, IgG level prior to rituximab infusions in order to make sure that patient is not hypogammaglobulinemic. Recommended doses for rheumatoid arthritis, it is given as a 1000 milligram intravenous infusion separated by 2 weeks, and that may need to be repeated after 24 weeks. And recommended dose for GPA and NPA is 375 milligram per square meter IV infusion every week for 4 weeks. Warnings with rituximab. The fatal infusion-related reactions, they have been observed when 24 hours later than the infusion. So a patient who has been given rituximab should be observed for next 24 hours for the development of any infusion-related reactions. Severe mucocutaneous reactions, progressive multifocal leukoencephalopathy, other infections like bacterial, viral, and invasive infections, cardiovascular adverse reactions with some arrhythmias, renal toxicity, bowel obstruction and perforation. Immunizations should be avoided with live vaccines during the treatment with rituximab, and it is not safe to be used in pregnancy. So next class of drug is complement targeting therapies, eculizumab, and it's also not available in Pakistan. T-cell targeted therapies like Betasap, and this is not also available in Pakistan. JAK inhibitors, the next class of drugs that is recently approved for the treatment in various rheumatological disorders, and they are made widely available in Pakistan by different companies. And out of these 3 JAK inhibitors, tofacitinib, baricitinib, and upadacitinib, only tofacitinib is available in Pakistan, and it is being marketed by many companies. For the use of tofacitinib is rheumatoid arthritis, psoriatic arthritis, polyarticular JIA, ulcerative colitis, and ankylosing spondylitis. What does it work? If we see here, the cytokines, they are attached to the cytokine receptors, and then the JAK enzyme is there inside the cell, and that is phosphorylating these STAT proteins. And these STAT proteins, then they go into the nucleus and cause the production of messenger RNA, which is then translated into the cytoplasm. And these cytokines and chemokines and other proteins, they are released outside the cell. So it blocks, these drugs block this JAK inhibitor. When the JAK inhibitor, they block this JAK enzyme. When this JAK enzyme is blocked, so there is no phosphorylation, no activation of the STAT proteins. So inflammatory process is stopped at this point. So long-term safety issues are also with the related JAK inhibitors. These include the serious infections, malignancies, and lymphoproliferative disorders, increased risk of cardiovascular disease, hypertension, dyslipidemias, especially in old age patients, more than 65 years of age. And there are higher rates of pulmonary embolism and death using high doses of tofacitinib, that is more than 10 milligram in rheumatoid arthritis patients and patients with ulcerative colitis. So there is increased risk of DVT and pulmonary embolism, and this is a dose-related effect. If it is used in doses of more than 10 milligram per day, so chance of DVTs and pulmonary embolisms are increased. So other side effects that are observed with JAK inhibitors is the bone marrow suppression, hepatotoxicity, increased risk of various infections, other metabolic disorders, thrombosis, arterial and venous and pulmonary embolism, and malignancies like solid tumors and lymphomas are reported in tofacitinib group, but not placebo-related groups. So we need to look for all these effects during the treatment and after the treatment as well. And all these patients before starting of this drug should be screened for any active infection, for any latent tuberculosis, hepatitis serology. And if the patient comes out to be positive for latent tuberculosis, then this TB need to be treated first, and then the patient can be started on this drug. So what are the points where we need to stop this drug during treatment? If there is a hepatotoxicity, the liver enzymes are more than 3 times the upper limit of normal ranges. Bone marrow suppression, if a hemoglobin drops by 2 gram per deciliter or it falls below 8 gram per deciliter, there is lymphopenia, lymphocyte count falls below 500, or the episode stopped of tofacitinib until the count recovers and then restart at lower doses. So dose modification in renal impairment, no dose adjustment is required in mild cases. In moderate to severe cases, the dose is reduced to half. And in liver impairments, in mild cases, no dose adjustment. In moderate cases, we decrease the dose to half, and in severe cases, it is not recommended. In pregnancy and lactation, use of tofacitinib in females of reproductive age groups may impair fertility potential, so it should be used with caution. Its use in pregnancy and lactation is not recommended. And drug interactions, it can be used with the conventional synthetic disease modifiers, but it should never be combined with biological disease modifiers. All the pre-treatment evaluation need to look for any cardiovascular risk factors before starting, the blood counts and active infections, the T-spot TB for latent tuberculosis, hepatitis B and C serologies, liver function test, and renal function test. Monitoring baseline, we need to get the baseline test, then monthly for 3 months. And once the dose is stable and there are no side effects, and it can be taken to every 3 months. Maximum effect on lipid occurs by 6 to 8 weeks. Thus, lipid panel should be done by every 12 weeks. So now here comes, we will talk about, as a general, the limitation of these drugs, as we have discussed, is the cost of these drugs. This is a study that was done in US. If we see the patients on different biological agents, the annual cost is roughly around 40 to 50,000 US dollars. That is very, very high. If we convert it into the Pak rupees, it will go around 10 to 12 million rupees per year. So, and another study that was done in Japan, and the first year of treatment, the second year of treatment, and third year of treatment with various biological agents, we see the cost is the same, around 40 to 50,000 US dollars per year. And we see the situation in Pakistan. The average salary in Pakistan is around 81,000 Pak rupees, with the lowest of 24,000. And vast majority of the patients, they are earning in the range of 30 to 40,000 per month. And that is equivalent to 287 US dollars only. And that, if we compare it with the income in US, that is 7,900. This is a big discrepancy, and it's quite comparable with the India, but it is even lower than India. So average cost of treatment with biological agents in Pakistan is around 0.6 million per year. So a vast majority of the patient, they are not affording these biological drugs. So average cost of treatment with a JAK inhibitor is around 0.12 million per year. That is relatively cheaper, but even this drug is out of reach of a vast majority of the patients in Pakistan. So I think this is the real hindrance. So first hindrance is the infections like tuberculosis and hepatitis B and hepatitis C. And even the bigger hindrance is this economical situation in Pakistan, because there is no universal health insurance in Pakistan. Patient, they have to pay from their own pockets to buy these drugs for their treatment. So here we have some suggestions that the local guidelines regarding the treatment of autoimmune inflammatory arthropathies should be developed. Because in American College of Rheumatology and EULAR, they recommend the use of biological agents once there is a failure with a single conventional synthetic disease modifier. So a vast majority of the Pakistani population is not affording for this. So we need to develop guidelines in which we may look for the combination of disease modifiers. Further studies are required in which conventional synthetic disease modifiers may be combined to achieve the targets of remission in rheumatological disorders. And secondly, we can write to the authorities to increase the budget for the Sehat Sahulat program. And I talked to a local person of SSP, and he told me that the allocated budget for rheumatological disorders is only 60,000 rupees per year. So, which is quite, that's not sufficient to even buy a drug for 1 month even. So we need, and the same SSP program is giving around 1 million financial assistance to the patients of cancer and other neurological disorders. So we can write to the authorities that the budget of these rheumatological disorders may be increased so that population may get benefit of these revolutionary drugs, which really are important in the treatment of these diseases. So thank you very much. If you have any questions, I will be glad to answer these. Thank you very much.
Thank you so much, sir. Our next talk is focused on a topic of great significance in the realm of rheumatology and autoimmune disorders, an overview and update on the International Axial Spondyloarthropathy Guidelines. It is a chronic inflammatory condition affecting the spine and joints, and it poses significant challenges to both patients and clinicians. Today, we have a privilege of hosting a distinguished expert in the field who will provide us with valuable insights in the latest developments, advancements, and recommendations that are outlined in the International Axial Spondyloarthropathy Guidelines. Without further ado, Dr. Professor Xenophon Berlikos will enlighten us with the expertise in this critical subject. Dr. Xenophon is a senior consultant and scientific coordinator at the Rheumazentrum Rubert, Henle, Germany, and associate professor for internal medicine and rheumatology at Ruhr University, Bochum, Germany. Dr. Berlikos is the current president for the Assessment of Spondyloarthropathy International Society, past chair for the European League Against Rheumatism, Standing Committee on Musculoskeletal Imaging, and a member of the EULAR Executive Committee. He is also the member of American College of Rheumatology, the Group for Research and Assessment for Psoriasis and Psoriatic Arthritis, and the German Society of Rheumatology. Finally, Dr. Berlikos is also a reviewer and associate editor for numerous rheumatological journals. Please note, this will be a recorded talk. Thank you.
Far away, but still I'm sure we can make for a good discussion. What we wanted to discuss is, as you see in the title, what we call the evolution in the AxSpA management in the light of international guidelines. And I am working myself in a very big rheumatology center, the biggest in Germany. I'm having a special interest in access spondyloarthritis. I was also involved in the international guideline as a member of the steering group that published them 2 years ago, a year and a half ago. And what I will do is to show, based also from what I know from your local situations, I will show you how the guidelines work, how we apply them, also the evolution in terms of adding now IL-17 inhibition in our guidelines, and which has been a major step forward. And we will, of course, also discuss the differences between possible treatments, including biologic and targeted synthetic DMARDs. Now, I would like to also remind you that what we have is the old guidelines from 2016. They were published in the beginning of 2017, and the newer guidelines that we published in December 2022. There is no big differences in terms of how they have been conducted. So we have one phase 1, we have the second phase 2, and the third phase 3, where we really step by step go through the medications that we have available in access spondyloarthritis, and try to put the patient in the best condition as possible, as soon as possible. And you will see that the timelines have now been shortened in terms of when we take decisions for the treatments. Now, going into more details, I would like to remind you that what we do is that we start our treatment by having a clinical diagnosis. That's the same as in 2016. We apply and recommend physiotherapy. We recommend exercising and quitting smoking as one major step for treatment. And this is even before any treatment with non-steroidals or others has started. So in patients who are even asymptomatic, we say that this should be applied. Even in those who may come with pain, we apply physiotherapy. These things we will discuss. When it comes to quitting smoking, which is something that many people really believe is something which is more kind of a general health advice, this is not so much the case in access spondyloarthritis. There is even more behind this data. Here you see data from the British registry, where they checked for the patients who ever have smoked as compared to those who never smoked. And you see that there have been differences. They have been statistically significant. Let's say BASTA, BASFI, BASMI, in terms of having lesser disease activity in the non-smokers as compared to smokers. And even if somebody was a smoker and has stopped smoking for at least 1 year and longer, as compared to those who have continued smoking, the stopping of the smoking has decreased disease activity even further. And this was also statistically significant, even after adjusting for several variables. So altogether, and this is the same, by the way, for the other parameters. So altogether, we believe that smoking and even quitting smoking in the smokers makes sense for disease activity decrease. Now, regarding physiotherapy, there is unfortunately a lot of heterogeneity. We don't have the same interventions in all the studies. We have different duration of the intervention, from 1 week to more than a year. We have different outcomes that have been taken into account there. So this is not so easy to understand. However, what we have seen is that, and here you can look at the green boxes, what is that 3 different physiotherapy approaches are useful for these patients. One is physiotherapy or exercises in the water. So water exercises, swimming, seems to bring some benefit. The other one is aerobic training. This means jogging, cycling, and so on. That is something that also brings even improvement in disease activity, and in both in ASTA and BASTAs, sorry. And the other thing is stretching. Stretching exercises, here it was compared with laser therapy. This did not make any difference, but stretching seems to really bring something more in terms of function and global pain improvement. So altogether, there are not many physiotherapy areas that we would recommend, but those that are here, water exercise, aerobic exercises, and stretching seem to play a big role, and they are recommended for these patients. They can do it in the group, they can do it with a physiotherapist, but of course they can also do it themselves. And this is something we recommend together on top on quitting smoking as well. Now, of course, the patients that we see, they come to us because of issues that when they are symptomatic. Therefore, we would indeed say, in that case, on top to the other two exercises and quitting smoking and so on, we would start with medication. The first step to start is still the non-steroidal anti-rheumatic drug treatment. We say that we would titrate up to the maximum tolerated dose. So we really treat with full dose. Full dose is as much as the patient can afford based on the indication for at least 4 weeks, for at least 2 weeks and maximum of 4 weeks. Now, within those 4 weeks, we are also allowed to change more than one NSAID if the first one did not work well. What kind of data do we have to support that? We have done a study that showed that if you take patients, non-radiographic and radiographic, it doesn't matter, who have all a BASTA of more than 4 at baseline, and you give them the maximum possible dose of NSAIDs, you decrease the BASTA significantly already after 1 week. So disease activity is impacted positively by NSAIDs. And on the other hand, if you continue the NSAIDs for more than 1 week or 4 weeks, you do not add anything more. So this study was positive in terms of showing the good effect of NSAIDs in patients with axial spondyloarthritis. However, there are two main limitations. First of all, what you can achieve at the first week, 7 to 10 days. If the patient does not respond within 7 to 10 days, I would change the NSAID. It does make much sense. The other thing is that indeed we improve the disease activity significantly, but still we are at high levels of disease activity. So NSAIDs are good for some patients, but the majority will still increase the average disease activity index. And therefore, although they are efficacious, the NSAIDs, we believe that they are just for a very limited amount of patients recommended. Otherwise, they are not really the best way to go in the long term. And you, of course, also know the safety issues we may have with heart issues, with kidney and liver issues, and so on. The other thing is how many patients we really put into remission, and that's from the same study. We took here the BASTA below 3 as the level of low disease activity. We took the ASDAS below 1.3 as the level of inactive disease, and the ASDAS partial remission as the level of remission. And you see here after 4 weeks of maximum dose, about 15-16% of patients were in remission. This is far too low. So again, there's just a very limited amount of patients who will, unfortunately, be candidates for NSAIDs in the long term. Now, if that all doesn't work, we would like to go to phase number 2. If the patients do well with the NSAIDs, they can continue with decreased dose, then we continue. But otherwise, we would like to go to a phase number 2. This is what the majority of the patients will do. And that means here that in patients with mainly peripheral symptoms, we would also consider sulfasalazine or glucocorticoids injection locally. Is there an evidence for that? So for the injections, there is some evidence that they help. Here you see a study where they took an injection by CT intra-articularly or peri-articularly, as if you would not do it with CT, more or less blindly by ultrasound guidance. The intra-articular injection indeed improved the BASTA in that case, and the pain in that case. However, you see after a week the patients increased their pain levels again. The peri-articular injection didn't do anything. So if one wants to avoid any kind of treatment for any reason, injections may be helpful, but they need to be done under clear CT guidance. It's a whole bunch of things you have to do for that. And unfortunately, this is something for very short period of time. And of course, it's also associated with radiation exposure. So also for us, not really the best way to treat patients. And when it comes to sulfasalazine, yes, we know that, again, peripheral arthritis may be treated with that. After 3 months in the registry from Norway, they did not find, here you see the p-values, they did not find any improvement of all of those parameters, with exception of the BASTA, and especially here question number 3, which has to do with peripheral pain. But this is it. It's only the peripheral pain that may increase, and for that you also need 3 months. So also not the best way to go here. Now, when we speak about anything else, everything else that makes sense, of course, we need to speak about biologic DMARDs and targeted synthetic DMARDs. How do we do that? Well, we check for our disease activity statuses, and here we always check for the change in the BASTA, in the ASTAs. We have omitted the BASTA. This was in the recommendations in 2016, 2017. Now we rely only on the ASTAs, and here we recommend a change of more than 1.1. If that occurs, then the patients are doing well. If that does not occur, then we obviously need to go on to the biologic treatment. I would like to remind you that the ASTAS has 5 questions, 3 questions from the BASTA, 1 patient global assessment, and the CRPs are included. And there's also the cutoffs for low disease activity, including inactive disease, or high disease activity and very high disease activity. And the cutoff is here, 2.1. This is the change of the ASTAS, and this is the status. Yeah. There is a reason to omit the BASTA from the recommendations, and one of the reasons you can see in this slide in this study. What we did here was to take patients from Germany who were on a biologic, here on the TNF blocker at that time, and it's an older study where we analyzed the data. And we started, or the colleagues in rheumatology department started the BASTA, the treatment with a BASTA of more than 4. Here it is the blue line, the group with patients of BASTA more than 4. Some of them nevertheless started the treatment with a BASTA below 4 for any reason that I do not know, but these were the data. And the range here was 2.8 to 4. And some other patients started with a lower BASTA even of below 2.8. What did we see? We saw that in the blue line, according to the recommendations, BASTA more than 4, BASTA decreased over 2 years. However, also in the lower cutoff, starting from 2.8 and on, also here the BASTA improved, very similarly to what the blue line did. So this very much means that, and this is also the meaning, experience we had from daily practice, even patients who may not reach a cutoff of 4 of a BASTA may be candidates for a biologic. However, the recommendations so far did not capture them, and that's why we always started higher. It makes sense to obviously replace the BASTA with the ASDAS, for example, which is much more disease-specific, and to omit the BASTA totally from what we take as a recommendation. Nevertheless, what physicians do in daily practice is, of course, their thing. But I just want to mention that here we have these changes, and the reasons for these changes of which parameter to use for assessing disease activity are studies like this one. And of course, when we talk about biologics, then about other treatments, we need to talk about logics and targeted synthetic DMARDs. And the very big change that this recommendation has, there's 2 big changes. This is the one, is that we do not only have TNF blockers here anymore, but we have included IL-17 inhibitors on the same level of evidence as TNF inhibitors before. We also have the JAK inhibitors. I will say a word about that later. Here is the word of caution because of safety issues that we have put here on the on number 2 as a reference. But again, the big difference is that we do not only have TNF blockers anymore. Now, the recommendations also say that we would start the current practice is TNF blockers as known, but IL-17 inhibitors as we know them now. If there is active inflammatory bowel disease or active uveitis, we would use a monoclonal TNF blocker. Etanercept is a little bit problematic here because there is no data for it, and there is also additional information that it may induce IBD. And if there is psoriasis, we would certainly use IL-17 inhibitors over, or prefer IL-17 inhibitors over the TNF blockers. So that is more or less the situation. For the JAK inhibitors, we did not recommend them as similarly yet, simply because there's not enough data. And again, there are also safety issues that we will discuss later, that we said that we need more data to really make a comment on that. But there, again, everything is on the same level in terms of starting immediately after an NSAID. What's the evidence for TNF blockers? Well, I mean, everybody knows that. I think there is not much to say here. I would just like to cite one study only that showed that a TNF blocker is efficacious as compared to placebo or to NSAIDs. Here is a 1-year placebo phase in that study. And we had very good results already after a couple of weeks, which continued over a year, whereas in contrast, the NSAID patients did not improve. So they work, we knew that. What do we know about IL-17 inhibitors? Here the data with secukinumab that we have as the only IL-17 inhibitor with such long-term data. We published the 5-year follow-up now means a couple of years already back. And here you see that indeed, independent of whether or not whether you take ASAS 20 or ASAS 40, in the entire group, or even in those who first line were treated, so it's not the switchers from a TNF blocker, but these are the first line treatments, these are the TNF naive patients, they showed very good results. And you see that there is no big difference, in fact. So it's independent on whether or not you have pre-treated the patient. The IL-17 inhibitors in that case, long-term, worked similarly well in pre-treated and TNF naive patients. What about JAK inhibitors? Here just the example of upadacitinib. The results that we have had so far show similarly good results in terms of treatment. Again, there are other issues that we may prefer the one drug over the other, but just in order to be fair with all data, I think it makes sense to have mentioned that we do not see very big differences in the treatment effects. It is the individual patient that needs more care, that we need to be careful on. Regarding MRI improvement in inflammatory activity, here you see the 3 studies with TNF blockers. That's a study with secukinumab. Here with infliximab after 6 months, with etanercept after 1 year, with adalimumab after 3 months. And sorry, here this was after 6 weeks. You see that the inflammatory activity disappeared. So altogether, we are able to show that indeed very fast, within 6 weeks, what is it here? Within 6 weeks, we are able to decrease inflammatory activity significantly, and patients get rid of their inflammation in their spine and the sacroiliac joints. We also have the very first study now that try to prove the efficacy of biologics in patients with axial manifestations, but those who are PSA diagnosed. This is what we call axial PSA. And the very first study was with secukinumab, the maximized trial where we gave secukinumab to those patients with PSA and axial involvement as compared to placebo, and we showed in those PSA patients with inflammatory axial involvement significantly better results with secu as compared to placebo. And those with placebo, when switched to secu, they were actually similarly doing well. So in fact, this confirms the efficacy of the axial disease of IL-17 inhibition of the secukinumab. That was an interesting study because it was the very first of its kind, and there is no other study so far in that regard. Now, if we talk about what we would do when the patients have been treated, of course, we would like them to be in the remission, sustained remission, and then continue with tapering. And that is something that we, of course, also have stated clearly in the recommendations. This is not the case. This was not the case in 2016. Here we say clearly, please taper, and the better the patients are, the faster they are in remission, the better then we can continue with tapering over time. Are there any data? Well, there are some data with biologics that have shown that if you stop the drug here in that gray line, patients flare again. The lower the graph goes, the more they flare. However, if you continue in the one similar dose, or if you continue with the reduced dose, there is no change in the treatment effect. So overall, this is a clear evidence, together with other studies, to say that indeed it makes sense to think of tapering when the patients are in remission. Here they were in remission, they either stopped or they continued with half dose or full dose. Now, the question is what happens if the patients do not do well? Here we have the situation, and that's the second big change, big difference as compared to the old recommendations, that in phase number 3, we said if there is lack of efficacy and the disease activity is still high, please switch to another biologic, either TNF blocker or IL-17 inhibitor. Now we say, before you do that, please reevaluate the diagnosis, check for presence of comorbidities that may influence disease activity in terms of it being high before you change the treatment. And if active AxSpA is confirmed, this means there's no comorbidity or issues that influence this activity, or there's any doubt on the diagnosis, please first reconsider. What does that mean? Well, reevaluation of the diagnosis may mean something like this. For example, in this first patient, where we have a sacral fracture after treatment with a biologic long time after. The patient had an accident, there was a sacral fracture here, there was low back pain, and obviously the symptoms came from that fracture and not from any loss of efficacy of the drug. Or it might be that indeed there is a misdiagnosis. Misdiagnosis means here like osteitis condensans, where there's a lot of sclerosis both on the iliac part, but the MRI shows also sclerosis, but there was no inflammatory activity. Or there might be something like that, where we had the metastatic carcinoma after long periods of time, this time without the treatment, but still when it comes to that, it might be that you have low back pain due to metastasis, or also in patients with DISH, who may also have some slight inflammatory activity, but there is new bone formation mainly in the thoracic spine that has nothing to do with spondyloarthritis. So all these things need to be taken into account. We also know, by the way, that the diagnosis may be put in, or may be questioned when especially the MRIs have been misread and misunderstood. And there's misdiagnosis. There is this Dutch study here that showed that not only in axial spondyloarthritis, but also, for example, in females after giving birth, or in frequent runners, or even in healthy volunteers, there might be up to about 20% of people with an MRI that is positive. And this is one study of ours where we found that indeed bone marrow edema, and this is the same patient in three consecutive slices, bone marrow edema may indeed be look like positive, even in a healthy volunteer below 45 years of age. So we just need to be sure MRI has been read properly, the radiologist is aware of what they are doing, and we have the clinical symptoms that confirm the diagnosis. How do you look like that? Well, just very briefly, you have MRIs that look like this. It's a lot of inflammation. It's around the middle part of the joint where there is cartilage. That is spondyloarthritis, as compared to very little inflammatory activity, which is more in the ventral part. This is more a bone stress like edema. Has nothing to do with SPA. Just as just so you see how we would read these MRIs. There's also other reasons to fail treatment or not to respond to treatment, and especially this has to do with obesity. So these are the p-values for those interactions of those BMI categories. You see here in obese patients, the category, this is the patients in the obese patients, the treatments were much lower or lesser patients have replied or have responded to the treatment as compared to the normal or the overweight patients. So overall, obesity may also play a role, especially because then you're also moving lesser and so on. And there's also these studies, one from Italy, one from Switzerland, that show that there's differences between males and females. Especially for the males, there is more chances to become a patient with a partial remission as compared to if you're female. And there's also here the p-values between males and females, also for the other outcomes, as is 20, as is 40, ASDAS, and so on. So altogether, there's many different reasons to unfortunately fail primarily the treatment, and these need to be taken into account. There's also this issue of secondary fibromyalgia. Here you see the p-values between those who had or those who did not have fibromyalgia on top of spondyloarthritis. If the patient does have secondary fibromyalgia or central sensitization, as we call it, issues, then there might be also lesser effect of the treatment. Now, importantly, we also need to know when we lose our patients. For lose means when they relapse. And there is a study with etanercept that showed that there is a high amount of patients especially with TNF blockade, we know that you lose within the first year. This is the blue line. See, these are the relapses. This is the percent of patients with relapse. These are years 2 to 6. But the very first year is critical because there is exactly where we lose the most of the patients, again, as shown in that study, which also confirms my clinical experience. So altogether, we also need to be aware that we need drugs, we need treatments that are not only efficacious but also safe. And there indeed, there might be different reasons for leaving the drug, for stopping the drug, either safety or inefficacy issues. But again, these numbers are pretty high, up to 40% only remain in the treatment. The others leave the treatment, which again may become problematic. This is, of course, also why we need more treatments than just the TNF blockers. Now, arriving at phase number 3, we say that if somebody has fulfilled everything that we believe there is a right diagnosis and there is still high disease activity, in that case we would suggest to switch to another biologic, either the TNF blocker or the IL-17 inhibitor, or if there is clear reason to the JAK inhibitor. But again, this is a bit left aside because we need more data for the JAK inhibitors here. And interestingly, we have conducted a small sub-analysis, I have to say, with not so many patients, but this is what we had. It was 80 and 146, where this is now with ixekizumab, but it's about the concept, IL-17 inhibitor versus TNF blocker, where we said, okay, what if the patient does not reply, does not respond to the TNF blocker in the beginning? Does he or she respond to ixekizumab or to IL-17 inhibition later? And we found that 1 out of 4, which is not little, 1 out of 4 of the patients who do not respond to a DNF blocker before will respond to the IL-17 inhibitor after, which is something to consider. Of course, we do not know who is the patient to start with IL-17 inhibition, who is the patient to start with a TNF blockade in the beginning, but obviously this switch makes sense. And again, I come back to what we had before. Then this is all for the phase number 3. If we go back to phase number 2, regarding remission, we also need to take into account that those in the remission in good efficacy statuses, they will continue, and they need to continue with lower drug doses, but of course, being efficacious. Now, this is relatively easy. I believe it makes sense. It's trivial. We don't need to discuss that longer. But one important thing that we need to take into account here is what happens beyond disease activity. And that thing is the issue of radiographic progression and syndesmophyte formation. Now, let's take this from the beginning. We've shown in this study that if you treat with a biologic, independent of what that is, this is baseline. And you see here the inflammation. 3 months later, the inflammation will be gone. So we know that there is good efficacy here. What we did in that study, though, was that we added a specific tracer in a PET examination that is specific for osteoblasts. And here you see the osteoblastic activity in the beginning, here in the hybridization of the image, the PET MRI. But the positive message of that study was that when the inflammation is gone, then the osteoblastic activity is also gone. So we do have a true disease-modifying effect by treating with biologics. We don't see that by NSAIDs, by the way. Now, in order to prove if this is also well happening with the drugs that we see in what we measure, so the drugs that we use as what we measure, this means with either TNF blockers or IL-17 inhibitors. We conducted a study that was called SURPASS. And the SURPASS study was having a primary aim to see if there is lesser radiographic progression with one or the other drug, secukinumab or adalimumab biosimilar. Now, the effect of the TNF blockers was well known, so we knew that indeed we had a positive effect overall, as I showed you before. And what we found was at the first sight that there was absolutely no difference. So the positive effect that we knew from the TNF blockers, you see here the lines overlap, the progressors are the same. These are the progressors here. The positive effect that we knew from the TNF blockers was seen also for the patients with secukinumab, which is positive in a way that, again, we confirmed the good effect of TNF blockers, but we did not see a difference again. We dipped more into the data and found that there are some changes and differences, especially when we treat with an IL-17 inhibitor as compared to the TNF blocker, especially when we measure the progression. So here we take every patient and say who progresses and who not. Here we measure the average progression in the whole group. And we found lesser progression with secukinumab as compared to adalimumab. These are now data that are going to be published soon. This is only for 2 years, so I do assume that this line may have changed if we would follow up our patients over 4 years. We don't have the 4-year data, but it seems to be that there is something in here. There is a difference, which we need to understand a little bit better between the different treatment options. Now, I was asking myself, and we have some evidence on that, that's why I put it in here, how we can really work on this concept and how to explain that concept. And you see here that we know from data that were shown at ACR in 2015, here's the reference, they were then published in 2017 in full, I forgot to change the reference here, from rats. And these rats had the SPA model. They were infused for having the arthritis that we know, in peripheral spondyloarthritis as we know it from rats. And what they showed was not only arthritis, they also showed peri-osseal ossification. This is new bone formation. When the rats were treated with an IL-17 inhibitor, this ossification, this new bone formation did not happen. So there was indeed the hint already that we may be able to stop radiographic progression, which we did not entirely show in the human yet at least. However, we also have good data to show, to believe that there is some good efficacy here. These are data that we published long ago, and we try to understand the biomarkers that we do not measure in daily practice, but they might be important for what we do with our treatments with our patients. And the biomarkers, the most important biomarker for understanding radiographic progression is DKOPF1, DKK1. This DKK1, when it's low, you have no protection. You get new bone formation. When it's higher, you are protected. You get no new syndesmophytes. And what has been shown pretty nicely, this is one of the different studies that are shown, that is that if you treat with an IL-17 inhibitor, this DKOPF1 increases, so you get more protection. The same is for sclerostin, another biomarker, shows exactly the same. Here is at baseline within 1 month. Here is after 3 months. Here is after 6 months. The longer we treated the patients with the IL-17 inhibitors, the better the protection was against TNF blockade. So there is, against new bone formation, sorry. So there seems to be a good effect, but it takes time. This we need to understand, and that's why it's also important to not lose our patients within the first year, to really continue for a long time with the treatment, as we know it also with the IL-17 inhibitors and the biologics in general. And then they do not only improve and benefit clinically, but they also benefit radiographically. What about safety? Well, I will not give you all the data because it's a lot of data to report about safety. What I've brought here is 2 or 3 slides only, which are, I believe, important since we know that IL-17 inhibition especially, but also TNF blockers with their limitations are safe drugs. What we did here was to take the 5-year secukinumab safety data in patients with psoriasis, psoriatic arthritis, and ankylosing spondylitis. And we checked for all the possible drug-related adverse events, as we also know them from TNF blockers. And the main thing that you see is that we have almost everywhere either zeros or, let's say, extremely low numbers. Wherever I would go my cursor, you see in the beginning might be something, but otherwise you lose it. So there is no there's no clear, let's say, signal for any kind of issues. Even the IBD part was very low, which is the reason why we do not say the patient should not be treated with 17 blockade if they are inactive. If they are active, you don't have any effect with the 17 blockade, but otherwise this is not a contraindication. So altogether, very low rates of any adverse events with IL-17 inhibition across all indications. in the preparation of this talk, I was, of course, also looking for something that is more relevant to you than it is for us, which is tuberculosis. We do have some patients who come in and they have latent tuberculosis. However, I can tell you that there is almost no data here, and this is simply because we know that IL-17 inhibition does not affect tuberculosis at all. There is in vitro data that has shown that even the bacteria do not grow if you put IL-17 inhibitors, especially secukinumab. This was the first data there on them. It's different from the TNF blockers that, where you have the granuloma that may resolve. And the same also for JAK inhibitors, we have to say, because there you have a multi-cytokine approach. But for the IL-17 inhibition, this is not an issue. We have to do the tests, unfortunately, still in Germany also. But this is, at least to me, nonsense. It doesn't make any sense for that because you just don't need it. Okay, it is on the label, but in fact, there's no effect here. And the other thing that is important, I mentioned safety with JAK inhibitors before. Without wanting to speak bad about the one or the other drug, there is still nevertheless the issue that we need to discuss. And the most important study that has, I think, that is maybe even the most cited study in the last couple of years in rheumatology is the so-called oral surveillance study, where it was tested whether or not there is MACEs, myocardial infarctions, and also thrombosis, peripheral thrombosis in those patients who were treated with tofacitinib, as compared to now TNF blockers. That was the study. The study failed. It did not meet the primary endpoint. And not meeting the primary, you see here the confidence intervals, not meeting the primary endpoint means that tofacitinib in that case was having or showing higher rates of MACEs and pulmonary embolism and thrombosis. So altogether, there are warnings both from the FDA and the EMA here for when we treat with JAK inhibitors, both in rheumatoid arthritis, but also in spondyloarthritis and psoriatic arthritis. We can go into details if you wish, but this is a little bit the problem we have with the JAK inhibitors. Although they seem to be efficacious, the safety events that we have to take into account. Now, by that, I'm at the end of my presentation. I hope you enjoyed it, and I'm really very happy to take up questions. Thank you.
Thank you so much, sir. Before moving towards the last talk of our first session, I would like to announce the panelists for this session are Professor Dr. Fazle Haq Mahmood and Dr. Ali Rukh Pirzada. Dr. Ali Rukh is an assistant professor at Bahawalpur Victoria Hospital and who is also a feather in cap in Department of Rheumatology in Shaikh Zayed Hospital. Moving towards the last talk of our first session, TNF-alpha inhibitor, etanercept, is one of the cornerstone medications of modern rheumatology. With its introduction decades ago, it heralded a new era in the management of many autoimmune diseases. So I would like to announce Dr. Taqdees Khalik, Associate Professor at Federal Government Polyclinic Hospital, Islamabad. This is a recorded talk and she may join us online later. Thank you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and a very good morning to all the participants. It is indeed an honor and a pleasure to be a part of this great Rheumacon. My apologies for not being present there physically. It was because of some unavoidable circumstances in my family. So the topic of my talk today is etanercept, years of practical evidence. And before I begin, I would like to disclose that the talk has been sponsored by Pfizer. These are the learning objectives of my talk. I'm going to give you a brief overview of the drug, its structure, and different indications for the use of this drug. I'll also be going through the possible adverse events that can happen when a person is being treated with etanercept. This would be followed by some real-world data that has been gathered from different registries. And in the end, I'll be discussing a couple of cases from my clinical experience where I've used etanercept for the management of ankylosing spondylitis. So before starting formally, let us recall our knowledge of immunology. You all know that TNF-alpha molecules are one of the most potent mediators of inflammation, and it has been implicated in the pathogenesis of several rheumatic diseases, including rheumatoid arthritis, ankylosing spondylitis, psoriatic arthritis, etc. So it is only logical that any drug that can counter the effect of TNF-alpha molecules would benefit the patient. So keeping this in mind, let's now go through the structure of etanercept. So this was the first ever biologic drug to get FDA approval for the management of SPA. It is basically a dimeric fusion protein consisting of two TNF receptor molecules. So these are the TNF receptor molecules, these blue structures here, and these are then connected to the Fc portion of IgG1 antibodies with the help of these protein bridges. So the resultant molecule works as a decoy receptor to which the circulating TNF-alpha molecules bind, and then they get neutralized, and hence the process of inflammation comes to a halt. This is just a diagrammatic representation of whatever I've just mentioned. These are the circulating TNF-alpha molecules which get attached to the etanercept molecule, and after this binding, they get neutralized and their function comes to an end. So this is the timeline of FDA approval for etanercept. It first got approval for the management of rheumatoid arthritis in the year 1998. And this was followed a couple of months later by approval for management of GIA. It wasn't until July 2003 that it got approval for the management of ankylosing spondylitis. So this is the landmark trial on etanercept, after which this drug received FDA approval for the management of ankylosing spondylitis. It was the principal investigators were Dr. John C. Davis and Dr. Vander Heide. There were a total of 277 patients in this trial. 139 of them were being treated with placebo and 138 of them were started on etanercept. The dose of etanercept that was used was 25 milligrams twice a day, and it was given to the patients for 24 weeks. At the end of 12 weeks, it was noticed that 59% of the patients in etanercept group and 28% of the patients in the placebo group achieved ASAS-20 remission. And when it was carried out for another 12 weeks, it was noted that 57% of the patients in the etanercept group were still maintaining ASAS-20 response, whereas only 22% of the patients in the placebo group could do so. So these are a couple of indications, FDA-approved indications for which we can use etanercept. In adult population, we can use it for the management of rheumatoid arthritis, axial spondyloarthritis, psoriatic arthritis, plaque psoriasis, etc. And as far as pediatric population is concerned, we can use it for the management of GIA in children who are 2 years of or older in age. It can also be used for the management of psoriatic GIA, again in children who are 2 years or older. And it can also be used for the management of plaque psoriasis. So as far as adverse effects are concerned, the list is really long, but fortunately the overall incidence is not too high. The first and the foremost are the cutaneous reactions, and of these, injection site reactions are the most common ones. About 5% of the patients can present with injection site reactions, and this includes itching at the site of injection, erythema formation at the site of injection, or bruising. And sometimes the patients can even have a generalized allergic reaction, and sometimes they can even present with fixed drug eruption. This is followed by incidents of by development of serious infections, and FDA has actually given a black box warning. So there is a chance that once the patients become immunocompromised, they can develop fungal infections, bacterial infections, and even different opportunistic infections. And then there's also risk of reactivation of tuberculosis. This is actually very pertinent to people living in subcontinent because we know that our area is endemic for tuberculosis. So it is mandatory that anybody who's going to be started on etanercept must be screened for the presence of latent tuberculosis. And this can be done by having a look at their chest X-ray, by performing a Monto test, and also going for IGRA testing. Then there's also a chance of reactivation of hepatitis B infection. And again, it is advocated that patients be screened for latent Hep B infection by looking for their hepatitis B core antibodies. And if they're found to be positive, then they should be asked to have their hepatitis B DNA PCRs done. And if the PCR is positive, then they should be given prophylactic. They should be given treatment for hepatitis B infection. And if the PCR is negative, then it's mandatory that you keep on repeating the PCR every 3 to 6 months, just to make sure that the virus is not getting reactivation. So next, there is also a concern that patients can develop worsening of existing heart failure, or they can also develop new onset of heart failure. So it is suggested that patients should have a baseline echo done just to assess their cardiac function. And patients who have NYHA class 3 or 4 heart failure should not be treated with etanercept. Hepatotoxicity is also encountered sometimes in patients who are taking etanercept. It can simply be a case of transaminitis precipitated by the use of etanercept, or there have been cases where autoimmune hepatitis, the patient has developed autoimmune hepatitis. So whatever the case may be, stopping the drug helps in this helps the patients. And next, we can also encounter hematological side effects, but fortunately, the incidence is really low. It is less than 0.1%. So patients can present with pancytopenia, or very rarely, they can also develop aplastic anemia. We have also seen over the years that patients can develop a lupus-like disease after getting treatment with etanercept. So anybody who becomes ANA positive, develops characteristic rash of lupus, presents with hematological or any other manifestations of the disease, must be checked for the presence of anti-dsDNA antibodies. Fortunately, as soon as etanercept is stopped, this manifestation also starts to abate. Then there's another black box warning regarding the use of etanercept, and that is the development of malignant lymphomas and solid organ tumors, and this is especially true for the pediatric group. However, the data is still conflicting, and some authorities believe that it is not because of etanercept that they develop malignant malignancies. It is perhaps because of the primary disease that they suffer from, or because of the concomitant use of other immunosuppressant drugs like methotrexate or azathioprine. Whatever the case may be, we should always be on the lookout for this particular adverse effect. Then patients have also been seen to develop antibodies against the etanercept molecule. These antibodies are usually non-neutralizing, as opposed to the antibody formation against other TNF-alpha drugs like all the MABs that are there. So if a patient is not responding to the etanercept treatment anymore, then it is worth checking for the antibody development. Lastly, there's also a concern that patients can develop certain neurological complications. Unfortunately, again, the incidence of these side effects is very low. It is less than 0.1%. So patients can develop demyelinating disease. Sometimes patients have also presented with optic neuritis, transverse myelitis, or even multiple sclerosis. So with this, I come to the next part of my presentation, where I'll be sharing real-world data regarding efficacy of etanercept. So it has been shown to be effective in reducing the signs and symptoms of ankylosing spondylitis, including pain, stiffness, and inflammation. Many clinical trials and observational studies have demonstrated improvements in disease activity and physical function after getting treatment with etanercept. So one such study is basically the ADEQUATE study, which is a German prospective non-interventional study, which was done to evaluate the proportion of patients who respond to treatment with etanercept. It had different limbs. For example, patients who had rheumatoid arthritis, patients who had psoriatic arthritis and ankylosing spondylitis, all of them were evaluated in different limbs. So I'll be focusing only on the results only from the ankylosing spondylitis limb. So initially, 333 patients entered the study, and 28 of them were excluded because they did not fulfill the entry criteria. 305 patients were then included in the study, and however, only 182 patients could complete the study. The rest of them continued, were dropouts because of various reasons, like insufficient effectiveness of the drug because of presence of different adverse effects or due to any other reason. So the patients who completed the study, it was noted that at the end of 24 weeks, 19%, almost 19% of the patients had achieved remission, whereas at the end of 52 weeks, 23% of the patients had achieved remission. And as far as low disease activity is concerned, 45% of the patients achieved low disease activity state at the end of 24 weeks, and 45% of the patients achieved low disease activity state at the end of 52 weeks. And these statistics are actually quite encouraging. And as far as maintained responses are concerned, it was shown that patients who had achieved remission maintained this response. 56% and almost 57% of these patients maintained this response at week 24. And also patients who had achieved low disease activity, about 65% of them maintained this low disease activity state at the end of 24 weeks. It was also noted that there was a decrease in the usage of steroids by the patients, and overall there was also a decrease in the dose of steroids that were being used, and this also indirectly meant that the drug was working nicely, and the requirement for steroids started declining after some period of time. As far as adverse effects are concerned, the major treatment emergent adverse effects were drug ineffectiveness, which was noted in 10% of the patients. Then 7% of the patients developed nasopharyngitis. None of the patients had to be hospitalized for that. 2.6% of the patients experienced aggravation of their existing condition or developed injection site erythema or any other injection site reaction. And around same percentage of the patients developed hepatobiliary disorders. As far as treatment emergent serious adverse effects were concerned, they were seen in 11% of the patients. Of these, cardiac disorders, intervertebral disc protrusion, hepatobiliary disorders, and GI disorders were most notable ones. So in conclusion, these findings confirmed the effectiveness and safety of etanercept in routine clinical practice and highlighted potential benefits of continuing etanercept treatment in patients who have not reached their treatment goals beyond 12 weeks. And additional benefits included improvement in patient-reported outcomes and reduction of concomitant glucocorticoid usage. So I think we all need a breather after this heavy discussion. Let's take a moment out and marvel at the beauty of this mighty mountain, K2. This picture has been taken from Concordia, which is basically the base camp of K2, and it's one of the most wonderful sights in this world. So moving on, I'll now be discussing some real-world data regarding safety of etanercept in ankylosing spondylitis. So here, generally, it has been noticed over the years that etanercept is a very well-tolerated drug in patients with ankylosing spondylitis. Common adverse events associated with etanercept treatment include injection site reactions and upper respiratory tract infections, as we have already seen in the previous study. And serious adverse events such as infections and malignancies have been reported, although the overall incidence is pretty low, as has already been discussed. So in this regard, I'll be sharing the results of ESTER trial. This study was published in 2021, and patients with ankylosing spondylitis who were being treated with etanercept were followed for a period of 10 years, and then the results were published. So there were a total of 76 patients who were enrolled in the study. 40 of them were started on etanercept, whereas 36 of them were started on sulfasalazine. And Overall, 66% of the patients completed the study for a period of 10 years. These are the different disease and functional status assessment parameters that were assessed. This one is PASTI. This dotted line here represents PASFI score. This interrupted line here is for ASTAS CRP, and this line here is for PASMI scores. And all of these scores were assessed at week 24, and all of them showed a rapid decline. And this was then sustained over a period of next 9.5 years. So this was quite encouraging. So as far as details of this trial are concerned, we first have a look at the PASTI score. We see that the baseline PASTI score was quite high for both the radiographic and non-radiographic SPA patients. It was 5 and 6.2 respectively. And both these groups showed significant decline in their PASTI scores at week 24. It was found to be 2.4 for the radiographic SPA patients and 3.2 for the non-radiographic SPA patients. And then this was sustained over the next 9 to 9.5 years time period till the end of 10 years, when it was still 1.9 and 1.4 respectively. Similar was the case with ASTAS score. At the baseline, it was quite high, but at 24 weeks, it had declined to 1.5 for the radiographic SPA patients and 1.7 for the non-radiographic SPA patients. And then this response was sustained over the next 9 years. Till at the end of 10 years, it was 1.2 for the radiographic SPA patients and 0.9 for the non-radiographic SPA patients. Same was the case with CRP. Initially, we can see that patients had high CRPs, but by week 24, the CRP levels had declined. And then this was sustained over the next 9.5 years. So to conclude, it was noted that during the 10 years follow-up, a total of 39 serious adverse events in 20 patients were observed, and 30 of these actually required hospitalization for diagnostic workups. But when you think of it, that it was a long-term study spanning 10 years, this is not a very high number. So among all these serious adverse events, only 7 were regarded as possibly or probably treatment-related, and 3 resulted in discontinuation, and only 3 resulted in discontinuation of etanercept. There were fortunately no cases of opportunistic infection, tuberculosis, or solid organ tumors. So in conclusion, etanercept showed long-term clinical response and also demonstrated consistent safety when administered in patients with axial SPA over a period of 10 years. And this was actually quite encouraging. And lastly, I would also like to share real-world data regarding NSAID sparing effect of etanercept in patients with Angst-Bond. This SPAR study was carried out in France, and I'll briefly share the results with you. In this trial, treatment with etanercept was associated with clinically relevant NSAID sparing effect of the drug, which coincided with significant improvement in conventional clinical outcomes. And this is also very important because we know that continued use of etanercept of NSAIDs can result in variable side effects. So the sooner the patients get off NSAIDs, the better it is for them, and they can do so only if the drug is effective. And here in the graph, we can see that there was quite a significant number of patients who actually attained an ASAS NSAID score of 0, which means that they were not taking NSAIDs at all. So in summary, we have learned that etanercept is very effective in reducing the disease activity in patients with SPA. Also, it is very safe to use. The incidence of adverse effects is not too high. And we have seen that over a period of time, patients tend to show good adherence to etanercept. And also, it has got an NSAID sparing effect, which is very, very beneficial for the patients. So I think we needed another breather, and this is from one of my favorite most lakes. This is Upper Kachura Lake in Skardu Valley, and it's a beautiful place to visit. Those of you who have not been here, I think must go in the summers and explore the area. It's a beautiful area. So this brings me to the last part of my presentation, where I'll be discussing a couple of patients from my own clinic. The first case is that of a 36-year-old male patient who had a long-standing history of left hip pain and backache. The history dated back 10 years. He hailed from Aptabad district and was primarily being treated by the GPs and Hakims there. He had severe limitation of activity when he first presented to us, and he was walking with the help of crutches. On evaluation, he was found to have advanced ankylosing spondylitis along with damaged left hip joint, and he was also found to have a vascular necrosis of the right hip. His disease activity was very high, with a PASTI score of 6.1 and ASTAS CRP score of 3.58. And since the disease had been present there for more than 10 years, we wanted to make sure that he still had active disease. So we went for an MR scan, and it showed that he still had active metasignals both at the SI joints and in the lumbar spine. So he was started on weekly etanercept dose of 50 milligrams subcutaneous injection, and he showed marked improvement at 3 months of treatment. Once his disease was stable, he also went for bilateral hip replacement surgery. Currently, he has a very well-controlled disease with a PASTI score of 1.4 and ASTAS CRP score of 0.9. And he's now taking etanercept every 2 weeks with occasional use of NSAIDs for pain relief. And I must mention here that this dose is per my clinical experience. For approved dosage, please refer to etanercept label. This is not the FDA-approved dosage of etanercept. And this gentleman is now quite happy and satisfied with his life and is working as a supervisor in a timber company. So the next case is of a 22-year-old male who was brought to our clinic by his father. Now, I remember very well when they arrived in our clinic, they were both crying. The boy was crying because he was in a lot of pain, and his father was crying because he thought that his son had become disabled for life now. So on probing, we found that he had complaints of left hip pain and inflammatory backache for the last 2 years. He went to local doctors and Hakims for treatment and was given painkillers and steroids. And he was also told to get a disability certificate because people thought that he wouldn't be able to get up and go to university again. And they thought that it would be better if he got a disability certificate so that he could qualify for some sort of help from the government. So on evaluation, he was found to have active sacroiliitis on MRI and a damaged left hip joint along with effusion in his left knee. He had high disease activity scores. ASTAS CRP score was 4.2 and PASTI score was 5.85. After preliminary workup and ruling out tuberculosis and hepatitis B infections, we started him on etanercept 50 milligrams sub-Q every week. Miraculously, he started showing improvement after third injection, and after 3 months of treatment, he had marked improvement in his disease activity scores and was able to without support. His PASTI at the end of 3 months was 3.85, and ASTAS had reduced to 1.27. What was more amazing was the fact that he was now walking without support, and he resumed his studies and completed it eventually, and he's now working as an accountant. His dosing interval, once he had achieved remission, his dosing interval was increased to 14 days, but this is again as per my own clinical experience, and this is not the FDA-approved dosage for dosage of etanercept for the management of ankylosing spondylitis. So he has been advised to have his surgery done for the avian of knee, of avian of hip as well, to help him with the discomfort that he's currently having, despite the disease being in remission. So we consider this a success story. Case number 3 is of a 23-year-old boy who was initially labeled as oligoarticular type of GIA since he developed the symptoms when he was 15 years of age. Now he hails from Mardan, and he was treated there by different orthopedic surgeons and also pediatrician. And he was started on methotrexate 10 milligrams per week with no use. Then he was started on sulfasalazine 1 gram a day, but again, he did not show any improvement. And along with these, he was also taking variable doses of steroids. So he presented to us with complaints of swelling and tenderness of left knee joint and right elbow joint. And he also gave a history of inflammatory backache, which was causing considerable limitation of his daily activities. He was found to have a positive Faber test bilaterally, and imaging confirmed presence of bilateral sacroiliitis. His inflammatory markers were skyrocketing with a CRP level of 90 and ESR of 140. Keeping in mind all of these features, he was diagnosed as having enthesitis-related JIA, which is the juvenile counterpart of ankylosing spondylitis. He was initiated on etanercept 50 milligrams once weekly after ruling out latent tuberculosis and chronic Hep B infections. He had a BASTI of 6.5 at baseline before he was started on etanercept, and ASTA CRP score of 4.8. However, both of these scores had reduced to 3.2 and 2.5 respectively after 2 months of treatment. So currently he has a BASTI score of 2.8 and ASTA CRP is 1.2, and this shows that he's now in remission. He's working as a software engineer somewhere in Mardan and is quite contented with his life. So with this, I say thank you to you. And I hope you found this interesting as well as useful. Thank you very much for your patience and patient listening.
Now, let us start with the end of session panel discussion. I would like to request Professor Dr. Fazle Haq Mahmood and Dr. Syed Ali Rukh Pirzada to commence this session. If there are any questions from the audience, we will be taking them right now.
Right. Thank you so much for all of you to come here and grace the occasion. All the lectures were splendid and have given us an enormous amount of information. Some of us has been illuminated by new ideas and new drugs which are available now in the world, and some of them are also available in Pakistan and are serving our patients very effectively. And we are using those drugs. Thank you, Dr. Ataur Rahman, for your presentation about the biologics and the JAK inhibitors. And what was very heartening to know is that, and it is for any teacher, many teachers are sitting here right now, that their students have become teachers themselves. And he's now become a supervisor and training a rheumatology student in Faisalabad. So alhamdulillah. Dr. Taqdees was, as usual, very precise and concise in her talk about etanercept and its role in rheumatoid arthritis as well as in juvenile idiopathic arthritis. Dr. Taqdees has very precisely illuminated that role of this drug in the very two diseases which we commonly see in our patients. Their side effects are very well discussed. We still are not very clear that when and how these drugs, the biologics, should be used in pregnancy. World is working on it. We are still hoping that the data will come and we will have a more clear picture to use these drugs in women who are in the childbearing age as well, since most of these diseases are prevalent in this kind of population. Now I request Dr. Ali Rukh to.
Hello, Assalamu alaikum. Thank you so much, sir, for inviting me to put some light on the discussions done. The first talk by Dr. Ataur Rahman is my friend, and he was my roommate as well. I have learned a lot from him as my teacher. along with Sir and Flaxa. His discussion on biologics available in Pakistan. There are so many biologics now available in Pakistan, and the message given by him and from me is we should start the biologics earlier when we are not getting the remission or low disease activity as early as possible, so that the disease process which is going on should not produce the deformities and the complications of the other diseases. The available biologics, as you know, is etanercept, interleukin-6 inhibitors, rituximab, and other as well. The newer drug is JAK inhibitors. This is very enormously being used by the rheumatologists and other doctors as well. It has got marvelous results as well. The second talk by Drs. Xenophon was on the guidelines. On axial SPA. He very well compared the guidelines on 2016 and with 2022. The message given by him is start with the NSAIDs, and if not working within 4 weeks, then switch to biologics. If there is peripheral arthritis, start with this sulfasalazine. If it is not working or not giving the results, then you should switch to biologics again. Or if the one biologic is not working, then switch to another biologic. And the last talk by Dr. Tikdis very briefly discussed about the role of the etanercept in axial SPA and her own experience with this drug and her modification of the etanercept dose, which we also practice in reducing the dose with increasing the intervals, and it's very effective. And the 10 years use of the etanercept in axial SPA in reducing the disease activity score. So all the three talks were very elaborate, and I congratulate all of them for giving us so much knowledge on this on these diseases. Thank you so much.
Assalamu alaikum. I have a question with Dr. Takdis regarding her talk. Is she online?
Yes, I am.
Yes.
I can hear you.
I'm Dr. Aflaq, Dr. Takdis. A very enlightening talk on etanercept, and I think so in biological agents, it's the mainstay of treatment in many rheumatological diseases. We are using it for a very long time. I would only like to ask your experience as well as your practicing in view of the current guidelines. We usually follow American, British, as well as European guidelines, as well as Asian guidelines. The duration which we give these biologicals regarding etanercept, for how long? You have commented very well on the safety profile, but how long do you prefer that regarding if the disease is well controlled only on etanercept? We multiple times reduce the dose, but it flares up. So what is your take on that specific duration of the etanercept injection? Thank you.
Thank you very much, Dr. Flat. It's a very good question. So, in my experience, or completely take off etanercept in any of the patients, other than a couple of maybe 4 or 5 patients, but most of them still require long-term treatment with etanercept, although in reduced doses.
Are there any other questions?
I am Professor Tariq Rashid of Dermatology. I want to ask the questions. What is your experience and how would you brief us about efficacy of etanercept versus secukinumab and versus tofacitinib in the management of psoriatic arthritis especially?
Thank you very much, Dr. Tariq. This is a good question. So I think as far as efficacy is concerned, all three drugs tend to do very well. However, there are certain scenarios where we prefer one drug over the another. So, for example, if we are treating somebody who is in her reproductive years and wants to contemplate pregnancy, then obviously TNF-alpha would be a better drug here because they can be continued throughout the pregnancy. Otherwise, if there's any, if a patient has a history of ischemic heart disease at a young age in family, or he has a history of thromboembolic phenomenon, or there is certain other contraindication, then we can avoid TNF-alpha, JAK inhibitors, and opt for either secukinumab or etanercept. Since they all have a very good result, I think no agent can be preferred over another. However, according to the scenarios, we can prefer one drug over another.
I'm Professor Mona Aziz Gilani. I'm clinical hematologist in Shaikh Zayed Hospital, Lahore. Madam, you talked about reactivation of hepatitis B in these patients where you are using this drug. We face a similar situation when we use rituximab and for B-cell lymphomas and CLL, and also ibrutinib, which is a TKI inhibitor. And there is a definitive, although small, risk of reactivation of hepatitis B. What is your strategy to prevent this? Can we, in fact, I want to know, can we really prevent it? Or I don't know whether I should ask a gastroenterologist, hepatologist, or I should ask you. Can you share your strategy? I mean, can you prevent it?
So thank you very much for your question. Yes. With all these biologic agents or immunosuppressant drugs, like even cyclophosphamide, mycophenolate, mofetil, etc., we always consider reactivation of hepatitis B. So what we do is we rule out hepatitis B and C first, and additionally, we also rule out hepatitis B, latent infection of hepatitis B. So we want to rule out presence of hepatitis B core antibody in these cases. The risk of reactivation is highest with rituximab and cyclophosphamide. So it is preferred that these two agents be not be used if avoided. However, if they have to be used, for example, in cases of ANCA-associated vasculitis, where these two are the treatment of choice, and patient also is found to have latent hepatitis B infection, then what we do is we concomitantly put them on treatment for hepatitis B, and after 2 weeks of starting treatment, or if the situation is dire, then we can concomitantly start rituximab or cyclophosphamide and give treatment for hepatitis B simultaneously. So this is the strategy with regards to rituximab. Data shows that the risk of reactivation of hepatitis B is not that much with TNF-alpha inhibitors. I was going through literature review and certain meta-analysis, etc., and they showed they were all performed in patients of psoriatic arthritis or patients with COVID-19 who were given different biologic agents or immunosuppressant drugs, and the data clearly showed that the risk of reactivation of hepatitis B infection with TNF-alpha inhibitors is very low. It is slightly higher for secukinumab, but still not. It doesn't fall in the high risk category like we say for rituximab or cyclophosphamide. So the best strategy is always to look for latent Hep B infection by going for hepatitis B core antibody. We all do the surface antigen. So additionally, we should be looking for core antibody. We should be looking for hepatitis B surface antibody positivity, and also if any of these are Hep B core antibodies positive, then we should also go for hepatitis B DNA PCR. And if the PCR is less than 2,000 international units per ml, then we can simply follow up the patients. And if it is more than 2,000 international units per ml, then it warrants proper treatment for hepatitis B infection. I hope it answers your question.
Thank you so much, Dr. Taqdees, for sharing your insight and joining us today at our conference. As we are short of time, we shall move on to our next segment. I would like to start with the beginning of the inauguration ceremony. I would like to call Dr. Aflaq Rashid, Head of Department of Rheumatology and Immunology, Shaikh Zayed Hospital, Lahore.
Assalamu alaikum, everyone. A warm welcome from Department of Rheumatology and Shaikh Zayed Hospital. We will start with our inaugural session. And before starting, I would like to request our guest of honors to come to the stage. I will call upon their names. First of all, I will call upon Professor Masood Sadiq Saab, who is the Vice Chancellor of the University of Child Health Sciences. Please, sir, come to the stage. Then Dr. Masood Ahmed, Professor of Pediatrics. Please, sir, come to the stage. Deputy Dean of Shaikh Zayed Hospital, Federal Postgraduate Medical Institute, Professor Mona Aziz. Madam, please come to the stage. And Professor Ejaz Hussain Sahab, Pro Vice Chancellor of King Edward Medical University. Sir, please come to the stage. Professor Izaz Mand Sahab, my great teacher and teachers of teachers. Sir, please come to the stage. And, Sir Professor Tafazul, sir, please come to the stage. And Dr. Tariq Rashid, please come to the stage. Professor Sardar Fakhr Imam Sahab, sir, please come to the stage. And Professor Tajammul Chaudhry Sahab, who is Professor of Forensic Medicine, sir, please also do come to the stage. And Dr. Fayaz Ranja Sahab, who has been an ex-head of Mayo Hospital, sir, please also do come to the stage. And Professor Farooq Kamal Sahab, Professor of Pathology, please, sir, come to the stage. Please come. And Professor Sumaira Farman, sorry, last but not least, madam, please come to the stage. He is Professor of Rheumatology at National Hospital and Medical Center. Madam, please come to the stage. Now over to Ariba, she is going to proceed.
I would like to call seats. Thank you so much, our guest of honors, for joining us here today. I would like to call on stage Dr. Aftab for the recitation of the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والتين والزيتون وطور سينين وهذا البلد الأمين لقد خلقنا الإنسان في أحسن تقويم ثم رددناه أسفل سافلين إلا الذين آمنوا وعملوا الصالحات فلهم أجر غير ممنون فما يكذبك بعد بالدين أليس الله بأحكم الحاكمين.
मैं पनाह मांगता हूँ अल्लाह की शैतान मरदूद से। शुरू करता हूँ अल्लाह के नाम से जो बड़ा मेहरबान निहायत रहम वाला है। कसम है इंजीर की और जैतून की और तूरे सीना की और इस अमन वाले शहर यानी मक्का की यकीनन हमने इंसान को बेहतरीन सूरत में पैदा किया, फिर उसे नीचों नीच कर दिया। लेकिन जो लोग ईमान लाए और फिर नेक अमल किए तो उनके लिए ऐसा अजर है जो कभी ख़त्म ना होगा। बस तुझे अब रोज़े जज़ा के झुटलाने पर कौन सी चीज़ आमादा करती है? क्या अल्लाह ताला सब हाकिमों का हाकिम नहीं है?
Jazakallah, sir. I would like to now request all our honorable guests to please rise in respect to the national anthem. Thank you. Please be seated. Proceeding forward. The Department of Rheumatology and Immunology was established in 1999 when pioneer rheumatologist Dr. Tafazlul Haq Mahmood joined Shaikh Zayed Hospital, Lahore. Since then, the journey was dynamic, resilient, and full of action. It all initiated with the allocation of beds in the medicine department and OPD. As time passed, patient burden increased, along with the restriction of human resource and space. In 2009, CPSP approved the specialty of rheumatology, and the department became first to gain recognition in public sector hospitals across provinces. In 2012, the department got recognized for MD rheumatology training by Punjab University. In 2018, after affiliation with University Health Sciences Lahore, the department gained recognition from PMDC as well. The department now has a full week of OPD to serve its patients. Trainees, along with the captains, sail continuously to provide state-of-the-art care to patients involving new biological treatments. In 2017, a dedicated unit was commissioned, having 13 beds, infusion center, and a procedure room. To date, 24 postgraduates from the department are the feathers in the department's cap. The dedication of the pioneer and the team has led to today's sunshine across the country. I would now like to request Professor Dr. Mona Aziz, Deputy Dean of Shaikh Zayed Medical Complex, to please say a few words.
Assalamu alaikum. I welcome you all on behalf of Department of Rheumatology and Immunology, Shaikh Zayed Federal PGMI Lahore, in this conference, and it is an honor to have you all here. Okay. Rheumatology is an important super specialty which has emerged in recent 2 decades. And in fact, our hospital and institute is the first where this department has become well established over last 12 or 13 years. And it has gained recognition in both CPSP and University of Health Sciences for major postgraduate studies. The credit goes to our professor, the Fazal, and also to Dr. Aflaq Rashid, who are working hard day and night for improvements in our rheumatology department, and also for awareness among other specialties for this super specialty. Now, few words about another super specialty of this, which is a branch of rheumatology, that is pediatric rheumatology, which is upcoming, and I think it's the time when we need to produce consultants and specialists in the field of pediatric rheumatology also. Because in coming years, because of the addition of gadgets, devices like cell phones and PlayStations, there is minimized outdoor activity for children, which is leading to joints, bones, and muscle problems. And also the indiscriminate use of immunization is leading to autoimmune disorders in the younger percentage of the population. So I think that the future is of rheumatology and also of in this field of pediatric rheumatology. Thank you.
Sir Fakhri Imam, please say some comments. The mic is with you. Or you prefer to come here, that is fine.
Assalamu alaikum, and as usual, I am grateful to the organizers and particularly to Professor Tafazal for having invited me onto this stage and this conference. It's always been wonderful to be here. And then many of us who have gray hair have really seen, and they have been a part of history, like for example, when all this started off in one of the small side rooms of Mayo Hospital of West Medical Ward, and then slowly and gradually, today we now see this specialty having grown up so much. Similarly, there's been another change, which is a very welcome change. And Professor Masood, you would realize that there were days when the physicians would say that pediatrics is mini medicine, so why have pediatrics? Why have a separate paper? Well, the two questions are good enough in final professional examination, and that is all. And then you and I are a part of that history also, where we have seen that not only that the field of pediatrics grew, but today those from adult medicine are actually holding a conference dedicating it to pediatric rheumatology. So that's another wonderful change that we have seen over the years. I wish them luck, and at the same time, there's another great personality whom we are missing on the stage. He has always been with us whenever we held anything which was related to education or so, and that is because he is not feeling very well these days, and that's Professor Mahmood Ali Malik. Whereas we not only miss him, I would request you all to pray for his well-being and for his health also. He's taught many of us, and we know that people who have taught one another, for all teachers, and particularly of senior teachers, that they hit at eternity. They or anyone else don't know where is it that their influence will stop working. So all of us, whether we are here on the stage, sitting there, people like Professor Salat and others, they're all great people. And though it might look out of tradition, but for those who are sitting here and for those who are not here for any reason, may I please request you to clap for them for a few seconds. And thank you very much for being with me. I'm grateful. Grateful once again, sir.
Sir Fiyaz Ranja sir, please.
बिस्मिल्लाहिर्रहमानिर्रहीम नहमदुहु व नुसल्ली व नुसल्लिमु अला रसूलिहिल करीम व नऊज़ु बिल्लाहि मिनश शैतानिर रजीम बिस्मिल्लाहिर्रहमानिर्रहीम। बड़ी अच्छी कॉन्फ्रेंस का इनेकाद किया है और माशाल्लाह एक ऐसे सब्जेक्ट को उजागर किया जा रहा है जिसके बारे में बहुत कम लोगों को इसके इम्पैक्ट का पता है। जब अल्लाह ताला ने मुझे अपने करम से डायरेक्टर जनरल हेल्थ पाकिस्तान बनाया तो 2-3-4 काम जो अच्छे मुझसे हुए उनमें से एक ये भी था कि मुझे बड़ी परेशानी होती थी कि बाकी जो बीमारियां हैं सारे सब्जेक्ट अपनी अपनी जगह पे अहम हैं। जैसे एजाज़मंद साहब के जो मरीज़ हैं उनका ज़्यादा से ज़्यादा रंग पुस्सा होगा, लेकिन चलते फिरते आम लोग उनके महसूस नहीं करेंगे। र्यूमेटोलॉजी एक ऐसी बीमारी है कि जिससे आपका चलते फिरते इंसान एक ऐसा भद्दा इंसान मालूम होता है कि परेशानी हो जाती है कि इसको क्या हुआ, अच्छे खासे हाथ थे यूँ हो गए, पाँव हो गए। तो इस लिहाज से जितने ये सारे लोग र्यूमेटोलॉजी में आए हैं और मैंने भी बतौर डीजी हेल्थ अपना इसको प्रायोरिटी नंबर 1 दिया और थैंक्स टू प्रोफेसर मसूद, उनका नाम भी था मसूद सादक से मुझे यहाँ भी प्यार है, लेकिन वो मसूद थे जो डो यूनिवर्सिटी के वीसी थे। तो सबसे पहले उन्होंने मेरी रिक्वेस्ट पर र्यूमेटोलॉजी डिपार्टमेंट को वहाँ बनी फ्लरिश कराया, अच्छा कराया, वो बड़ी यानी उन्होंने काम अच्छा कर दिया। अब भी मैं आपको सिर्फ इतना कहना चाहता हूँ कि आप एक ऐसा काम कर रहे हैं कि अर्ली डायग्नोसिस हो, प्रॉम्प्ट ट्रीटमेंट हो, तो जो डिफॉर्मिटी और ये एडजस्टेड लाइफ है सारी जाइंट्स की, उसमें आप इतना बड़ा रोल प्ले कर सकते हैं कि आपकी वजह से लोग हेल्दी नज़र आएँ। तो अगले चंद सालों में मैंने जो अभी 2-3 साल में देखा है कि कैल्शियम, विटामिन डी डेफिशिएंसी और ये जो ऑटो इम्यून डिजीज़ेज़ हैं इनकी अबंडेंस इतनी ज़्यादा है। और मैंने अपने तौर पर, अब तो मुझे अच्छा प्लेटफॉर्म मिल गया र्यूमेटोलॉजी सोसाइटी वाला, कि आप मैंने 2-3 लोगों को कह दिया है कि सर्वे करें। आप हैरान हो जाएंगे कि अगर ये र्यूमेटोलॉजिस्ट अपना काम इस तरीके से कर रहे हैं, करना जारी रखेंगे तो इंशाअल्लाह हम लूली लंगड़ी कौम को एक सेहतमंद कौम बनाने में कामयाब हो जाएंगे। तो इसलिए मेरे ख्याल में जितने हैं यहाँ 2-3 तो ये बैठे हैं और मुझे भी अल्लाह के करम से एक ऐसा मेरे पास ओहदा है कि हम इंशाअल्लाह इस र्यूमेटोलॉजी का जो आगे मैग्नीट्यूड है ना, मैग्नीट्यूड जो डिजीज़ का इंसिडेंस है वो इतना ज़्यादा है कि 2 किस्म के लोग आपको, एक तो एक्सीडेंटल जिनकी हड्डियाँ टूट जाती हैं, ये इंसिडेंटल डिफॉर्मिटी वाला काम है। इस डिफॉर्मिटी को रोकने के लिए र्यूमेटोलॉजी को नंबर 1 पे लाना पड़ेगा, वरना अगले चंद सालों में बहुत सारे लोग डिफॉर्म्ड लाइफ वाले होंगे। उनको रोकने के लिए आपका सारा मेहनत कोशिश जितने लोग कर रहे हैं वो काबिल तहसीन है और हम इंशाअल्लाह आपके साथ शाना बशाना काम करेंगे गवर्नमेंट के लेवल पे और सर्वे कराने में और WHO के लेवल पे इंशाअल्लाह हम अपना रोल प्ले करेंगे। बहुत मुबारक, बहुत शुक्रिया।
Well, that is one of also a goal that policy makers should also be aware and be present in our forums to understand and identify and can advocate us to the higher authorities. Thank you very much, sir. Professor Tariq Rashid, a professor of dermatology and essential co-opt of the rheumatology discipline, I would request Dr. Tariq Rashid to please say a few words about it.
Thank you very much, Professor Fazl Saab, Dr. Flagg Saab and the whole organization team for inviting me and arranging this great academic event. And it's always so rich with academics and learning that I always wish to attend this symposium, this seminar. And being a dermatologist, rheumatology is very much linked with dermatology because we often see patients with connective tissue diseases like SLEs, dermatomyositis and overlap diseases. So it is our keen interest to learn from you the various uses, the educate and judicious uses of biologics, JAK inhibitors and others in the management of such cases. And definitely it always helped us to improve our skills basically in the management of the diseases. And now, as I was discussing, as Professor Fakhar Imam Sahab has said, it's exciting that pediatric rheumatology is going to establish now. And this is great, I think, because we see patients with pediatric psoriasis, adolescents and children with psoriasis and suffering from arthritis. And then we need more expertise, more knowledge for management of such diseases. Wishing you best of luck. Thank you very much.
Your comments are mutual to our rheumatology as well as pathology is a very important subject related to our rheumatology, as multiple biopsies and things associated with it are very much closely related. So I would request Professor Farooq Kamal to please have few words in our session.
Assalamu alaikum. Thank you very much for to the organizers for inviting me over here. My comment is that I'm a basically histopathologist, and I wish with the development of this rheumatology, the burden of joints to histopathologists should decrease because of this targeted therapy and biologics. A few years back, we used to get biopsies of the tissues who at the level where nothing can be done except the replacements. Another comment over depending upon or based upon my practice over the years, that we should always keep in mind in our country tuberculosis as one of the very common cause of joint problems in our population. I thank again to the organizers and congratulate them with such activities. The subject of rheumatology is highlighted and its importance is known to the people. Thank you very much.
Thank you, sir. Thank you very much, sir. I would request Professor Sumaira Farman, who is a role model for all of us in the field of rheumatology, to say a few inaugural words.
Assalamu alaikum. Thank you so much. मुझे एक चीज़ जो शायद सिर्फ प्रोफेसर तफज़ुल और आप जानते हैं कि शेख ज़ैद एक तरह से मेरा मैका है, क्योंकि मैंने अपनी मेडिसिन शेख ज़ैद से शुरू की थी और दिस इज़ व्हेन शेख ज़ैद खुला था बिल्कुल शुरू में. तो मेरी बहुत खुशकिस्मती है. उस वक़्त प्रोफेसर मोयुद्दीन होते थे हेड ऑफ़ द इंस्टीट्यूट, ही वाज द डीन आल्सो. और मैंने ऐसे ऐसे लोगों के साथ 1-to-1, क्योंकि वहाँ एक कंसल्टेंट और 2 रेजिडेंट्स होते थे. सो मेडिसिन में प्रोफेसर ज़फ़र इकबाल, प्रोफेसर शफाक कार्डियोलॉजी, प्रोफेसर ताहिर शफ़ी नेफ्रोलॉजी, प्रोफेसर अनवार खान गैस्ट्रोएंट्रोलॉजी, और ये सब नए अभी भी आए थे. हम भी छोटे थे, वो भी जवान थे, यू नो. सो इट वाज़ अ वंडरफुल टाइम और मेरा वो वक्त कभी भी मैं भूल नहीं सकती, 2-2.5 साल जो थे. So Shaikh Zayed is very, very close to my heart, and any activity that is affiliated with your institution has to be close as well. और बहुत मुबारक and good luck and best wishes to Children's Hospital for, you know, planning to start a training program in pediatric rheumatology. आप सबको पता है कि that is a thing that's very, very close to my heart. और किसी तरीके से भी अगर if I can support and facilitate, I'm here. And thank you for inviting me, and Professor Tafazzul and you and the organizers. Thank you. Good luck with the meeting.
Thank you very much, madam. And I would request Professor Tahir Masood Sahab, who is Professor of Pediatrics, to please say a few words.
Bismillahir Rahmanir Rahim. First of all, I feel deeply honored, and it's a great pleasure for me to be invited on this esteemed forum by the Department of Rheumatology, Shaikh Zayed, and the Pakistan Society of Rheumatology. I think these activities of continued professional development go a long way in furthering the knowledge in medicine. Medicine, as we all are aware, that it's a dynamic and ever-changing field. Medicine which we practice today is not the same which was practiced by our forefathers, by our predecessors, and shall not be the same which will be practiced by the future generations. because of the fact that there are so many innovations we have seen in our own life that the treatment modalities which we are having today, they are altogether different from those of in the past. It's very heartening to see that the rheumatology has grown and rheumatology has been established as a separate specialty over the past 2.5 decades. It's not easy to develop these subspecialties when the response from your colleagues is not encouraging. It's always difficult, जैसे है ना इकबाल ने कहा था कि आईने नौ से डरना तर्ज़े कौन प्यारना मंजिल यही कठिन है कौमों की ज़िंदगी में. So this problem or this ordeal we have faced when we were developing pediatrics as a subspecialty or pediatrics as a specialty as recognized at the undergraduate level. There was so much opposition from our own colleagues, and and now you are seeing that how the children's hospital over the country has emerged. And there are pediatric subspecialties which are working, which are coming at the international level. So I think it's a great progress. And regarding the pediatrics pediatrics obviously is altogether a different specialty. Children are not mini adults. Gone are the concepts when this was believed that just reducing the dose would suffice and we can treat children. Now each and every field of pediatrics, starting from neonatology to infancy to children or adolescent, these are altogether different. I would specifically thank the rheumatology colleagues, especially Dr. Tafazzal, Dr. Sumaira Farman Raja, and Professor Nigat Mir for developing this specialty in pediatrics. In pediatric rheumatology owes a lot to especially Dr. Sumaira Farman Raja and Dr. Tafazzal Haq, and I feel greatly intended to them, and we owe a lot to our adult rheumatology counterparts. Thank you very much.
Thank you very much, sir. And I think so the words of introduction become dwarf in front of Professor Azaz Mansab. He's such an icon of nephrology, and rheumatology and nephrology are like chuli daman ka saath. Sir, please.
Thank you, Aflaq. I am humbled by your gracious comments. Thank you, and I thank Professor Tafazzal for inviting me to this meeting today, and I wish you all the best for this conference, and we hope that this rheumatology grows. We have a lot of common patients with the rheumatology, may it be vasculitis, may it be lupus, or is it non-steroidal anti-inflammatory drug use by the patients for long that causes renal injury, and patients with rheumatoid, patients who end up with rheumatoid arthritis and then eventually develop amyloidosis, and the use of biologics and use of cyclosporin and other CNIs in rheumatology. I think these are some of the areas that are common in nephrology and rheumatology. So we keep seeing these patients and we keep growing, and it is very healthy that we look at other specialities. For example, if we have a patient with vasculitis and comes with a pulmonary hemorrhage, we need to consult a pulmonologist, we need to look at a rheumatologist, we need to look at a nephrologist, and maybe other specialties also, like a stroke can develop and things like that. So all these specialties are now developing and growing, and thanks to all those people who are the stalwarts in developing these specialities. And this was not an easy task because of the personal sufferings that people had to go through while developing these specialities. It was an arduous task because you get, as Professor Tahir Masood has said, that you get resistance from other areas. Instead of getting support, you get resistance at times to develop your specialty. For example, this rheumatology was purely a baby of the orthopedic surgeons. But then when rheumatology developed, then some resistance could be there. Same with the case in nephrology and urology. So people who have stood up and worked hard against different odds to develop these specialties, they deserve a special appreciation for developing these. And I'm very glad to know that Professor Masood Sadiq, who is himself, struggled quite a lot in developing pediatric cardiology in this part of the country. He has now been able to develop the pediatric rheumatology group. So I think that will ameliorate the sufferings of the children with the polyarthropathies. So with these comments, I would like to congratulate you and thank you for honoring me for this occasion.
Thank you so much, sir. Professor Masood Sadiq will be having a presentation at the end of the session. Professor Ijaz Hussain, Professor of Dermatology as well as Pro-Vice Chancellor.
Bismillahirrahmanirrahim. Thank you very much, Professor Raflaq Rashid Saab. I must congratulate Professor Tafazliya Mahmood and Professor Raflaq Rashid Saab for holding this very successful, very well-attended conference. We witnessed the journey of dermatology, starting from the scratch, and now it is well-grown specialty, feeding rheumatologists, at least I think whole of the Punjab, Shaikh Zayed Hospital, and we hope so. The lesson from the history is, inshallah, pediatric rheumatology will also develop a specialty, and Children's Hospital under the supervision of Professor Masood Sadiq will be a nucleus, and it will provide pediatric rheumatologists to the whole of the Punjab, rather whole of the country, inshallah. Thank you very much, sir.
Professor Tajammul, Professor of Forensic Medicine.
Thank you so much, sir. I'm truly honored and humbled to be part of this great conference. Teachers, amazing colleague, amazing friend in the form of Professor Tafazul. So, thank you so very much, sir. You and your team has done wonders. And a message to the juniors is that in Punjabi they say, "Jinne puchya nahi, unne sikhya nahi." So these are the people sitting on the stage in front of you. They are the legends. They are the institutions. So my request to the juniors would be that please get hold of them. जहाँ आपको नजर आए, corridor हो, ward हो, hospital हो, इनके मुंह से एक लफ्ज़ निकला हुआ एक सुनहरी लफ्ज़ है. And wishing you all the best of this conference, today, tomorrow, and always. And I'm truly honored and humbled. Thank you, Professor Tafazul and your team. Thank you.
Now I would request Professor Masood Sadiq Sahab to, sir, please come to the stage and introduce pediatric rheumatology.
Thank you. Bismillah ar-Rahman ar-Rahim. First of all, let me thank Professor Tafazul and Dr. Ikhlaq Rashid for giving this honor to pediatric rheumatology as the focus of this particular Congress, Rheumacon, today. I think I'm extremely grateful to them. Let me say that pediatrics in its own right is a universe of its own. It's like adult medicine, there is pediatric medicine, and you have adult disciplines and we have pediatric disciplines. We live in a country where 48.7% of total population is 18 or younger. And we have the third largest pediatric population in the world. We are fifth largest country in terms of population, but when it comes to children, we are the third largest in the world as third largest pediatric population. So I think the context of pediatric rheumatology relates to that fact as well. And we are extremely grateful to Shaikh Zayed Hospital in that context, because our journey actually was very much initiated and started by Professor Tafazul, because he trained our first pediatrician in the field of rheumatology. So I would request everybody to give a big hand to Professor Tafazul for his tremendous contribution in that context. I think we know that pediatric rheumatology is a specialty for last 7 decades, and globally there are over 6 to 7 million children who are affected by rheumatic diseases. If we look at the Western data, we have over 350 practicing pediatric rheumatologists in USA, more than a dozen pediatric rheumatology centers in UK, 16 centers already across the border in India, and look at even Africa, where there are 10 pediatric centers across 54 countries of Africa. But we here in Pakistan, I think the only pediatric unit at the moment which has a pediatric rheumatology setup is at Children's Hospital, Lahore. We all know that it's a very diverse field, and you need close cooperation between various disciplines. So I think there cannot be another place better than Children's Hospital to have such a specialty, because you would need input from cardiologists, nephrologists, neurologists. The other one is not here. Professor Sajid Bakul and Professor Tahir Hussain, who is our guest of honor today. These are the two people who started pediatric rheumatology clinic at Children's Hospital way back in early 2000. And then our journey started. We had our first pediatric rheumatology seminar, then training of Dr. Samia Naz, who is sitting here, and I will request her to stand up because she's the first pediatric rheumatologist in the province. She was trained by Professor Tafazzul way back 2014, 2015, and then of course the journey went forward. We had our first international liaison with the Hospital for Sick Children, Great Ormond Street, and had a rheumatology conference only last week. Just to give you an idea, we are seeing a large number of patients in our Children's Hospital already. If we look at the last 2 years' data, you can see juvenile idiopathic arthritis, SLE, juvenile dermatomyositis, systemic sclerosis, vasculitis, and many other diseases which we see at our institute. Our pediatric rheumatology clinic sees 50 to 70 patients in their OPD. Over 2,600 OPD visits last year only. We have an independent lupus clinic, a juvenile idiopathic arthritis clinic, and you can see the number of children who actually need admissions, and they regularly hold MDT meetings as well. So lastly, I think what is the future of pediatric rheumatology? I think two fundamental things need to be understood. One, we need to have an outreach program. One center cannot cater for the rheumatological needs of this province or this country. And of course, we need to have a fellowship in pediatric rheumatology. We need to detect these patients early. Of course, assistance in maintaining continuous care, initial management by both pediatricians and adult rheumatologists, a close liaison, a timely referral, provision of information and counseling to these patients, and of course, to monitor disease activity and promotion facilitation of telehealth assistance. I think it's extremely important to understand that we need to develop this close network between pediatricians, rheumatologists, and then pediatric rheumatology at Children's Hospital to move forward in this regard. That's how we were able to convince the government to have the first University of Child Health Sciences on the globe. We are 1,300 bedded, one of the largest, rather second largest children's hospital on the globe. We have 26 clinical and 13 diagnostic disciplines, and this is going to be the 39th discipline at Children's Hospital, which pertains to pediatrics only. So with the help of adult rheumatology colleagues and of course pediatricians, we are going to start our fellowship program. It's going to be a 2 years pediatric fellowship program after FCPS, which will have a, depending which route you have come, if you have come from adult route, there will be a different training program, and if you have come from a pediatric route, there will be a different program. And of course, let me finish by saying that progress lies not in enhancing what is, but advancing what will be. That's what we believe in terms of pediatric rheumatology and all pediatric disciplines. Let me conclude by once again thanking the team at Shaikh Zayed Hospital for being the patron of our group at Children's Hospital Lahore, and we look forward to their continuous support, not only from Shaikh Zayed, but I think from the entire rheumatology team across the country. Thank you very much.
Thank you so much, honorable guests. Now I would like to call Professor Dr. Tafazul Haq Mahmood and Dr. Akhlaq Rashid to please come and present souvenirs to our guest of honors.
Before we present the shields to our guests and respectable colleagues for their presence here as a token of appreciation, I would like to also thank them for coming here and saying so many kind words for the department as well as for myself, for which I'm really humbled. Yes, as Professor Azazman, Professor Masood Sadiq and all others have said, that it is not going to be an easy task. It is going to be a difficult task to develop pediatric rheumatology, because it's not just the rheumatologist that you are requiring. It is also the specialists associated with the field of rheumatology that you are going to require, who should be familiar with the subject. Either they are pediatric nephrologists, either they are pediatric gastroenterologist, or whatever field they are in. They need to be on board before you start developing and progressing the field of pediatric rheumatology, because without any multidisciplinary approach, it's not possible to treat and manage these patients amicably. So with this, I thank you all.
Okay, so proceeding forward, I would like to request that without our allied health department, we would have been nowhere. I would like to call Madam Talat Aslam, matron of Shaikh Zayed's nursing, to please come on stage. I would like to call our guest of honor, Professor Dr. Mona Aziz, Deputy Dean, Shaikh Zayed Hospital. Professor Dr. Tajammul Chaudhry. Professor Dr. Azazmand. Professor Dr. Sardar Fakhr Imam. Professor Dr. Farooq Kamal. Professor Dr. Sumaira Farman Raja. Professor Dr. Tahir Masood. Professor Dr. Tariq Rashid. Professor Dr. Ijaz Hussain. Professor Dr. Masood Sadiq.
Dr. Fiaz Ranja. Dr. Fiaz Ranja.
Yes. Professor Dr. Fiaz Ranja.
कोई भी शील्ड दे दो, शील्ड दे दो। फरमान राजा मैडम सुमारा फरमान को दे उनको दे बस मैडम निगत मीर का देते हैं मैडम निगत मीर डॉक्टर सुमारा को काइंड ऑफ आई विल रिक्वेस्ट डॉक्टर सुमारा
I think talking about rheumatology and not talking about Professor Nigat Mir is inevitable. She is not here with us, but in recognition of her untiring efforts for promotion of excellence in the field of rheumatology, Rheumacon would like to give a small token of appreciation as in the form of Lifetime Achievement Award to her. And I request Professor Sumaira Farman Raja to receive this on her behalf. Thank you so much.
Conclude the session and these 15 minutes and after 15 minutes we will come back.
I would like to now conclude the inauguration ceremony. I would like to thank all our guests of honors. Thank you so much. Now we would proceed for a brief tea break, and then we will restart the session with our second scientific session in 10 to 15 minutes.
12:30.
At 12:30 to be exact. Ladies and, ladies and gentlemen, we will be starting our second scientific session in 2 minutes. Thank you. I would like to request our respected guests to please settle down. We are about to begin our second scientific session. To commence the second scientific session, the next talk is an insightful discussion on the therapeutic potential of tocilizumab in the treatment of juvenile idiopathic arthritis, JIA. JIA is a chronic autoimmune condition affecting children and poses significant challenges to both patients and clinicians. However, amidst these challenges, there shines a beacon of hope in the form of tocilizumab, a monoclonal antibody with the potential to revolutionize the landscape of JIA treatment. Today, we are honored to host a distinguished expert who will guide us through the clinical insights and the promising future that tocilizumab has to offer in the treatment of JIA. Professor Dr. Sumaira Farman Raja is a certified pediatric rheumatologist from Australia, and she is the head of Department of Rheumatology in National Hospital and Medical Center, Lahore. I would like to invite Dr. Sumaira to please come on stage and present her talk.
अस्सलाम वालेकुम जी। सबसे पहले तो बहुत शुक्रिया डॉक्टर खदीजा का, उन्होंने अपना टाइम मुझे स्लॉट दिया है और अपेरेंटली हम दोनों ने वहीं जाना है, सो इट्स अ रियल सैक्रिफाइस. I want to thank Dr. Flak, Professor Tafazzul, the whole organizing committee for inviting me to give this talk. So when we look at the cytokines that are involved in JIA, we can see that IL-6 is raised and it has receptors not just in the synovium but in the uvea as well, which explains why it has a role in uveitis in JIA. So this is a humanized monoclonal antibody, and the indications are in systemic, polyarticular, as well as in refractory to treatment uveitis, which is chronic anterior uveitis. This is off-label. The first two are actually approved. It's very important for you to just understand this concept that JIA is not one single disease. It's a diverse immune-mediated composite disorders that begin before the age of 16 years. They have a common feature, which is arthritis. Although arthritis may not initially be seen in systemic, but other than that, a common feature arthritis that persists for more than 6 weeks, and there is no known cause known, which means that in any patient with polyarthritis, which has had every acute reasons ruled out, including infections, etc., which has been lasting 6 weeks, and is negative for other autoimmune conditions, negative for infections, negative for malignancy, that is JIA. And it's the pattern over 6 months which determines the subtype, and it is the most common cause of chronic arthritis in children. Just very briefly, this is the ILR classification in which systemic and polyarticular are associated with the most morbidity, and mostly that is what we are going to talk about. So systemic onset accounts for up to 20% of JIA. It is the most serious form, and a mortality rate is up to 4% or even more in some series. And 1/2 to 2/3 will persist as chronic arthritis, with approximately half having significant disability. Please remember that this is a clinical diagnosis of exclusion again. So just like JIA, you need to exclude other autoimmune things, infections, etc. Over here, even more, you need to rule out other causes of fever. So infections, malignancy, like leukemias, lymphomas, Kawasaki disease, and then the autoimmune diseases like SLE. And the patients, before you decide, are diagnosed with systemic onset, should have pan cultures, all imagings done, wherever indicated bone marrow and lymph node biopsy. And in case of a patient presenting with macrophage activation, you may consider genetic testing as well. The S100 proteins can also help distinguish systemic onset from other febrile illnesses, but we do not have this available here. As I said, it has a variable course. It may be monophasic, polycyclic, or persistent. And it is the persistent course actually which has the greatest destructive arthritis, even when systemic manifestations have settled. So, joint damage in systemic onset GI can be as destructive as that seen in adult rheumatoid, and damage can occur within 2 years of disease onset. Up to 30% of patients will develop erosions as well as involvement of the TMJ joint. Most commonly involved small joints, but also the hip. And we have seen that systemic disease, so if you have ongoing fever which is not controlled, there will be ongoing radiographic progression. Therefore, it's extremely important to control this. And so you have systemic onset GI with systemic manifestations which are impacting which have systemic implications like growth retardation. Especially it has been seen that IGF-1 is decreased in patients with GIA, and also a decrease in bone mass which leads to an increased risk for fractures, osteoporosis. Mostly, it is most seen in systemic onset as compared to other GIA. Again, most mortality is seen with this subset, and it is mostly due to disease complications like infection, mass, myocarditis, and amyloidosis, which is rare. Amyloid is rare, and I'm only going to talk about macrophage activation here. So this is a young boy with a high spiking fever. I just want to emphasize that if you see this pattern, this is a quotidian pattern, which means that you have a spike during the day and it comes back to normal, and otherwise the patient is well. And he also had pericardial effusion and adenopathy. Then he develops fever which has become continuous for the last few days. And if you see here, his ESR is 40, his white cell count and platelets are actually normal. And the infectious diffuse and band cultures were negative. But this normal count is actually, this patient was developing mass because the baselines were very, very high. So his ESR was 100, his white cell, he had leukocytosis and a thrombocytosis. In a patient with systemic onset, even if you have normal figures, please watch out for mass. They should have a ferritin done, ferritin done as soon as possible, in addition to other things like TGs, etc. So what happens in mass is that you have a liver dysfunction and coagulopathy with DIC hypotension. You have a bone marrow may show active phagocytosis, but you cannot and you do not rely on a bone marrow for diagnosis. One, you can't always get it done in a sick child, and two, you may miss it. And three, sometimes you can have macrophages seen in bone marrow in a patient who's not showing overt mass, so it's not 100% correlation. This child responded partially to solumedrol and cyclosporin. Unfortunately, anakinra we have given and it's done very well. It's not available these days, and he did respond to tocilizumab. This is a classification criteria, which is a new classification criteria. It's important again to see the platelets on the left, less than 180, TGs are high, fibrinogen is low. So again, anybody who has a dip in 2 cell lines and in systemic onset GI, if they have normal lab parameters also, please make sure that you don't miss macrophage activation. So this is, classification in GIA, like most other diseases, is basically for research purposes. And more, we now think that even ILR needs to be superseded by other more phenotypically focused classification of the types of GIA. And so Printo has proposed this, in which only thing that you need to remember is that there is a phenotypic difference, that all polyarthritis GIA, which is ANA negative, is actually poly-GI. Even if it starts as oligo, as long as it is ANA negative, there's no psoriasis, so all other polyarticular GI will be poly-GI, and that is the place where you can use actually anti-IL-6 inhibitors. In poly-GI also we see there's a difference in the growth, and again impaired growth velocity is reported, although not as much as it is seen in systemic onset. And we know that IL-6 levels have an inverse association between growth velocity. All suggested treatment pathways for JIA, and you can find them from the ACR to the latest, which was NHS England Clinical Policy Statement, they all basically work around with the same drugs. You have synthetic DMARDs, and methotrexate is the core drug that should be started in all children with polyarticular JIA, and in systemic JIA with polyarthritis as well. And then you have IL-6 inhibitors, which are tocilizumab, which are used for both systemic as well as polyarthritis. So we now know that more and more JIA treatment is moving towards the treat-to-target approach, because it's been seen that the window for inducing clinical remission is greatest with early treatment within months of onset of disease. So we've had two very good trials that were presented, which is treat-to-target in JIA, early aggressive therapy as well as aggressive combination drug therapy, which used a combo of synthetic DMARDs with biologics. In these two cases, these were anti-TNFs. And it was seen that you achieved better ACR responses with the addition of the anti-TNF and early initiation of treatment. So what we want is, we want our patients to be in disease remission off of medication with acceptable disease control to prevent long-term damage and obviously improve the quality of life. Why is it important for us in Pakistan? We know that we've had revolution of biologic DMARDs globally, but some of them, and many of them, in fact, I should say, are available in Pakistan as well. And so initiating early intensive therapy and a treat-to-target approach is possible in our setting as well. When we look at and apply the numbers, we know that we do not actually have prevalence rates in Pakistan, and they vary globally. However, if we just apply those global rates to our population and our young population, the prevalence is anything between 200,000 to 20,000. So 20 lakh children might be out there suffering from juvenile idiopathic arthritis. And so this is a young population that is being set up for disability if they are not diagnosed and treated in time. And we also know that the risk factors for worse outcomes are always delay to diagnosis, poor access, and inadequate specialist services. And also children living in countries like ours with worse socioeconomic status. We do not have guidelines available as well. So there is a concerted effort within the Asia-Pacific region. We are working on guidelines for low resource income countries within the APLA region, and hopefully we will have something by the end of this year, inshallah. And we also know that patients living in countries with lower GDP like ours had greater disease activity, greater damage, and as you can see, more systemic and polyarticular disease is seen in these low resource income countries. So this is like a high stack against the prospects for children unless we all make an effort. And you know, it's not just systemic onset which is a problem, but without treatment, this polyarticular child came as a young woman who was not diagnosed with GI in time. She was treated with benzyl penicillin. She was put on anti-tuberculous therapy. And by now, you know, she had such bad deformities, I can't even show you the rest of the photographs. And on the right side, another girl came within 6 months. She was on treatment. And as you can see, she's doing so well. So it is extremely important to understand that there are things worse in life than dying, and that is living with disability. And I think it falls to all of us to try and, you know, sort of like work on improving health resources, on improving the expertise of health resources and health professionals and health personnel that are actually seeing these children. And so I commend the effort by University of Clinical Health Sciences as well as that of, the faculty of Shaikh Zayed Hospital. And they have our support for basically working on the pediatric rheumatology training program. So these are the current approved pediatric indications for the biologics, and I just want to focus on this. So when you look at tocilizumab, that is the one biologic that is FDA approved for systemic onset JIA, and polyarticular JIA, which I've now told you encompasses a bigger group than the one that was initially, or that is initially given in the ILR classification. So we know that IL-6 levels are elevated. We know that they are correlate with CRP and fever. We also know that they are elevated in patients with poly-JIA, and they correlate with joint damage and markers of inflammation in poly-JIA. And that is the rationale behind why anti-IL-6 inhibitors are so effective in both these sub-classifications. And then those trials that were done, both for looking for efficacy, as well as, efficacy in terms of improvement of swollen and tender joint count and the ability to wean off corticosteroids. It reached, these trials reached their endpoints, but however, you must remember the risk of infection, neutropenia, and abnormalities in liver functions. So you have to make sure that, these patients are screened before and during the infusions. Again, this was extended to 5-year data, and it seemed that the same safety and efficacy results were seen over the 5-year period. Also seen that anti-IL-6 actually helps children to catch up in their growth phase, which is a fantastic thing. And both in systemic onset JIA as well as in poly-JIA. And then, from intravenous tocilizumab to subcutaneous, both were studied, and the efficacy and safety was comparable. And since subcutaneous is much more easier for children, and so the compliance is also better. Again, safety and efficacy, same thing in polyarticular is also being seen. So to conclude, when we look at what is important is the rates of infection. So we see that the rates of infection were similar for the 2-year period, for the 5-year period, and particularly the risk factor for neutropenia is more when the younger the child and if you're using methotrexate, especially in polyarticular. However, neutropenia was not, the degree of neutropenia was not consistent with the same degree of risk of infection. And the reason for that is that IL-6 actually works on the liver receptors as well. And so you know that leukocytes are also acute phase reactants and neutrophils also. So sometimes because of anti-IL-6 activity, you may have a drop in neutrophils, but not an increased risk of infection somehow. So this was shown, and but of course you need to keep your absolute neutrophil count above 1500 at all times. Again, growth improved with poly-JIA as well. I just want to mention that tocilizumab has been used in chronic anterior uveitis. Chronic anterior uveitis is that uveitis which is seen in the ANA positive subgroup of children, younger age onset. Whether the extent to having more than 4 joints later is not the thing. It is young age of onset, ANA positivity, and primarily initially oligoarticular. And because they are young, they are asymptomatic and they cannot actually perceive that there is a problem with their vision. It's extremely important to screen these children with JIA, all children with JIA, but particularly this subset with the ANA positive. And in patients who do not respond to therapy, like methotrexate has been used, and of course adalimumab works very well, infliximab works very well. But for refractory uveitis, tocilizumab is indicated. We have used it and it has shown good results. So one word of caution, please remember you're increasing the risk of infections with an anti-IL-6 inhibition, including zoster, tuberculosis, fungal. You can have bone marrow and liver toxicity, which is seen more in anti-IL-6 as compared to anti-TNF. You need to monitor their lipid profile. There may be an increased risk of cancer, but it's not been, there's not enough data. And of course, we know that if you have diverticular disease or there's a risk of diverticular bleeding, and so you need to watch out for that. And there may be a risk of some neurological risk of demyelination. Again, we don't have enough data. Please remember to vaccinate your patients. and live vaccines have to be given before the start of therapy. You must do yearly flu and pneumonia 5 yearly. Inactivated shingles is not available here in Pakistan. It is available abroad, and wherever possible, patients should be vaccinated with that. So the doses are IV, they are available, you can see, and subcutaneous as well. So I just think that, it's very important for us to remember, for each one of us, we have to keep trying our best with our patients, and as much as we can learn, probably look again, and if we are stalled, we must ask other colleagues. Don't forget, for all the trainees, safety comes first. So there is no magic bullet. There's always collateral damage unless you're very, very careful. So the best of therapeutic agents are nothing if you do not use them carefully and intelligently. We have want to share the Arthritis Care Foundation funded children with you. I'm proud to be part of this foundation, where we are trying to help all children and adults who cannot afford expensive treatment or drugs. And some of the activities that I'm here with some of my team, as well as the colleagues in PSR. And we just initially inaugurated last year. Dr. Laura Landowski was visiting from NIH. She's the clinical head of lupus genomics in children at NIH, and we started clinics for children, adolescents, and young children at National Hospital with an inpatient facility. And of course, we are nothing alone. So I want to just give a shout out to my very respected colleagues who are sitting here and invited me, Professor Tafazzul, Dr. Flak. Nikat couldn't make it, so apologies from her. And some of the resource links which are available, these are free resource links, please go visit them. And thank you for your attention.
Thank you so much, ma'am. Our next talk is an lightning discussion on a topic that affects millions worldwide, osteoporosis. As we gather here in 2024, the landscape of understanding and managing this condition has evolved significantly. We are here to separate fact from fiction. In order to have osteoporosis fact check, I would like to invite Professor Dr. Khatija Irfan Khwaja. She is a consultant endocrinologist and expert in her field. She is Head Institute of Endocrinology and Metabolic Diseases in Services Institute of Medical Sciences, Lahore. Please, ma'am, come on the stage and present your talk.
Assalamu alaikum, and thank you. Let me put my timer on so that I don't overshoot the time, right? Right. So my talk is titled Osteoporosis Fact Check, because although it is one of the commonest, perhaps the commonest diseases in the world, we are all very confused about it. And again, the reason why it is such a confusing topic is because nobody really knows who is the person who is supposed to be looking after this disease. Is it an endocrinologist domain? Is it a rheumatologist domain? Is it an orthopedic surgeon's domain? Or is it a geriatrician's domain? And the answer is, in fact, everyone, and also the primary care physicians and the specialists in internal medicine, the physical therapists, occupational therapists. It is a problem which affects all of us, and it affects us also in a very personal context, because like it or not, we are all one day going to have to face this. So let's begin. I do not have any disclosures, and briefly I am going to be talking about, first of all, the challenge we face, and the challenge of osteoporosis, which is perhaps the most unrecognized and undiagnosed disease in the world. And then I'm going to be focusing my talk intensely on matters which confuse us, what I like to call the enigmas, because these, however much we read about this, these are things which continue to confuse the resident fellows and also many of us, be whatever stage in life we are at. So, first of all, I'd like to share this patient of mine. She was a very elderly lady, and in her time she had been a very active person, a social worker. But unfortunately, at this stage of life, and she's 82 years old, she's living alone. She's taken care of by some carers in her home and some home nursing facilities. She has dementia, she has limited mobility, diet as in elderly people is very insufficient. And so one day, and he has, because of dementia, she's on some medication for that. And one day, her carers notice that this is how her hand is, and they contact me. The question here is that, is this story just beginning here? Or is it the ending? Or is it the beginning of the end? Because this is something which is the sentinel event, which basically begins the downward decline. 1 in 20 Pakistanis is living abroad. That is 10 million, 1 crore Pakistanis are outside. And what is happening here is that their parents are left here alone, and they are living here alone. They are alone, they are becoming frail, and their vision is falling. And this is the problem we have. I call it the parent problem, but nobody actually thinks about it when they go abroad. It's a global problem. The world is aging. And Asia, which was typically the youngest of the somebody just said in the pediatric rheumatology presentation that we have the largest pediatric population in the world. But we are also projected, the number of people over the age of 60 is expected to triple in this part of the world in the next few decades. So we too are going to be facing the aging population, but unfortunately we do not have the mindset, the resources, and the preparedness to look after this aging population. So osteoporosis, what is it? Stated simply, it means porous bones. And the bones which become porous are the precursors to a lot of problems. And it's a huge problem. It's a silent disease, but it affects nearly 250 million people in the world. It's a very large percentage of the population. It's a silent disease. Nobody knows you have it until this happens, a fragility fracture, which is defined as a fracture when if I just fall while I'm standing here, I have a fracture. That's a fragility fracture, because I shouldn't fracture my bone if I just fall from this height. But if I do, that means that my bones have no longer the strength which they had at one time. And a fragility fracture is often the first thing. As I said, it is the beginning of the end. A fragility fracture leads to very drastic consequences. Fully 1/2 of people who have a fragility fracture of the hip become immobilized, become dependent. They lose their ability to move around. And 1 in 3 people with a fragility fracture of the hip, especially if they're a woman, may not last a year. So it is the beginning of the end. And we don't know it, but it is there in Pakistan also. This is our own data from a community-based surveillance study which we did. And from the ages of 51 to the age of 80, if you can see, the blue bar, the dark blue bar here, that is the bar of people who have osteoporosis. It is steadily increasing from 10%, around 10%, to more than 30% in the very elderly. And if you see the lighter blue bar, the osteopenic people, that is also increasing. So osteoporosis is here, but we need to recognize it and we need to look after it. And I'd like to ask you, like you all, to ask yourself this question, that are we going to be the one person who's going to be facing this one day? So, the diagnosis. We have a very scientific thing, the ACE criteria, which basically say that if you have a bone mineral density of less than 2.5 in the regions which are typically affected by fragility fractures, or regardless of this bone mineral density, if you have a low trauma fracture, you should be labeled as a case of osteoporosis. And also the ACE stands for our field, American Association of Clinical Endocrinologists. I like that because it's a simple criterion here. For people who are osteopenic between -1 to 2.5, they can still be labeled as osteoporotic, provided they have one of the fragility fractures, or if they have a high probability of having a fracture based upon a risk prediction score such as a FRAX. So these are the criteria. So coming to DEXA, something which mystifies us all. What is it? This is a machine, a patient lies on it for about around 4 minutes for 3-region DEXA, and some people are concerned that it's a lot of radiation. It is no radiation whatsoever. Certainly maybe 1,000th of the radiation you get from a CT scan. And what does it measure? It tells you the bone mineral density. But it is important to remember that bone mineral density is not the same as bone strength. It is an important component of bone strength. It contributes about half of the bone strength. But beyond bone mineral density, there is the structure of the bone, what we call the microarchitecture. And there are other things, the capacity of the bone to deal with fractures. It's important to remember that while we think about bone mineral density a lot, we think that DEXA is the way to find out if a person has osteoporosis. Remember that fully 3/4 of fragility fractures occur in patients who do not have DEXA-defined osteoporosis. They occur in the people whom we call osteopenic. So DEXA we should not be obsessing about DEXA. So as I said, bone strength is not just bone mineral density. It is also the trabecular microarchitecture. And that is why some later DEXA machines have an intrinsic component by which they can predict the weakness, they can detect the weakness of the trabecular bone by a trabecular bone score. So just to explain that the trabecular bone score trabecally sort of like hold up the bone, just like a corrugated cardboard. And it is far more, a corrugated cardboard is far stronger than a stack of plain cardboard. So that is the importance of the trabecular structure, and we'll come back to that at a later stage. The next question, a lot of my residents are always asking, what do these T's and Z's mean, and which one should we be using? So stated simply, a T-score, it's not working, a T-score is a measure of how much bone mineral density you have lost over the years. So it compares a person to the reference young adult male. T-score is a measure of age-related decline, whereas Z-score places a person among a company of his peers, what we call the age cohort, the age and gender cohort. So T-score should be used when we're looking at age-related decline. And obviously you'll be looking at age-related decline in older people. So it should be seen in postmenopausal women and older men, and sometimes in fragility fractures. Whereas and it is classified according to which I just showed, that it is classified into osteopenia and osteoporosis depending upon these T-scores. But remember, we do not use them in younger people. Because it compares it to the standard young adult. And in people younger than this, the comparison would not give you any significant and useful information. In younger people, we use what is known as Z-score. And here, it just tells that if you take all people of this age and gender, where does your patient stand? So within 2 standard deviations of the normal mean of all people of this age and gender, that is what is normal. But if somebody is beyond 2 standard deviation, then we call this that the patient has a low bone mineral density for this age and gender. So this is the chronological age. And this tells us that this patient, unlike everybody else, if I am 50 years old, if I have a Z-score less than 50 years old, that means that for all the people of 50 years, I have a weaker bone even than my peers. So what is wrong with me? I have to look for a secondary cause. My age doesn't account for that. So in older adults, Z-score may actually fail you. Because if you just look at Z-score, it just says that my bone mineral density is just the same as everybody else. But it doesn't take account the fact that it's still low. It's still much less than it was when I was 30 years old. So in older people, Z-score may mislead you because it may actually not highlight the fact that there is a loss of bone mineral density. But in a younger person, Z-score will tell you that this person who should have a very good bone density is in fact not having that same kind of bone mineral density, and this patient has some cause, possibly a secondary cause. So you get a DEXA report like this. DEXA possibly only, you should know what DEXA tells you. It tells you bone mineral density, it can tell you in the T and Z score, but it also gives you a number, which is the absolute value, which is estimated value, because DEXA simply looks at how much of a beam is absorbed, and then it puts it on a film, and it's an image analysis, which tells basically how white that bone is. And the whiter the bone is, the more dense the bone is. So it's an image analysis, a 2D image analysis which is being done. Therefore, it is affected by artifacts. If there's something else which makes the bone whiter, for instance, if there's a fracture or if there is something, it will pick it up as a higher bone mineral density. But it's not obviously high. That bone is weak, but it is an artifactual effect. So you get a report like this. This is our own report, and you see that there are the 3 bars, the green, yellow, and red. So these basically, the red bar is below bone mineral density of 2.5, then the osteopenic and the normal. And according to the patient's age, you have to interpret where the patient is. It also tells in this part of the picture the various areas of this. So you have to see, and it is important because in serial images, if you get a DEXA and then you get a DEXA 3 years later, and you see that in L2 there was a 0.9, the value was 0.9, and 3 years later it's come to 0.7. So in that particular area there is a loss of bone mineral density. So DEXA is good for tracking. There are other measures. There are other measures which basically the quantitative ultrasound, the quantitative CT, which is basically same as DEXA except it gives you a 3D image. Again, it bases upon the image analysis. The bone turnover markers, however, tell you that how the bone is being resorbed. So they are the bone formation markers, the P1TP, P1NP, and the bone resorption markers, which is a CTX, which basically tell you the balance between how much bone is being laid down. But again, these are not a measure of bone strength, but they do tell you that if the bone turnover is proceeding rapidly. The next question is asked as FRAX. So what is FRAX? It's a fracture risk assessment tool, WHO validated, and it is validated for many countries. And there are other tools also, but we only, I think, preferably should look at FRAX because country-specific information is available for a lot of countries. So what's the difference between FRAX and DEXA? FRAX basically predicts, it's called fracture risk assessment. So it tells you that this person has so much risk of fracture at 10 years in the major osteoporotic sites or at the hip fracture sites. Whereas DEXA estimates bone mineral density. So they don't look at the same thing. But that doesn't mean that FRAX is inferior to DEXA. FRAX gives a different information to DEXA and it should be interpreted together. So FRAX is a calculator like this. You input your age, your gender, and certain risk factors such as if you're on steroids, if you're having any previous fractures, parental fractures and all that, and it tells you in this box down here, in this box down here, what is the risk of your osteoporotic and hip fracture. And it is different for different countries, the thresholds, but this is the US threshold that more than 20% at the major osteoporotic sites and more than 3% at hip is considered high risk. The advantage of FRAX is that it can be done in a community setting without a bone mineral density. And this is our own team which is doing the FRAX in the communities and getting information of what is the fracture risk. Obviously, it doesn't measure bone mineral density, but there are other limitations also, because a person may fracture not just based upon those hard factors such as the patient has this age, this gender and this, but also how frail that person is, what is his risk of falls, what is his mentation. So all these things are not in. So FRAX perhaps in some people underestimates 10-year fracture risk. And what does the FRAX, how to interpret FRAX? So when you do a patient, very simple 1 minute calculator, you get the fracture risk. Then according to the age of the patient and according to the percentage of fracture risk, you place that person's dots wherever. If it comes in the green area, it's a green signal, except for reassurance and some calcium supplementation, nothing is done. If it comes in the red area, treatment should be given regardless of anything else. If it comes in the orange area, then what you should do is that is when you need the bone mineral density, and bone mineral density then would translate it into either a high risk or a low risk area. And accordingly, for low risk, reassurance is needed. For high risk, an oral bisphosphonate along with the reassurance in calcium, vitamin D. And for very high risk, you might consider anabolic agents followed by anti-resorptives. So we have assessed a patient. Now it comes the challenge of treating this patient's osteoporosis. So we have two players in the game. We have the osteoblast and the osteoclast. Osteoblasts are the people which lay down the bones, the cells which lay down the bone, and osteoclasts are which absorb the bone. So I like to think of the osteoblast as a bricklayer and the osteoclast as a sculptor, which forms the bone into something more useful and more appropriate for the purpose it is made. And osteoporosis medication also falls along these lines. The anabolic agents, which basically work on osteoblast and increase the osteoblast activity and encourage formation of new bone. And these include teriparatide and other agents of the same class. And the anti-resorptive agents, which work by blocking the osteoclast. By blocking the osteoclast, they slow the bone turnover, and the existing bone then has the opportunity to get stronger. And in this class come the bisphosphonates, denosumab, and other characters. And our main player, I think the workhorse of osteoporosis is bisphosphonate. And here again, people are confused. Are they the same? What's the difference? When to use the oral, when to use the IV? And in fact, although there are differences in the efficacy, oral including alendronate and injectable such as zoledronic acid, they all do the same thing. They increase the bone mineral density. So you would probably not prefer an oral. Orals are the first line, but if there is an oral intolerance, because they do have significant GI side effects, an injectable may have to be your resource. They also differ in whether they are given weekly, monthly, annually. So zoledronic acid is an annual injection in osteoporosis, postmenopausal osteoporosis. It may be used more frequently in other kinds of osteoporosis. The precautions are that when you give bisphosphonates, whether it's oral bisphosphonates should be taken with a lot of water, the patient should not be supine after that, and even with injectable bisphosphonates, because they tend to cause an acute phase reaction, patient should be well hydrated and have an appropriate position, calcium and vitamin D replenished state. The other question we are asked is that, is there a drug holiday? Do you give bisphosphonates indefinitely, or do you stop at some stage? And the concern here is that bisphosphonates may cause what is called low bone turnover. They may cause a form of adynamic bone. So that is why it is recommended that for oral bisphosphonates after 5 years and for injectable after 3 years, you should stop and give a holiday, and again a longer holiday for the injectable and a shorter holiday of 2 years for alendronate. And this will give recovery time for the bone to recover its microarchitecture. But if the patient is very high risk, if the patient has fractured, if the patient is on high dose steroids, if the patient has very high FRAS scores, you should not give a drug holiday, because the risk of stopping is more than the risk of continuing. So the issues I have already discussed. The acute phase reaction occurs in virtually every person we give zoledronic to, because it's like flu-like symptoms, pain, myalgias, feverish feeling, and this can be improved by well hydrating the patient and giving it slowly. So it's an infusion, it needs to be given slowly and given in, obviously, always in the hospital setting. There are rare concerns which people consider, including which are people do ask, and our fellows are very concerned about it. What is atypical femur fracture and the bisphosphonate-related osteonecrosis of the jaw? So first of all, the atypical femur fracture. It's atypical because it doesn't occur where the femur fracture normally occurs, which occurs at the neck of the femur. So this occurs below the neck. It's a shaft femur. And it's a transverse fracture. And this occurs because the bone tube, which is the cortex, is held up by a network of the trabeculae. And the network of the trabeculae in bisphosphonate and other anti-resorptive agents is not continually renewing. There might be a minor trabecular fracture, but that minor trabecular fracture which normally heals, does not heal when the patient is on bisphosphonate. So that bone that here actually leads to this transverse fracture. And on the opposite side, if you can see, in the circle here, there is this indication that this is happening on the other side also. This is an abnormal deposition of calcium, and this is producing shear stress, and this is where the next fracture will occur. And then the question of what is very scary for most people is the osteonecrosis of jaw. And is it as scary as it sounds? Because osteonecrosis of jaw simply means exposed bone in an ulcer in the mouth which doesn't heal after 8 weeks. And for us endocrinologists, we see it all the time in our diabetic foot ulcers. Happens. So in most cases, osteonecrosis of jaw is not as fearsome, as scary as it sounds. But most people think that they're going to lose half the jaw, and they are very, very scared of it. And in fact, it is classified in stages according to the depth of the ulcer. Stage 1 and stage 2, all you need to do is give them chlorhexidine mouthwashes and maybe some antibiotics, because the infection actually is the thing which is preventing the healing. It's only in the advanced stage 3 that surgical debridement may be needed. There are risk factors. So these are the people whom you should be concerned about, but that doesn't mean you do not give them bisphosphonates and let them fracture and then die within 1 year. So the person, obviously this occurs more with anti-resorptives, the more potent anti-resorptives such as zoledronic acid and denosumab. And older people on steroids, diabetes, and other local poor dental hygiene may actually contribute. The question is that how to prevent it. So before if a person is going to be put on bisphosphonates, and you know you're going to put them on bisphosphonates, good to send them to a dentist and tell them to do any dental work beforehand. It doesn't mean that you're not going to treat them, but you want to get that out of the way if any urgent dental work is there. Otherwise, you should look at their mouth and look into the condition of dentition. And this is one of my favorite slides. It comes from the Osteoporosis Foundation. It says that the comparative risk of developing an osteonecrosis of the jaw compared to being run over by a car. So it is far less, it's vanishingly low. It's not going to happen to your patients. I have not seen any patient with osteonecrosis of the jaw. And the benefit is that, so this is the benefit here. So much an untreated fracture versus treated fracture, that is how much morbidity and mortality you can reduce. And the next thing is denosumab, which is one of our favorites. So what is denosumab basically? You know the osteoblasts and osteoclasts which you showed in the beginning. The osteoblasts produce a chemical called the rank ligand, and that is supposed to bind to its receptor called the rank. The denosumab, basically the blue portion, is the kebab mein haddi between the rankle and the rank. And it stops the osteoblast from activating the osteoclast, and when the osteoclast is not activated, it doesn't resorb the bone. So basically that is how denosumab acts. It's an extremely effective medicine. It reduces the vertebral fracture risk amazingly. The only problem is that once you're on denosumab, you're like the lady who's riding the tiger, you cannot stop. Because this is the figure which I wanted to show you. So above, in the white portion of the figure up there is, in the upper, is how the bone mineral density is increasing on denosumab, so dramatically. But the moment you stop denosumab, it drops all the way to baseline. At the lumbar spine, at the hip, and the hip actually comes even below normal. And the bone turnover markers, which tells you how active the bone resorptive phase is, overshoot even beyond the basics. So basically what is happening is that when you are giving denosumab, the osteoclasts are stopped in a state of pre-development. The moment you remove denosumab, they become active and they are hungry, they eat the bone even more than they would have normally eaten. So that is why denosumab stopping can lead to a such. Should you stop it? There's no reason to stop. So you should select the patients very carefully, because if the patient is only going to be affording it for, let's say, 1 month, one year or 2 years, then better not to give that. Use some other agent. If you think that the availability of this medicine is dodgy, don't give it. So if you think that the patient is not going to be compliant, don't give it. We will skip the anabolics and that. So this is the ACE algorithm, which basically says that when you have high-risk patients, you give the patients oral bisphosphonates and go for a second-line agent only if there is a continued decline in bone mineral density. However, in the very high-risk patient who has a prior fracture, you may start with an anti-resorptive afterwards. First, you should give the anabolic. So you build the bone with anabolic, then give the anti-resorptive. One I wanted to share here. So this is because our joint concern. The rheumatologists are always on steroids, or I don't know. So the steroids are very bad for the bone. This is a high-dose steroid. You can see how much bone mineral density is declining on steroids. And this is very dose-related. So the higher the dose, the more bone mineral density decline is. So beyond 20 milligram of prednisolone equivalent, it increases very rapidly. But it is a very transient thing, so it recovers rapidly. So you should basically, when you're putting a patient on steroids, you should use the lowest dose of steroids, and you start bisphosphonate early. The last part of my talk is preventing. Is it inevitable? Are we all going to have osteoporosis? Are we all going to fracture? Not if we look at this part of the graph. You improve the peak bone mass in our younger individuals. And how can you do that? Ensure that you get the adequate amount of calcium and vitamin D from diet. This has been shown to reduce fracture risk. There are some concerns recently that giving calcium supplements increases coronary heart disease risk, but that occurs in very high rates, that is more than 1500 milligram per day, and there is a small decline. So perhaps in those patients you would be careful. Otherwise, calcium and vitamin D reduces fracture risk. It's a simple thing. Dietary calcium. So you're recommended 1000 to 1200 milligram of calcium every day. Most people, this is our own data, are taking less than that. Cola consumption. This tree graph shows that by how much bone mineral density declines with cola consumption. Across the board in all these studies it's declining. And the more number of colas you take, the lower your bone mineral density decreases, and especially in women and especially in hip. So cola consumption is so dangerous. Next time. But it's not all about. We have traps in our house. Our elderly people, our parents are living with failing vision, poor balance, forgetfulness, medicines which put them in a state of drowsiness. And then there are traps, like these stairs. So a normal stair should not be higher than 7 inches. And it should not be narrower than 11 inches. This is, I think, 1 foot, Dr. Tafazzal. This should not be in a rheumatology conference. Okay? So you should look into that, put anti-slip pads on, and this is also a very slippery surface. This should have anti-slip pad on it. So we have traps in the house. We should make, if we are going to leave our parents alone, make your house foolproof. And preferably don't leave them alone. But then there is special, improve the balance. So Tai Chi is a form of exercise which focuses on improving the balance. And this reduces fracture risk. This is my final message. Keep your bones strong and healthy. Thank you.
Thank you, Madam, for such an illuminating talk. Moving towards our next talk on a rather misunderstood autoimmune condition, relapsing polychondritis. In this disease, the body turns against its own cartilage, causing inflammation, pain, and potentially life-threatening complications. Yet, it often still lurks in the shadows of medical awareness, undiagnosed or misdiagnosed, leaving individuals battling with its debilitating effects. Today, we shall try to unravel the perplexing disorder with the help of our renowned expert, Dr. Shakib Qureshi. Dr. Qureshi did his MBBS at King Edward Medical College. He is an American board certified in rheumatology, American board certified in internal medicine. Dr. Qureshi is one of the esteemed doctors with more than a decade of experience. He has remained the Director of Rheumatology at UBMC Utah, USA, and the Clinical Associate Professor at Rocky Vista Medical School, USA. Dr. Qureshi has served the Chief of Rheumatology, Lead Physician, and Educational Coordinator of Rheumatology for Internal Medicine Residency in Christiana Care Healthcare System. Dr. Qureshi is also the ex-president of the Delaware Society of Rheumatology. I would like to invite Dr. Qureshi to please come on stage and present his talk.
Bismillah ar-Rahman ar-Rahim. Thank you very much for inviting me for this talk. Thank you to Dr. Tafazzal, Dr. Aflaq. मुझे पता है कि ये आफ्टरनून है, आप जरा थोड़ा बोर होना शुरू हो गए होंगे. मेरी टॉक ब्रीफ है, इसलिए आप को ज़्यादा तकलीफ नहीं होगी. So the reason I chose this topic, in fact, I told Bilal that I want to do it, who was actually scheduled to do a talk on this, was because this is a very interesting case that I'm going to start with. And the reason I'm presenting it is that it's a little bit emotional to begin with. I'm going to present actually a case which is, I'm just recalling from my memory because I do not have his chart or any information available now. So this was a patient who presented to me, I would say about approximately 10 to 12 years ago. And during a very busy schedule, he was, I received a call from infectious disease, head of the department that, this is a very important patient, very important member of the community that you would like to see. So he was an add-on patient. He came to me, and his main complaints, so he was consider this that he was a marathon runner. He was a physically very gifted man in his early 50s. And what he presented was something that looked like relapsing polychondritis. everybody's a rheumatologist in this room, so everybody knows what the common features are. So he presented with intermittent pain and inflammation in the ears and nose. But what was different was that he had febrile episodes, and he also had some weight loss. His appetite was not as good. And what was really different was that he had low platelet counts, and he also had shortness of breath, cough, and pulmonary infiltrates on the CAT scan that he brought with him. So at that time, I told him that the possible diagnosis is, one of the possible diagnoses is relapsing polychondritis, and then I would like to work him up for that. And obviously, since the things do not look very typical, so I would like to work him up for some other things too. So based on his clinical symptoms, I said that, top of the list is relapsing polychondritis, then there is lupus, vasculitis, and stuff like that. And since relapsing polychondritis is one of the vasculitides, I told him that this is a kind of falls in that category. So what he requested to me was that, tell me the name of the best vasculitis person in the nation, and I'll rather go to him, because I don't want to take a chance if it's such a rare disease. So at that time, I had a close working relationship with Johns Hopkins Vasculitis Clinic. Dr. Philip CO is very famous now in the field of vasculitis, was one of the people I knew. So I told him to get there, and he was, because using all his connections, he actually went there. Kind of the patient fell off my radar for a while. I felt that, okay, a patient came, and then, that's it. A few months down the road, or I think about, I would say closer to a year, the patient, I was called, so we were the thing about our practice was that we were the only ones who used to come to the hospital where I used to serve. And rest of the rheumatologists would not come to the hospital because everybody would make more money in their private practice. That's how in US it works. So you come to the hospital, you're going to basically lose money. So that was the downside was that it was a very busy inpatient practice where a lot of rheumatologists turnover was there. The good side was that we would see all the difficult patients, even for the local rheumatologists. So by default, he landed up there, and I was on call, and I was called to see him again. And he got admitted for fever, chills again, thrombocytopenia, and pulmonary infiltrates, and was on steroids. So again, the infectious disease came, and they ruled out their own stuff. So I asked him what happened in between. So he said he went to the Johns Hopkins, and they tried different steroids, they tried immunosuppressants, but he keeps getting these attacks. So this was a little odd. A little bit more time went by, and he started getting admitted again, and this time around he was sent to NIH, which is the mecca for all these autoimmune inflammatory fever syndromes. So again, they could not do anything too. And then what happened was that finally he has been cycled through different DMARDs and some biologics. And finally, one of these admissions, I also got bored that I had nothing else to offer, and he keeps coming back. And in one of his final admissions, I told his wife when he was admitted, I said, we have done everything. You have been to Johns Hopkins, you've been to NIH, what else do you want me to do? And then what happened was that I still remember that, that helplessness that I had when I went to his room. This was a guy who was a marathon runner, now shrunken, shriveled, small guy, lying there and asking me for help. And I still remember his final words that he said that, "Doc, could you save me? Is there any way that you could save me?" And at that time, like all the physicians in the room, when you don't know what's going on and the patient is very critical, you feel very, very emotional that, you are here to help him out. You're here to kind of save his life, but you could not do anything. So, and an interesting fact I'm going to also explain is in 2021, the ACR now, it's COVID time, the American College of Rheumatology is now remote. So the best time I'm telling you that I'm enjoying in education is now, because every lecture is recorded. In the ACR meetings, you don't have to rush around, you don't have to, at one time, 10 different parallel lectures are going on, and we used to miss them other than the one lecture we were attending. So this time around, I actually listened to every talk for the first time. And lo and behold, what happened was that there was a lecture on this vexus, and a newly diagnosed disease. I don't know how many. Has anybody heard about this disease in the room? Yeah. So, so I actually got excited in that sense that I thought that this was what that patient had. So I called up my ID specialist friend, and he completely agreed with my perspective. By that time, he has heard about this disease too. So this is what vexus is. And that's why my topic of discussion was not relapsing polychondritis, but its mimics. So VEXUS, this is what stands for vacuoles, E1 enzyme, X-linked, autoinflammation, and somatic. So primarily, it's a sporadic genetic mutation. Sporadic means that it's not genetically inherited, but it's a sporadic by chance mutation, which basically affects the E1 enzyme, affects the UBA1 gene, which in return actually affects the E1 enzyme. So E1 enzyme is present in all the cells, which is important for what we call ubiquitation. Ubiquitation, remember that thing, ubiquitation. So ubiquitation basically means that when the cellular process routine is going on, this enzyme is required to remove the degradation products of the cell. And when this enzyme is not working, those degradative process does not happen, and all those protein which is not required in the cell is still there, which actually in result causes the antigenic stimulus, and as a result of which there is an unrelenting, widespread autoimmune inflammatory process that sets in. So the first article which was presented ever for this disease was in 2021 in New England Journal. So what the New England Journal people, that particular article mentioned was that we all know that there are a lot of illnesses where we don't know what that is. Like there is a febrile illness, platelets are swinging, joint disease, arthralgias, but no diagnosis made. So at that time, a group of physicians were basically, they grouped a lot of patients like that, and they started doing genetic testing on them. And once they were doing genetic testing on them, what they found out was this one commonality, this particular genetic mutation, UBA1 genetic mutation with similar kind of clinical symptoms. So that's when they published this article, and the first patient, there were about 25 patients then. One pearl I'm going to give, I try to give pearls in every of my talks so that there's some take-home message. So remember, if there is a relapsing polychondritis patient, remember this if you don't remember anything else. If there is a relapsing polychondritis patient where there is a macrocytic anemia, that means MCV is greater than 100, or platelets is less than 200, strongly think about VEXUS. It has got 100% sensitivity almost and 96% specificity. We are talking in relationship to relapsing polychondritis-like picture. This scheme of, this basically picture will give you a lot of symptoms as a part of VEXUS. The most important symptoms, as we already know, like there is going to be, a chondritis-like picture, ear and nose inflammation. But what is important is mostly they get, almost 100% they get a skin rash. And that skin rash is a vasculitic kind of a skin rash. If you do the biopsy, it will look like a neutrophilic dermatosis. And that's why a lot of these patients get confused with Sweet syndrome or anything which can cause leukocytoclastic vasculitis. So that's one of the differentials. The other thing which is very common in these is the bone marrow disorder. So myelodysplasia kind of a picture, which mainly is affecting the erythroid or myeloid cell line, is where you want to worry about. This is a very specific symptom as well. Other ones are relatively, so the DVT is also very common in this. So DVT, more common is the venous, which means about 40 to 50% patients will have blood clot in the legs or elsewhere, and about 15 to 20% will also have arterial clots, which is a very important thing as we know. And then there is pleural effusion, the lung involvement, the pneumonitis, and those kind of things, which also are pretty odd. This is a picture of the bone marrow from a VEXUS patient. These vacuoles, as you can see, is one of those VEXUS vacuoles. So V stands for these vacuoles in the bone marrow, which basically affect the erythroid and myeloid cell line. This is another picture of a patient who had VEXUS, or patients who had VEXUS. So you can see in picture A, there is a lung involvement with pneumonitis. B is vasculitis of the medium-sized bronchial arteries. C is the neutrophilic alveolitis, and D is vacuoles in the bone marrow. The skin biopsy which showed neutrophilic dermatosis and tender plaques or nodules, and then there's a chondritis picture. Cutaneous manifestation could be of any kind. Palpable purpura, leukocytoclastic vasculitis-like picture, nodules which are painful but not itchy, and these can be pretty widespread as well. Treatment. So treatment part is very important because treatment is evolving. So far it's kind of typically a fatal disease. Fatal disease means that patients will keep on getting these attacks, and they're steroid responsive for a little while, but then they stop responding. The drugs which I'll give you a nutshell, different drugs have been tried, but the one which have shown some promise is cyclosporin for especially the inflammatory attacks, some help of tocilizumab, but I think the most effective, you should note it down, is ruxolitinib. So which is a JAK inhibitor, we call it Jakafi also. We have been using it for polycythemia vera, we have been using it for myelofibrosis. But this particular drug so far has given about 50% relief of symptoms in 50% of patients, which is a lot. So a lot of patients who are steroid dependent will not be more steroid dependent after using this drug. And so far, it can give you a remission for a year or more, which is kind of not very common. The only thing which can cure these patients is bone marrow transplant. So bone marrow transplant is a very tough situation in these patients because they're old age, typically they're above the age of 50, 60, 70, they have a lot of comorbid features. So they are not the best ideal candidate for bone marrow. I think so far about 6 patients bone marrow has been tried, 3 patients have been cured, I think 2 or 3 died after that because of the complication of bone marrow transplant. But this is one of the options for cure of the disease. So this is a part of the VEXs. If you have any question about VEXs, you can ask me. As I said, the field is evolving. Oh, one very important part about VEXs is, as people think it's a very rare thing, it's by the way not that rare. According to the updated literature, not up to date, about one in 5,000 males can have it, and 1 in 10,000 females can have it. So it's not that uncommon too. As more and more genetic testing is becoming available, actually Mayo Labs regularly does this lab now commercially available, that if you feel like that, obviously it's not available here, but in US and those countries actually this genetic testing is readily available and it's very sensitive and specific. So relapsing polychondritis, which is the other topic that it mimics obviously, is another rare disease. How many patients in this room has seen relapsing polychondritis patients? So 2, 3, right? In the lifetime of any rheumatologist, I think you're not going to see more than 3 to 5 patients at the most. Because one in a few millions, 1 in million or 1 in 2 million people are going to have a relapsing polychondritis, which is very rare. Which means that after seeing thousands of patients, you're going to have 1 relapsing. Another thing actually why it is rare is because it is relapsing. Relapsing means that the patient is going to have some symptoms. For example, a lot of patients who have a minor kind of a subset of this disease are going to have a symptom, but then the symptom will disappear. And then during that episode, patient may be self-medicating with ibuprofen or any kind of an NSAID, and the symptom will go away. And that's why actually I think it's relatively rare. These days, the classification, like, remember when in myositis, I used to give that lecture to you guys. Myositis was polymyositis, dermatomyositis, which is not the classification anymore. We all know that the classification of myositis is antibody-based. Similarly, the field of relapsing polychondritis is evolving too. It's not, they're trying to divide it into different subsets. It's a relatively lengthy, boring process, so I'm not going to go into that detail, but coming in a few years, you'll see a very different classification of relapsing polychondritis. Another take-home pearl, if the kidneys are involved, it's not relapsing polychondritis. So take another message. The first case of RP was described in 1923 by Jacques Wartenhorst, probably a German scientist. Then the term relapsing polychondritis was first used by Pearson and all in 1960 in their review of the first 12 cases, published cases. This is typical McAdams criteria and Damiani and Levine criteria. To tell you the truth, it will become obsolete soon. So I'm not going to go into that detail. As I said, the new classification will be based on the subset of patients and how they are. Everybody knows about this, right? The ear involvement, especially for the students, I'm sure the attendings already know that. If you have repeated attacks of ear chondritis, first of all, what is the tip-off? How is this? What is the clue in this picture that tells you that this is relapsing polychondritis ears? Anybody can tell that? So it's involving the cartilage part of the ear, right? Cartilage. It's sparing the lobule. So basically, this is a relapsing polychondritis picture. What is this now? Infection. And you know why it's an infection of the ear? Because you can see like there is an entry point. So typically such kind of ears happen when the girls go for the piercing and the piercing is not done in a proper fashion, the ear piercing, and you can get an infection. Or you are a diabetic and you get an ear infection. Or if you have an ear surgery and you get an infection or insect bites. But the previous picture was not in. But why I'm putting this on is because a lot of patients with relapsing polychondritis gets confused with infection. Rugby players. You know what is if the patients with relapsing polychondritis keep on getting attacks untreated, what happens? What is the final version of the ear? What is the catchy name for that? So cauliflower ears. Cauliflower gobi ki tarah ki jo hoti hai us tarah ki picture. These are again cauliflower ears, but this is a rugby player. In rugby players, especially the front runners in the front people, they get their ear damaged quite frequently. And then they develop the clots in the ears. With repeated damage, they develop cauliflower ears. Very different thing. This is not to be missed too. So lymphoma of the relapsing can really mimic as well. This I am presenting a case report. In this case report, what was the clue was that although this is bilateral auricular chondritis, but the other ear was almost completely involved. So that was the clue. So whenever that happens, you have to take a biopsy, and this was a low-grade lymphoma. The patient was treated with splenectomy and chemotherapy, and he went into remission. Not to be missed. Antiphospholipid antibody syndrome ears. Everybody knows about CAPS, what CAPS is. So in CAPS, you can have this kind of a presentation. Again, the whole ear is involved. It's very painful, and necrosis can happen. So one of the differentials that you're going to run will be antiphospholipid antibody syndrome. This is leprosy. So what is again the tip-off is the whole ear is involved, and you have skin nodules there. And this patient, when he had the biopsy, the acid-fast bacilli were seen. Now, anybody in the room can tell me about nasal chondritis, how does it present? What would be one symptom? Pain? Yes or no? Right? Yes? It will be, it's an inflammation, right? Would there be a lot of erythema or swelling? Very good. I think only Yasser and Bilal are awake. I think everyone else is sleeping. So it's not that boring, guys. Wake up. All right. So what happens is that with repeated attacks so what you're going to tell what you're going to ask the patients about it is that you don't ask them, you should ask this directed question, where is the pain? If they say that it's at the tip of the nose, it's not, chondritis. If they say the pain is in the base of the nose where the nasal bridge is, that's where the pain, that's where the clue is. So with the repeated attacks, what happens is that they develop this particular ear, which we call nose, which we call saddle nose deformities. This is where the money is. This is where the things become more serious. If it's only the ear and nose involvement, it's not that serious. But when we have the airway involvement, has anybody seen any patient of the airways? I've seen actually one of the patients actually a co-managed with Johns Hopkins. Again, airway disease is where you should become very serious. So if somebody's so the airway is also divided between upper airway and lower airway. The lower airway patient can present it's a very lethal disease, and it can be a very emergent situation. They can present with acute shortness of breath and asthma-like picture, because remember that it affects the cartilage. So neck has cartilage, thyroid cartilage. It can present in the form of neck pain, trouble swallowing. It can affect the vocal cords, so dysphonia or hoarseness. When it affects the trachea, you will have obviously inspiratory and expiratory problem and stridor, etc. But when it affects the lungs, it can be very asthma-like picture, because the reason is whatever cartilage is in the bronchioles and bronchi, they basically will melt also, and they will start collapsing, and there'll be a lot of inflammation and edema, which can lead to bronchial obstruction and asthma-like picture. This picture gives you a tracheal involvement. As I said, lower part can have cough, thoracic pain, wheezing, respiratory failure, and it's emergency. When the airways is involved, remember what you have to do is you have to do a CAT scan of the face, CT scan of the chest, and the CT scan of the chest should be done as a dynamic CT scan, which means in inspiration and expiration, both, because you're going to see this collapse of the trachea in inspiration and expiration. This is very important. This should not be missed. Tracheobronchiomalacia is a potentially lethal disease, life-threatening. This is a picture of a tracheal involvement where the first one shows active disease and the second one is after improvement in the trachea after the treatment. Ocular involvement, like any other inflammatory vasculitis, it can cause scleritis and episcleritis and uveitis, so remember that too. Cardiac involvement, another very serious thing. So like lung involvement, cardiac involvement is very important. And what it affects is the thoracic. So this is, as compared to the other things that I mentioned, this is a late complication. So somebody who has repeated attack of relapsing polychondritis involving the ear and nose, don't dismiss it. 5 years down the road, they can have a cardiac involvement. And the cardiac involvement is mostly around the aorta. It could be the thoracic aorta, abdominal aorta, and it also involve the aortic root. So aortic valve can be involved too. If you do not take care of it, finally aortic dissection and rupture can happen too. And like any other vasculitis it can also affect the endocardium, myocardium, and epicardium, pericardium. And the resulting, you all know that can lead to pericardial effusion. In fact, my patient had pericardial effusion, the one I sent to Johns Hopkins along with the tracheal involvement. Costochondritis, like cartilage anywhere else, you have cartilage in the rib cage area. It will present in the form of chest pain. Everybody in this room knows about costochondritis, its presentation and its clinical findings, so I'm not going to go into that detail. Articular involvement. This is the only easy part. The joints are never that bad. Means you're going to have a polyarticular, it can be symmetrical, it can be asymmetrical, it could be large joint, it could be small joint, it could be even spondyloarthropathy like picture, but it never is destructive, it's never is erosive. So this also is a very important slide. You might want to take a picture of this. What not to order. What not to order is the anti-collagen 2 antibodies have a very low sensitivity and specificity, only 20 to 30%. So therefore they're not useful in making a diagnosis. And I don't think they're commercially available for that reason. Biopsy of the cartilage. Biopsy of the cartilage should not be done until and unless you think it's a lymphoma. And you have some reason. If it's a very classic picture, don't take a biopsy because it is an invasive thing to do. Relatively non-specific results if it's not a lymphoma or infection. Similarly, inflammatory markers can be deceptively normal. It's a very complicated disease, a lot of relapsing. So 50% of the patient have seen 3 physicians before they come to make a diagnosis. Treatment. So the milder cases, we all know, they heal with just NSAIDs intermittently, and that's why many patients show up very late, because they're taking NSAIDs on their own. If it becomes relatively more chronic, colchicine can be tried. If colchicine fails to protect these joints or protect these attacks for 6 months, you want to stop colchicine. Dapsone used to be one of the criteria. Response to steroid and Dapsone used to be one of the criteria. But Dapsone is a very complicated medication, a lot of side effects, and it can lead to some irreversible damage in case of G6PD. So make sure if you have to start it, you check the G6PD levels. Injection of steroids wherever the joints are, and the prednisone in short term if everything else is not responding. Then come the synthetic DMARDs with methotrexate, leflunomide, MMF, and biologic DMARDs in the more difficult cases. Anti-TNF and IL-6 blockers have very good results. And limited role of surgery. Treatment of the airways is very important. Remember this thing. If somebody is having an acute tracheal obstruction or they are having severe subglottic stenosis, tracheostomy will resolve the issue. As we all know that tracheostomy is life-saving, and the upper airways you can manage just by tracheostomy. Lower airways is very dangerous. So when you're really thinking that it's more of a low tracheal involvement or lung involvement, you have to, and it's a very emergent situation, you may want to pulse them with steroids. So in very life-threatening cases, you pulse them with IV steroids, gram a day for 3 days, followed by Cytoxan, and then further azathioprine, etc. Role of biologics, as I said that in this disease, the main role is with infliximab and adalimumab, good response in most of the patients. Tocilizumab in most of the patients as well. Abatacept has a limited role so far. And JAK inhibitors are being studied right now. Final slide is, I want to mention about this MAGIC syndrome. How many people have heard about MAGIC syndrome? Right? So MAGIC syndrome basically means it's a Behçet's disease along with relapsing polychondritis. Everybody probably knows about Behçet's disease. It basically is an oral and genital ulcer disease. And when combined with relapsing polychondritis, it's a potentially quite a lethal combination because this is a subset of patients who can have anything. Raynaud's phenomena, skin disease, lung involvement, even VEXAS, thromboembolic disease. So remember that you don't take it that non-seriously. Very few cases though. So overall, I think reported cases about 50 or so. So in summary, this is the final slide. It's a very heterogeneous disease. It can present in any shape or form. Diagnosis is mainly clinical. There's not a blood test to diagnose, not a biopsy that should be done. The poor prognostic signs are male gender, hematological involvement, respiratory and cardiac involvement. VEXAS is a very serious subset, very serious subgroup of the relapsing polychondritis with very high mortality and needs genetic testing. Early diagnosis and treatment requires collaboration between rheumatology, ID, ENT, and pulmonary, and new modalities of treatment are evolving. So here I stop, and if you have any question, you can ask now.
Thank you so much, sir. Our next topic is focused on the latest developments in myositis therapeutics. Myositis, a group of idiopathic inflammatory myopathies affecting muscle tissues, presents unique challenges in diagnosis and management. Today, we have the privilege of hosting a distinguished guest speaker who will discuss the cutting-edge advancements, promising treatments, and future directions in fighting this complex condition. Let's extend a warm welcome to our speaker, Dr. Julie Jason Peck. Dr. Peck completed rheumatology fellowship in 2013 and currently sees patients in Johns Hopkins Myositis Center and Scleroderma Center. Her research interests are in myositis and scleroderma or overlap myositis. She is Director of Clinical Trials at Johns Hopkins Myositis Center and Associate Professor of Medicine. Please note that this is a recorded lecture and she may join us online later. Thank you so much.
Thank you for the kind introduction. I'm so excited to be here to discuss updates in myositis therapeutics. My name is Dr. Julie Pack, and I'm an Associate Professor of Medicine in the Division of Rheumatology at the Johns Hopkins University School of Medicine. And I'm also the co-director and director of clinical trials at our Hopkins Myositis Center. So thank you deeply for this invitation. And without further ado, I will be discussing the promising area of myositis therapeutics. So these are my disclosures today and our obligatory copyright material slide. So the outline of my talk is to give you a brief overview of the diagnosis and different major subgroups of myositis, just briefly, about 1 or 2 slides. And then I'll go into the current treatment algorithm of myositis. And then I will finish off with the promising treatments in myositis, highlighting the areas in particular in dermatomyositis, and also in anti-synthetase and inclusion body myositis as well. So first and foremost, the diagnosis of myositis, I say, takes about 6 diagnostic tools that are at our fingertips. First is the pattern of weakness, of course, because for myositis, patients will typically have proximal muscle weakness in polymyositis and dermatomyositis. But of course, don't forget that inclusion body myositis, or IBM, patients will also get proximal and distal weakness. And then we also use the muscle enzymes, the CK or creatinine kinase and aldolase levels. Third, we use the EMG and nerve conduction studies. And really, that's very helpful to tell us if someone has muscle weakness, is it truly an intrinsic muscle problem or is it a nerve problem because the nerve is not properly communicating to the muscle? is it a nerve problem that's resulting in muscle weakness, like ALS or Lou Gehrig's disease? Next is muscle MRI. This will tell us activity and also chronicity, so damage if the patient has had, myositis for some long time. And the T2 stir images are the sequence that we want to look at to look for muscle edema. And you can see here that there is evidence of muscle inflammation in the anterior and posterior compartments, and also evidence of fasciitis. And if this MRI image is not as clear, I just want to clarify that, in terms of orienting ourselves, on the top is the skin, and then right below is the subcutaneous fat, but they white out the fat so you can actually look for muscle edema. And then there's fascia right here on top overlaying the muscle, and then you have the muscle right underneath the fascia. So in this sequence, we're really trying to look for edema, a fluid signal, which would be very bright to tell us that someone has myositis. But remember, I always tell this to my fellows, and any time there's a conundrum of, is this diagnosis myositis or not? The key thing is that the key message about the muscle MRI is that it cannot diagnose myositis. Myositis is still obviously a clinical diagnosis, because someone can also have muscle edema because they just have a lumbar radiculopathy. And you'll see that muscle group in the posterior group of the muscles light up because of that. Anyway, I may have spent a little bit too much time, but it's just a reminder that while we have these advanced techniques, it can be extremely helpful, certainly, but it's not the be all and end all to make a diagnosis of myositis. And then here we have muscle biopsy, obviously still the gold standard, but I would have to say that we're not doing as much muscle biopsies as before. And the reason for that is that we have up here, right here in the middle, I hope you can see my arrow, the myositis autoantibodies. And as you know, the myositis autoantibodies can be very predictive of a patient's phenotype and can help with diagnosis and also prognosis. And that's why, in particular in patients with dermatomyositis, we may really not need to get at all a muscle biopsy because it's very clear that a patient has it. Now, I always say that a muscle or myositis talk is incomplete without a slide on myositis autoantibodies. And the reason is that patients with myositis autoantibodies have a tightly linked correlation with the presence of a specific myositis autoantibody and the presence of specific clinical features in a patient with myositis. So if someone, as you know, has MDA5 dermatomyositis, we know that this patient will have those kissing papules or the palmar papules on the hands, and you can make that diagnosis by just looking at their hands. And we know that we're going to be able to predict that they have a high risk for developing interstitial lung disease, and this is why these autoantibodies are helpful. Now, I think the biggest concern about myositis autoantibody is where and what type of autoantibody assays are being conducted. And this is a big discussion among myositis investigators that if the assay is done in an improper place, this can really, or done on a poor assay, let's say, not improper place, a poor assay, it will not be very helpful, and it can make patients get very nervous, because I've had patients come to us and say, well, I had this, IBM antibody positive in the blood, the NT5C1A, and I was told I have inclusion body myositis. But we all know that the NT5C1A antibody is not 99% specific for the disease. We know that it is not. We know that certain patients with lupus or even Sjogren's can have this autoantibody be positive, and even some dermatomyositis. And we've looked at that in our cohort by collaborating with the Lupus Center and also the Sjogren's Center at Hopkins. So it's important that these autoantibodies are definitely helpful, but definitely still need the clinical context or a gold standard, especially in the cases of questionable inclusion body myositis, a muscle biopsy. And I think, the audience here certainly knows about the immune-mediated necrotizing myopathy. SRP and HMGCR are the most common, and TIF1 gamma and XP2 are most commonly associated with malignancy. I would have to say for the past, 5 to 10 years, TIF1 gamma is more highly linked with a increased risk of cancer now. And overlap myositis is truly at the intersection of myositis and another connective tissue disease, where you either may have scleroderma or lupus, and these patients can be very difficult to manage because they have two connective tissue disease going on at the same time. And so we have to look for different manifestations, extramuscular manifestations like Raynaud's and interstitial lung disease that can be challenging to treat. All right, so that's the background of the myositis autoantibodies. So the four main subgroups of myositis to this day, although I think in the next couple of years this will really be changed, so my talk would change as well. But the four main groups are dermatomyositis, immune-mediated necrotizing myopathy, polymyositis, but truly it's a diagnosis of exclusion, and then inclusion body myositis. But then you'll ask me, well, then why is the ACR-EULAR criteria, classification criteria from 2017, have dermatomyositis and polymyositis, right? And even for clinical trials, we still say we're recruiting for DM and PM or dermatomyositis and polymyositis. We don't specifically say we're recruiting just for immune-mediated necrotizing myopathy. So I think this will evolve, because we know that most of the patients who were previously diagnosed as polymyositis using the old 1970s Bowen and Peter criteria, most of those patients are really actually immune-mediated necrotizing myopathy, or misdiagnosed and actually end up having inclusion body myositis. Because you remember those Bowen and Peter criteria was vastly sensitive to pick up on the diagnosis of myositis, but not very specific. And so remember, polymyositis is truly a diagnosis of exclusion here in red. And if a patient has polymyositis without an autoantibody, then you really want to pursue the muscle biopsy. Because if they don't have a autoantibody, it'd be very suspicious. Maybe this patient actually has adult onset muscular dystrophy, which I've diagnosed as well. So certainly you don't want to miss those things, different alternative diagnoses. All right, so now let's switch gears and talk about the treatment paradigm of myositis. Now, this is fraught really with a lot of uncontrolled trials and case series back in the 90s and early 2000s. But I would have to say this is really the standard of care in the United States currently. And of course, I would love to learn about how it is done in Pakistan as well. So initially, we always use glucocorticoids, 0.5 mg per kg per day to 1 mg per kg per day. And if someone is extremely sick, we'll admit them to the hospital, especially if they have diaphragmatic weaknesses or severe weakness and dysphagia, they'll be getting pulse dose steroids naturally. But in the outpatient setting, depending on the severity of manifestations, we would give them steroids plus one of these three agents. And it's really largely dependent on whether the patient has more prominent muscle plus joint involvement, so then we would choose more methotrexate. If someone has lung plus muscle, then we would either be using azathioprine or mycophenolate. Now, there's no really prospective head-to-head clinical trials looking at any of these three agents. But we do know that in a retrospective study that we did at Johns Hopkins, a pulmonologist working with Dr. Danoff, our colleague in the ILD Center, the director of the ILD Center, looked back and looked to see if there's a change in FVC or forced vital capacity on PFTs. And if it was different across the follow-up period when you compare azathioprine versus mycophenolate. And there really was no big difference. Now, this was not a prospective clinical trial, but it gave us insight that whether the patient can tolerate azathioprine or mycophenolate is probably about the same. Now, in terms of skin disease, I think it's a little bit different. This is more anecdotal, and there's some small case reports, and this is my own anecdote that I do think mycophenolate tends to work a little bit better for the skin disease of dermatomyositis. But both really work well for the lungs. Now, what about combination therapy? So yes, we start with the steroids and we use these agents at the same, we start them off at the same time with the goal of maxing out the methotrexate, azathioprine, or mycophenolate while we're tapering the glucocorticoids. And usually the methotrexate we start, from usually around 15 to 25 is max per week. Azathioprine, 1.5 to 2.5 mg per kg per day, and the mycophenolate, the minimum efficacious dose we think, extrapolated from other studies really is about at least 2,000 milligrams per day, and maxing it out to 3,000 milligrams per day. Now, one note, yes, about the combination therapy. So there is an old study in the NIH by Dr. Paul Plotz, A Giant in Myositis, where you could actually combine the methotrexate with the azathioprine and get some significant control of the patient's myositis and muscle strength and improvement in CK. So if you have somebody who's on methotrexate, but you can't fully control their disease and their CK is not coming down and they're still weak, but you can't quickly access the infusion medications, or insurance is giving you a hard time, like we have issues as well, I'm sure you do as well, then adding a little bit of azathioprine, about 25 to 50 milligrams per day with the weekly methotrexate, can certainly be helpful. Now, if after about 3 to 4 months of these oral agents, then we're going to be adding one of these agents, usually IVIG, especially if they have dysphagia, and or rituximab. And rituximab, unfortunately, as you know, the rituximab and myositis trial, that was unfortunately, the RIM trial, unfortunately, was a negative study. But as you know, there were a lot of issues with the clinical trial design. The endpoint was actually time to improvement, and that not actually the percentage of how many people met the definition of improvement of a validated myositis response kind of criteria at the time. So this was a big disappointment. To date, it is still the largest myositis clinical trial, but now in the US, because it was a negative study, it was very difficult for us to get this drug approved. And this is very challenging for us to get this approved for our patients with myositis. Now, IVIG, I'm sure you've seen in the news and also in the New England Journal, led by Dr. Rohit Agrawal at the University of Pittsburgh and other investigators from Octapharma. It was a study, it was a phase 3 double-blind parallel group randomized placebo-controlled trial, or ProDerm, Progress in Dermatomyositis Study. And this included 95 patients, and it was a multi-center clinical trial. And the endpoint was actually at 16 weeks. Now, let's take a step back. We already knew that IVIG worked brilliantly in the treatment of dermatomyositis. And this was done by Dr. Delakis in 1993, and it was also published in the New England Journal. Now, it was a smaller study, but we knew that it worked as quick as 2 months, even back in 1993, and the peak efficacy between 4 and 6 months. So this is why they chose their endpoint at 16 weeks. And in this case, they also allowed concomitant therapy up to 2 immunosuppressive agents and steroids, meaning that you could have actually had a chronic myositis patient who had some weakness because you required at least mild muscle involvement, 4 out of 5, or less than 142 on the MMT8, and without any elevated muscle enzymes, and they could enter the study. Now, what do we see in this graph? The big take-home point here is that in patients who received IVIG, these patients had a significantly higher mean total improvement score, which is the validated ACR-ULAR criteria for myositis response criteria, as measured by the total improvement score that was that was validated in 2016. And the blue is the placebo group, and you can see it was much lower. Now you're going to say, well, it's not 0, which is interesting because now this did shed some light that the placebo group response was actually a little bit higher than we would expect. So actually 20 means that there's a little minimum improvement, even in patients who got placebo. But as you can see, they're definitely increased up to moderate improvement and plateaued out, similar to the group that got IVIG. So based on this led to the FDA approval of IVIG in the United States before it was not FDA approved as of July 2021. And just to highlight again, that I think it's the really old school thinking about dermatomyositis, and you need to have an elevated CK. It's very well understood and published that patients with dermatomyositis can have mild elevations in their muscle enzymes, but still be predominantly weak. They can also have significant fasciitis as well. And so this highlights the patients that they recruited had improvement despite a normal CK. And maybe their CK was not that high because they were on up to 2 background immunosuppressants. But you can see here that compared to the treatment group versus the placebo group, the MMT8 score, which is a manual muscle testing score of 8 muscle groups, that this is pretty low, and is comparable to the placebo and IVIG group. And this is really highlights that these patients with dermatomyositis, they really don't need to have significant elevations of their muscle enzymes. So there is the muscle enzyme here is 141 and 113 for you to consider, if they're not responding, as long as they have some weakness, for you to consider to actually add IVIG. All right, so I talked a lot about IVIG, and I hope it's readily available in Pakistan as well. We have been using it for some time, and now it's FDA approved, so we're using it a lot more, and which is great for the patients as well. So what are some other promising treatments in dermatomyositis? And we've had really, truly an explosion of clinical trials. So I'm very excited to tell you about the different ones that are currently ongoing. But I would have to take you back to kind of the more mechanistic pathways of dermatomyositis. So in dermatomyositis, I would say in the past 10 years, there's been a lot more understanding because of advanced transcriptomics and RNA sequencing of tissues that we know that the interferon pathway is the primary driver of disease in dermatomyositis, similar to lupus. And the thought is that these plasma dendritic cells are secreting type 1 interferons alpha and beta, binding to the interferon receptors, and then activate the JAK-STAT pathway. And then you get the production of other cytokines through the translation and modifications of these proteins. So you get these inflammation, complement deposition, autoantibodies. So knowing that, of course, it would not be surprising to try to block this pathway in different ways. So one of those pathways I mentioned is the JAK-STAT pathway, because the interferon binds at the interferon receptor, and then the whole JAK-STAT pathway is activated intracellularly. And the first case report of a JAK inhibitor in dermatomyositis was actually a ruxolitinib back in 2014. And I remember this very distinctly because this was on Christmas Eve. I saw this come up. And this was very fascinating to me because I had also just put a patient on a JAK inhibitor at the time. And she had done very well. And I was very excited to report it as a case report. And then I saw this come out of Germany. So this was very interesting because the thought was there was a little bit of controversy when this case report came out because this patient actually had myelofibrosis and had JAK2 mutation and actually received ruxolitinib not because of their dermatomyositis, but because they were treating the myelofibrosis. But they incidentally noticed that the patient had improvement in their dermatomyositis. So there was a bit of controversy with this case report because they were saying, well, you're just treating the cancer or the myelofibrosis, and that's why the patient improved. But mechanistically, these authors came back and said, no, we know that, JAK inhibitors block interferon beta through STAT1, and it really makes sense that it could work. Now, as I told you, I was very excited when I saw that because I was so blown away by my own patient who told me that for the first time when I put her on tofacitinib, because that was what was available in the US back then, the first FDA-approved JAK inhibitor for rheumatoid arthritis. I put her on that because we knew about the mechanism of the disease, but also more importantly, she had a little bit of, synovitis. And so my patient and I decided, okay, let's try this. And within weeks, she called in tears saying, I was able to go to the beach because her dermatomyositis rash had significantly improved. And she was literally in tears. So it was a very striking moment for me that I had some almost immediate feedback from the patient that this medication was potentially working for her dermatomyositis and skin disease. Now, I think all good things happen at the same time. And, our dermatology colleagues at MGH also had noticed this and used this medication in, I think, 3 patients at the time for really skin-predominant dermatomyositis. And these patients had significant improvement. And again, all these patients on this slide actually had failed other agents. So this really led to a collaborative effort with Pfizer and me bugging them incessantly, potentially, as you might think. We need to look at dermatomyositis. I had to convince them because really at the time in 2014, they were just only excited about rheumatoid arthritis because JAK inhibitors just came on the market. But through a lot of convincing and kind of pitches or something like this, where I had to, really convince Pfizer to be like, let's please invest in dermatomyositis. So it was a collaborative clinical trial that I titled STIR, or Study of Tofacitinib in Refractory Dermatomyositis. It's a proof of concept trial of 10 patients everybody got the drug, and you can see here that at baseline, they had to get a skin biopsy, needle muscle biopsy, muscle MRI, and research blood. And they were given tofacitinib 11 milligrams XR daily, and at week 12 was the endpoint. Now, there was here, I wanted to mention, this was complete washout of any of their other oral agents. So it was really to assess the pure effects of a JAK inhibitor in dermatomyositis without being on anything else. So if they were on IVIG, they had to stop for at least 3 months. If they were on methotrexate or azathioprine or mycophenolate, they had to stop that for at least 3 months. If they were on rituximab, that had to be stopped for 1 year. At the time, this had just come on the market. So there was concern about the safety of any kind of overlap with rituximab and a JAK inhibitor. So anyway, and then in order to assess the pure effects, we also enforced a forced prednisone taper. And here, the results show of the 10 patients that overall the composite total improvement score, again, this is the ACR-EULAR validated myositis response criteria as measured by the TIS, or the total improvement score. And you can see by 4 weeks, patients had an overall improvement with a moderate improvement sustained by 12 weeks. Now, I'm not going to say that it was everybody. There was definitely heterogeneity in the total improvement score. Some patients actually had a mild response, but then increased and plateaued out, and other patients had a really rapid response by 4 weeks. And I think a picture is worth 1,000 words. As you can see here, this patient had a very angry skin, all over her V-neck, face, heliotrope, and the shawl sign is clearly visible, and here as well. And then by week 12, this had completely resolved, and you can see here a little bit left over in the neck. And then the V-neck, you can see this patient had extensive V-neck with extension up to the neck. And this had mostly resolved by week 12. And then we had pre and post muscle MRIs, and you can see that the subcu edema and also the edema in the rectus muscle also was mild, not severe, but had completely resolved by week 12. And the same here in the posterior compartment at week 12. Now, the beauty of this study, I think, was also really to understand the mechanisms behind and confirm the actions and the efficacy of a JAK inhibitor. So I performed the skin biopsies at baseline and week 12 on all patients. And we were able to do immunohistochemistry and stain for STAT1. So at baseline, you can see there's a significant upregulation here in the skin biopsies. And by week 12, these 2 patients in particular had downregulation of STAT1 on immunohistochemistry performed by Dr. Olivia Castillo-Rosen, where we did a collaboration to look at these skin biopsy slides that were performed. CXCL9 and 10 have been reported, especially in juvenile dermatomyositis, to correlate with disease activity. And these are downstream chemokines from the JAK-STAT pathway. And so we had to hypothesize that these would also decrease with treatment because we're blocking the JAK-STAT pathway. And we only had 10 patients, so you can see there's a limited number, but you can see that there was definitely a statistically significant trend of downtrend or downregulation of CXCL10 and also CXCL9 here. Some of the exploratory endpoints, I think one question is, well, if you're blocking that pathway and, I talked a little bit about the autoantibodies. Well, are the autoantibody titers, did they decrease with treatment because these patients actually improved? So we did actually look at the titers, but we did not see any significant downregulation or a lowering of the autoantibody titer. But we did notice that, when we enrolled the patients, we included patients who had skin and or muscle disease. And so most of our patients were with more refractory skin, and you can see 71% were moderate responders and 29% were minimal responders. So 7 out of the 10 were TIF1 gamma positive. Of course, we ensured that there was no cancer in 5 years preceding entering the clinical trial. And as I stated, we required washout of all immunosuppressants or steroid-sparing agents. If they had a flare coming into the trial because we had stopped their methotrexate, mycophenolate, IVIG, or rituximab, we did allow a stable dose of prednisone, but only 4 were at 20 milligrams of daily max at entry, and 3 out of the 4 were able to completely taper off all their steroids, which was great. A little bit more mechanistic information that we were able to obtain, because to really ensure what is going on, are we really down-regulating, type 1 interferons, and is it doing a good job? And so we took a deeper dive and did pathway analysis and RNA sequencing analysis on these patients. And you can see, especially in the skin of these patients, we already showed you the immunohistochemistry, the stain decreased. And also here, you can see the most highly inhibited interferons were type 1 interferons and type 2 interferons, and which was quite interesting and also confirmed what we thought. But we didn't expect that this would be almost a log-fold, 40-fold change. This was quite striking for us to see. Similarly, when we did the needle biopsies of the thigh muscle, we noticed that the patients had downregulation on this volcano plot here in this corner. We're looking for the interferon genes or interferon-related genes here, and these are IFI6 and ISG15, MX2, IFI27. Those are the commonly interferon-related genes, and those were significantly downregulated. And this also supported our initial hypothesis that this drug would downregulate interferons in the muscle as well. And I think this is how the drug is working, not only in the skin, but also in the muscle. Now here, this is not interferon, but these are complement. But we know in dermatomyositis that, the complement pathway can be important as well. All right, so this is really just confirming what I told you before. We knew that the downregulation of type 1 interferons was to be expected in the muscle. So it was great to see that it was working in the skin, in particular, as you can see with the pictures. And in the muscle, there was improvement, although we didn't have many patients who had extreme weakness. There was improvement in the muscle MRI, and then also the interferon signature was downregulated in the muscle. So based on these findings at week 12, we wanted to see the long-term efficacy and also the safety of these patients. So we actually were able to extend the study up to week 96, and 7 out of the 10 decided to continue. And in this one patient in particular, you can see by week 96, this had all completely resolved. A little bit of this red is solely like what we call poikiloderma, or damage from the skin disease. And she's still doing well on the tofacitinib currently. Another interesting observation we made, which we were not expecting at all, but we noticed that 3 out of the 10 patients had calcinosis on entry. And these patients were telling us that they felt like their calcinosis was actually improving, which was quite surprising because it was not expected. But at the end of the study, this was during the pandemic, I was like, this is really not reported very commonly. So I had a very exuberant college student who wanted to go to medical school, and I was like, here, write this case series with me. So we were able to write this up, and it was nice because we had pre and post muscle MRIs, and you can see here that this is the area of calcinosis, and by C, this was gone. And then here on the T1, you can see there's areas of calcinosis resolved. And this patient actually had extrusion of the calcinosis, and she was highly motivated and took a picture. Not as small, she's comparing it to the size of the penny, but it was extrusion and improvement in the calcinosis. Another example, was here. There was an area of calcinosis, and that resolved. And this is also in T1. And this patient, incidentally, not part of the study, also had x-rays done for another reason. And this kind of bulky area had loosened up here. So when we were writing this, there were actually at the time, I think, 2 additional kind of case series and case report. And one was in a patient with JDM, or juvenile dermatomyositis, and had received tofacitinib as well. And 3 months after, you can see how much improvement there was in their calcinosis. Didn't fully resolve, but certainly there was improvement in a juvenile case. Here, there were 3 patients, I believe, who had improvement in their calcinosis. One actually was in combination methotrexate and tofacitinib, and they were able to have resolution, as you can see, in their calcium deposits here on the digital tips. And they performed a DEX scan to show that these calcium areas of calcinosis had resolved as well. All right, so now after the conclusion of our trial, there has been a lot of certainly much more all going on at the same time. I think that's the beautiful thing about medicine and advances in medical research is that, you know, when a new drug comes on the market and there is some promise, we all want to help our patients, and that's our ultimate goal. And so during the pandemic, there was the question of, well, how many studies are there really using JAK inhibitors in the literature in dermatomyositis? So we actually undertook a systematic review with additional colleagues, and you can see there's total records of 749. The unique records screened were 313. So we looked from December 2014, which was the first case report, to August 2021. And adult DM was about 34 publications and 84 unique adult patients. This is going through our whole kind of algorithm. And if you look at the cutaneous disease versus muscle disease, the skin disease, there were 28 publications, 61 patients, and all had improvement in their skin disease. And similar to our proof of concept study, the improvement in the skin disease measured by the CDASI improved within 4 to 12 weeks of treatment. There was definitely less in the evidence for muscle disease. There were 16 patients, and 15 of the 16 had objective or patient or clinician reported improvement. So that's promising, but I think, you know, the biggest question is, we know it works in the skin. There's no question it works in the skin, but does it really work well in the muscle? Maybe it works well if you have mild muscle, but does it work well if someone has a CK of 2000 and has dermatomyositis? I think that's the biggest question for me, because we really didn't recruit patients like that in our study. And this just came out recently in August 2023, and I think this highlights this. You know, this is kind of a real world rheumatology clinic in British Columbia. You know, I think, you know, JAK inhibitors are much easier to get in the UK or in Canada than in America. And they had about 41 patients that they had collected over the years from 2016 to 2022. And they actually included dermato, polymyositis, and amyopathic DM. And they all were refractory. And you can see that the patients, not all of them continued. There were only 19 that continued the study. And you can see here that in patients who had who did not yet receive pre-tofacitinib, right? They didn't receive it yet. Their MMT8 score was 76, and then if they were on it, was 78. So there was no statistically significant difference in the muscle strength score. So they're trying to say that in this retrospective real-world clinic in Canada, that there was no significant improvement in the muscle strength. So I think this is going to be an important question to be on the lookout for. And how are we going to answer that question? I think the biggest way to do it is actually through this another clinical trial. And I'm excited to report that there's actually a phase 2 clinical trial ongoing using baricitinib called the MyoJAK study in the UK, led by Dr. Hector Chinoy and also Ingrid Lumberg. And so I believe that is enrolling, and I started enrolling during the pandemic. And this is really just adding it on to one of these agents. If you're on methotrexate, mycophenolate, or azathioprine, you would add baricitinib to their background immunosuppression. Now, a larger phase 3 study that is a multi-center international trial, I believe they're recruiting in Europe and also Eastern Europe and Europe and also in South America. And obviously the US. And we are also a recruiting site for the phase 3 brepocitinib study, which is a JAK-TYK inhibitor that is supposed to be a more potent suppressant inhibitor of STAT1, JAK-STAT pathway in this STAT1. So this will be very interesting because they're still enrolling patients and hopefully we will have a better answer, because all of these studies actually require you to have muscle involved, like muscle weakness. So we will have a better answer in the phase 3 and phase 2 study. Now, when another trial is the anti-interferon beta that's still ongoing. These are all ongoing currently. Anti-interferon beta is the phase 3 trial. It's a drug by Pfizer. And this trial is directly blocking interferon beta, but it's an infusion drug, unlike it's not an oral drug like brepocitinib or baricitinib. So we will see what will happen, and hopefully in the next couple of years, we will have some top-line results from these studies. But currently, as I said, IVIG is approved, and while rituximab was never approved, FDA approved, we still use it a lot, and we know that the patients that respond, who are they? Those patients who don't respond to rituximab are those patients who have autoantibodies. So certainly if you have someone who's not responding and they have high titer autoantibody positive myositis, definitely want to consider rituximab. So treatment considerations in refractory dermatomyositis, because we were talking about DM first, is really, thinking about and breaking it up into, is their skin more active versus muscle versus, refractory joint, refractory lung. And I think definitely refractory, so we know IVIG works, tofacitinib works. Excuse me. There is a proof of concept study using apremilast as well that was published in the past year and a half, I believe. So that is something to consider if someone is completely failing multiple agents. And then refractory muscle, I still think, we have the wealth of data is really supportive of IVIG with the ProDerm study, combination of the first-line agents, rituximab, cyclophosphamide. And I think tofacitinib, we still need to wait for a bigger phase 2-3 study. If you have someone who has mild skin and severe muscle, like that would not be my first go-to agent, a JAK inhibitor at this time. Hopefully I could give you more data in the next couple of years. But refractory joint, you have someone who has prominent joint involvement with skin and a little bit of muscle disease, then certainly rituximab and tofacitinib is a consideration. Refractory lung, again, these are the other agents to consider for active disease as well. All right, so let's move on to the next subgroup of myositis, which is promising treatments in immune-mediated necrotizing myopathy. So just to remember, immune-mediated necrotizing myopathy, the patients get proximal muscle weakness, and the statin exposure is something we ask about, and they get very high CK levels, extremely high, usually 10,000, 15,000, 20,000, or even higher. I think the highest is like 100,000. But I've never had anybody have, renal failure because of rhabdo. That's not going to happen in our immune-mediated necrotizing myopathy patients. But as you can see here on muscle biopsy, you're going to have necrosis of the myofibers and a paucity of inflammatory cells. So the two common autoantibodies are SRP and HMGCR, as you can see here. But don't forget that these autoantibodies, yes, they will have, an association with muscle histopathology of having significant necrosis. But there are other connective tissue diseases like systemic sclerosis and lupus, where you can have necrosis of the muscle fibers as well. So that should always be on your differential. If someone got a muscle biopsy and it's a necrotizing myopathy, but the autoantibodies are all negative, we really want to be thinking, does this patient actually have overlap scleroderma or overlap lupus? And of course, if their autoantibodies are all completely negative and your clinical judgment and acumen doesn't show any evidence of another CTD, then thinking about muscular dystrophy, like some of the common adult ones that we see in the United States that have adult onset and later onset is facioscapulohumeral dystrophy, which is FSHD. But certainly I've diagnosed younger people with a dysferlinopathy, like limb-girdle muscular dystrophies, and they were treated as a necrotizing patient and received multiple immunosuppressants without any significant improvement. So don't forget about thinking about other differential diagnoses. But, the really heartbreaking aspect of treating patients with immune-mediated necrotizing myopathy is that if you don't treat it early and aggressive enough, the muscle really undergoes early fatty infiltration. And as you can see here, these patients in the first couple years of disease, you're actually seeing on T1 that the muscles here in the posterior compartment has already turned into fat. Remember, you have skin on top and you have sub-Q fat, and then you have the fascia and the muscle. So this muscle looks very healthy. We say like this is like a T-bone steak, I always tell my patients, But, in your steak, you don't want to have, you want a well marbleized steak. You don't want to have a lot of fat in your steak. And here, this is a good area, but this is too much fat in the back. And that's what happens in our patients with immune-mediated necrotizing myopathy. So, and in this study, it was interesting because they actually highlighted the hamstrings and the adductor magnus were the most commonly affected muscle groups and SRP-associated immune-mediated necrotizing myopathy. So I would have to say in patients with necrotizing myopathy, the muscle MRI can be very helpful, especially if they have chronic myositis and you're trying to determine if someone still has active disease. And, they're saying, I'm a little bit weak, but I'm not that weak as much as I initially presented to you, but is there any still disease activity? And a muscle exam may be very difficult to assess that because they have fatty replacement, which results in fixed weakness. So the muscle MRI can tell us if there's active disease. And the reason I have this figure is, on the x-axis, we have the HMG-CR antibody titer. And then here we have the CK. And you can see there's a tight linear correlation with as higher you go on the titer, the CK muscle enzyme is higher. So this is really highlighting this very important association that the titer and the CK are tightly linked. And so if you do check a titer and someone has active disease and it's high, and they're very weak with an elevated CK most likely, then it's something to consider if this patient is having a flare or do I need to treat them more aggressively for their disease. So how do we treat these patients with immune-mediated necrotizing myopathy? So back in 2018, Yves Allenbach from the Myology Institute in Paris and other colleagues, here you can see here, drafted these kind of guidelines. And these are not validated guidelines, but these experts are getting together and saying, how are we going to approach patients who have necrotizing myopathy, if they're SRP or HMG-CR. And you can see on initial treatment, you have patients who will, obviously, if they're severe or not severe, will get IV steroids and then start at the same time. You see, the time is, a bit urgent here because, they can get early fatty replacement. So same time or within a month, you're starting a second or third agent, methotrexate or even rituximab, and then IVIG. And here you can see if there's no adequate response within 6 months with this first agent, you want to reconsider rituximab. It was discovered by my colleagues, Dr. Lisa Christopher Stein and Andy Mammon and also Livia Casciela-Rosen, and so we have actually quite a number of patients in our cohort who are HMG-CR positive. And these patients really respond beautifully to IVIG. You'll see that their CK will just come down very nicely with IVIG. So that's really if your patient has severe disease and they're already on an oral agent, like methotrexate, Cellcept, or methotrexate, mycophenolate, or azathioprine, they're not responding, then we go immediately and add IVIG. Now, don't forget that once you start tapering IVIG, the patient can flare, so you really want to go slowly. You don't want to just stop it like that. Now, for rituximab, we also consider using it if someone's not responding to IVIG as well. Now, how about maintenance? This is a common question we get from our colleagues. Like, what are we going to do long-term to manage these patients? So we always say about, you want them to be stable for about 2 to 3 years. And this is, also supported by this guideline here, or this, international workshop recommendations from 2018, that you would continue rituximab every 6 months and at least 2 years of well-controlled disease. And here, it says here that HMG-CR patients can require, quite a long time, many years of IVIG. So I think that's an important observation to note about IVIG and HMG-CR. Another point about IVIG, another point about immune necrotizing myopathy is that sometimes we also consider plasma exchange in these patients. And this is something to consider in someone who is very severe and refractory in their treatment response. So why plasmapheresis? So remember, I was showing you in this slide that patients can can have high HMGCR titers, and that correlates with high CK levels, and that may indicate, more active disease. So if you use plasmapheresis, you're removing the autoantibodies that are potentially, pathogenic and driving the disease, and this helps with the treatment and management of necrotizing myopathy. So about 6 patients with immune-mediated necrotizing myopathy were included in this study at our Hopkins transfusion medicine. These patients were all evaluated at our transfusion medicine, and you can see that the HMGCR patients had a significant decline in their autoantibody titer that also associated here, pre-plasmapheresis was greater than 200, post was 33, and then here greater than 200 titer, post was negative. And these patients were the best improvers or responders, as you can see. Their CK had dropped from 1,896 to 847, so a 55% drop, and this also was a 58.7% drop. So something to seriously consider in someone who is not responding to anything else. You gave them IVIG, rituximab, and they're on methotrexate, like 3 agents or 4 agents, and they're still flaring. Then you really want to consider these necrotizing myopathy patients who are HMGCR, SRP positive, that especially want to consider plasmapheresis. And after you give the plasmapheresis, you want to give the IVIG right after, ideally. Yeah. Okay. What about other future treatments and the pipeline? Well, now, this is not in the pipeline. This is an ongoing clinical trial of efgartigimod. And this drug actually will bind and block the FcRn portion and reduce immunoglobulins. So it's similar to IVIG in a sense, but you're not giving them immunoglobulins. You're actually blocking the FcRn portion and reducing the immunoglobulins that are contributing or maybe directly pathogenic to the muscle. This is currently enrolling at our site, and it's an injectable, and it's done every, it's a subcutaneous injection, I'm sorry. This has already been FDA approved for myasthenia gravis in the US, so they're really only enrolling patients because they're thinking that patients who have autoantibodies, you want to, get rid of those autoantibodies that are potentially causing the disease. And so you're only recruiting patients who are autoantibody positive who have myositis. And one last comment about HMGCR is that if someone flares, and now I always ask this, is because don't forget that mushrooms can also have high levels of statins in it. And if a patient is trying to lower their cholesterol while taking natural mushroom, like multiple pills or supplements, they can certainly flare the disease. And this was a case report of my colleague, Dr. Adler, where, they were diagnosed with HMGCR-associated necrotizing myopathy, and their CK, rapidly declined with treatment, with IVIG, and then suddenly it went up. And it was not because their disease was, not responding to treatment, but actually the patient was taking mushroom supplements, and you can see the nice rise in the CK that associated with the disease as well. So definitely, once they stopped the mushroom supplements, it came down. So want to ask about that in your patients as well. I think I have like 3 more minutes left because unfortunately, I wish I had more data about inclusion body myositis, and I could tell you that we finally found a cure, and we unfortunately have not, and there's still a lot more to do in IBM. However, I can tell you at least there's some exciting trials that are ongoing. All right, so why is IBM so difficult to treat? Because certainly there have been some, multiple trials in the past looking at, IVIG, methotrexate, and these all don't work. And that was really trying to target the, inflammatory features of patients who have inclusion body myositis. And that has not worked at all. So in the past, recent years, the focus has turned into trying to block degenerative features that we see on muscle biopsy. So the degenerative features we see on muscle biopsy are these rimmed vacuoles, mitochondrial pathology, and protein aggregates. As you can see here, all these protein aggregates. And the thought is, well, why don't we remove those protein aggregates and see if this helps and improves patients' muscle strength with IBM. So one of them was actually arimoclomol in inclusion body myositis. And some of the initial proof of concept studies showed that patients, when they take arimoclomol, it increased the heat shock response. And that is very important in clearing all those protein aggregates and misfolded protein, because this is very commonly seen in all IBM muscle biopsies. So because of this, Dr. Machado in the UK and other colleagues, including we had a site at our Hopkins Myositis Center as well. We enrolled patients in a multi-center clinical trial to receive arimoclomol. And you can see here the treatment period, and either you got placebo or arimoclomol 400 milligrams 3 times a day. And unfortunately, as you can see here, the trial did not meet its primary or secondary efficacy endpoints. And the primary endpoint was really the IBM-FRS, which is a functional rating scale, and it wasn't the 6-minute walk test or anything like this. So this was very big disappointment, and this paper actually just got published, I believe, like November 2023 in Lancet Rheumatology. So this was a bit of disappointment, but in any clinical trial, I think we learn a lot, and it's never a waste. You know, it gives a lot of insight to what we can target next and how can we do things better. And I think patients also appreciate that we are trying to eventually, hopefully, get some type of treatment for our patients. So unfortunately, the arimoclomol study was a negative study, but we currently have, there was a lot of excitement. An ongoing trial right now, as we speak, is this some exciting data that was presented at our global conference in myositis in 2022. ABC008 is a first-in-class humanized monoclonal antibody that binds to KLRG1. And the company that makes it is Adcuro. And as you can see in patients with inclusion body myositis, the thought is that these KLRG1 positive T cells invade and destroy the muscle tissue. But in patients who don't have myositis, this is all not even present. So based on this and some promising phase 1 clinical trial results, a phase 2 trial is ongoing, and we are a recruiting site as well for this clinical trial. So there's a lot of excitement about this. This is an injectable medication. So hopefully we will hear some details in the next several years. The next agent that also has an ongoing trial, the proof of concept was a phase 2 trial done in France by Dr. Olivier Benveniste. And you can see the primary outcome was the quadriceps strength. Unfortunately, it was a negative when you look at the primary outcome. The secondary outcomes on imaging, these patients had less fatty replacement and improved 6-minute walk test. And I think that's a win. And so there's now a phase 3 multi-center international study of sirolimus in inclusion body myositis as well. And this is we are a recruiting site for this as well. So, you know, a lot of our IBM patients are excited to enter these clinical trials, and hopefully we'll have some more exciting data. So I think there's a lot that I talked about, and hopefully this is a nice summary slide. I was able to work with some amazing colleagues to write a recent review article that just came out in the Lancet of Rheumatology. I think it literally just came out 2 weeks ago. But it was a great international collaboration with my colleagues in the UK and Japan and Ireland. And we really try to take a deep dive into what has been going on in the past years in this vast space of myositis. And as you can see, the therapies are tremendous. We did not have this much clinical trials in our space in a very long time, never. And so, as I told you before, dermatomyositis I think is most exciting because there are multiple clinical trials that are ongoing there, and we have multiple pathways that we're blocking. So we talked about baricitinib, tofacitinib, brepocitinib is in phase 3. There's also daxdilimab, which is actually blocking a pathway of the PDCs or plasma dendritic cells, and I told you about interferon beta infusion. And of course, we have these CAR T cells. This is emerging as well, and we are involved in this as well in the U.S. And then we talked about these FcRn inhibitors. There's 2 of them. Those are 2 separate clinical trials with different pharmaceutical-sponsored clinical trials. And then we know about IVIG from the PRODERM trial, but there is also a subcutaneous IgG clinical trial that is ongoing as well. And here is a complement inhibition. We were a recruiting site for this trial, but this trial has completed. And so we will see what the final results are for that. And in green here, don't forget about IBM. That targets those specific T cells, the KRG1 inhibitor. So we will hopefully see what is going on in these different subgroups of myositis and the significant number of promising treatments in myositis as well. All right, these are my acknowledgements, and I think that's about it. Thank you so much for your attention.
Thank you so much, Dr. Park, for such an enlightening talk. Now she is joined us online here today for this conference, so if anyone has any questions in the audience.
Hello.
Everybody hearing me? Yes, Dr. Pike, a very enlightening talk by you and a very comprehensive talk about myositis and its variants. I'm Dr. Flaq from Shaikh Zayed Hospital, Lahore, Pakistan. I have a question that the modalities of treatment which you have just suggested, in our setup, we are using up to the stage of rituximab in severe non-responsive inflammatory myositis, especially polymyositis and dermatomyositis. So the next level, if we do not have treatment, and as we know that there are two variants, outcomes we usually see, one is non-responders and the other is late responders. So thinking about the bad prognostic indicators, what's your take that in our setup where guidelines we usually follow the ACR's guidelines or EULAR or even the APLAR's guidelines, do you think that tofacitinib or baricitinib, the JAK inhibitors, will play a role in the setup of our country, Pakistan, a third world country? Thank you very much.
Yes, thank you so much for the question. And I apologize for my voice. I've lost a little bit of my voice through a cold from my son. But anyway, so the tofacitinib, I do think there is some role. And I think I'm hearing a little bit of an echo. Do you hear the echo?
Can somebody reduce the volume?
Is that okay?
Yeah, it's okay.
It's okay.
Okay. I'm going to lower my audio. Okay. So yes, so tofacitinib, I do think there is a role. I've had colleagues reach out from other countries as well, internationally, about using it. And there is some data in small case series that could be definitely helpful in different international populations. So I think that there will be a role, but especially in dermatomyositis. And for the skin, I think it works beautifully for the skin. There's no question. We're using it a lot, especially in skin predominant dermatomyositis right now and in different countries, off-label. So I think that's definitely one area in myositis that I think it works. I think the biggest question is does it work with muscle, concomitant muscle disease? And I think the question mark is still out there. Even in our small study, we didn't recruit that many patients with muscle disease. There was definitely improvement in the muscle strength, but I don't have enough numbers in our own cohort to say that it works 100%. I'm not that confident. But there are other studies that are in Asia and in Europe that it does work for muscle. And so I think the phase 3 clinical trial using brepocitinib will be very helpful to answer that question. I know they're finishing enrollment in a couple of months, so hopefully that data will come out probably in the next year, hopefully. And it's a registration studies. The FDA has approved the go-ahead to do this study, and if this study is positive, it will get FDA approved in the United States. They have been recruiting patients internationally in Chile and also in America, and a couple in Asia, in Korea and Japan, I believe. I do not believe they're recruiting in Europe, but only in Poland and that area, but not in like the UK or France. So I think hopefully that bigger phase 3 will inform the true efficacy in a phase 3 trial.
Thank you so much. Thank you so much.
Dr. Pike, thank you so much for such a informative presentation, encompassing all of the subject very, very clearly, and it was very illuminating for me personally. I'm Dr. Tafazul Mahmood. I have a question that there is myositis associated with other connective tissue disorders such as scleroderma and many others. And there is an overlap syndrome when myositis is coexistence with other connective tissue disorder. How do you differentiate between the two?
So, I'm sorry, but thank you for the kind remarks. So for overlap connective tissue disease, it's still a black box, I completely agree, because there's no consensus criteria or diagnostic classification criteria or diagnostic criteria for overlap connective tissue diseases. I know there have been some groups out of France, like Dr. Troyanov, and recently we're going to have our global complex myositis conference actually March 10th, 11th, and there's a special session about having, by the French group in Montreal, trying to start to develop a classification schema. And I know that in the scleroderma world, there's also been interest in trying to at least decide a minimal definition for muscle involvement. But in my mind, I see it as two separate. And I think working in two separate areas, you know, more in the myositis area, more a little less in the scleroderma world. But in the myositis world, I feel like the myositis experts are currently saying if someone has definitive myositis and they meet ATR criteria, and they have a little bit of features of ring nose or a little bit of features of puffy fingers, they'll consider that for myositis. But I think in the scleroderma world, or maybe I am in the field of saying it should be more specific. Definitive criteria for scleroderma, and then also definitive criteria for myositis. Maybe the ATR criteria for both. But I do think that there is a spectrum. So someone's full-blown scleroderma, full-blown myositis, and then there's a different spectrum. But I do think their type is different. At Hopkins, I see patients with myositis and dermatitis, but all of the patients who have overlap scleroderma are shuffled to me because of my research interests. And it's very clear to me that patients who have definitive scleroderma and myositis together have a different phenotype and outcome. And we recently just got a manuscript that got accepted and talked about scleroderma. Especially I want to highlight, for example, like the coup positive patients who have scleroderma and myositis, definitive criteria. We did a lot of heart involvement in myocarditis. Just had several patients get a defibrillator. I think this is something we didn't see in the coup positives who only had myositis and did. Thank you very much. It's an honor to be here. Thank you.
We have one more question.
One more question. I'm Dr. Shaikh Zayed. I'm a rheumatologist in South Punjab, Pakistan. It was very elaborative talk on inflammatory myositis. Thank you for giving us such a nice talk. And my question is, are there any guidelines for the workup in patients with dermatomyositis for the workup of malignancies especially? And what is your practice in cases of the dermatomyositis to work up for the malignancies? And which kind of the malignancies you see very commonly? Thank you.
recently in the past year and a half in Nature Review Rheumatology, I believe. The patients who are TIF1 gamma positive, that autoantibody, if they're positive for that, if they have obviously dermatomyositis, and they did it by a tier approach. So if those two autoantibodies, TIF1, they're not responsive to treatment, they have dysphagia, those kind of clinical features would put you at the highest tier of being worried about cancer. And then if you have HMGCR necrotizing myopathy, or even anti-synthetase was a little bit less, risk for malignancy. So that's one aspect, providing like consensus criteria for how we're going to approach these patients. Second is my colleague, Dr. Christopher Meckley, has been really interested in cancer, the intersection of cancer and myositis in our center in myositis. And so he has looked at all of our entire cohort. And in the past, we've always ordered baseline CT, chest, abdomen, and pelvis, and anybody who was coming to our center as a new patient. And we always wondered, does this even really pick up a lot of cancers? I think, the past 14 years I've been at Hopkins in the Myositis Center, I think I've picked up maybe 2 or 3 cases. So that was really the question, like, does this practice, this clinical practice of ordering CT, chest, abdomen, pelvis really help us? And so when we looked back, it looked like it didn't really pick up that much as we have suspected, but only in those patients who are really TIF1 gamma positive. And so I think in those high-risk TIF1, NXP2, in those patients, we're worried about cancer, definitely want to do the workup at baseline. And then after that, we always say just age-appropriate malignancy screening. And then the key, in my mind, and I see this more frequently, is if someone is not responding to at least 2 or more agents and they're refractory to treatment, then we really push forward with PET scan if we can. But even in the United States, PET scan are so hard and expensive to get approved. If that's not possible, then we just do the whole body CT scan again. But yes, it's a difficult.
We will be taking
question.
one last question.
Yes.
Dr. Paik, thank you very much. I just saw that it's 4:45 in the morning at your place.
Yeah.
So
yes.
Thank you so much for being here for us. A very enlightening talk, and your presence and answering our question. On behalf of Rheumacon and Department of Rheumatology and Immunology, Shaikh Zayed Hospital, we thank you a lot. And hope
absolutely.
to see you
My pleasure.
next time
Thank
as
you.
well.
Thank you.
Thank you. See you again.
Okay. Bye-bye.
Thank you so much, Dr. Paik. Since we're quite short of time, we would like to now proceed for lunch, and we'll be back in about 20 minutes. Guests of honors, please join us in this dining hall, and the rest of the participants can go to the back dining hall.
Hello, everyone. Welcome. I'm glad to be virtually talking again at your Pakistan meeting. I hope people are well. For a change, I'd like to talk about an update on Raynaud's phenomena. And although your country is warmer than mine, of course, you all see Raynaud's as well. These are my disclosures. So our objectives will be to understand who should you work up for secondary causes of Raynaud's phenomena, and how should you do that workup? How do you treat your patient with secondary Raynaud's? What are their complications that you will have to identify and treat? You should develop a treatment algorithm if you don't have one already. And it's really important that you start looking at the nail beds in the for capillaries being dilated or dropped out or hemorrhaging. And that's important to rule in or suspect secondary Raynaud's. So Raynaud's is a few percent of the population. It is more common in colder countries. And almost everyone with systemic sclerosis has Raynaud's, and it's often more severe in that group of patients than in primary Raynaud's. When we think of it, it's either primary or secondary. So primary, we can also call idiopathic. So it's not associated with another disease. Secondary is associated with other diseases, especially in a rheumatology congress, we're thinking of connective tissue diseases, but it can be vasculopathy of other sorts, from vasculitis, occupational, like hand vibration injury, people that work on a jackhammer doing road work, things like that can also be considered secondary because there's a reason for the Raynaud's. If we think of idiopathic Raynaud's, in A, you see the pallor, well demarcated. It's circumferential around the finger. You also see in the second and fourth fingers the redness, and you can see on B that the fingers now got cyanosis. That third finger down here is now becoming blue. You can see it on panel C in the feet, so the toes, it's more common in hands than feet. And in panel D, this is a patient with decades of Raynaud's, primary, but you can see a lack of wrinkling, mild, minimal, sclerodactyly distal to the PIPs. You can see that kind of change in other conditions such as long-standing diabetics. Where the tissues have become a little bit shinier, a little bit tighter. But sclerodactyly, that is from primary Raynaud's, will never go really beyond the PIPs. So as soon as you're getting sclerodactyly more proximal, we're going to think of sclerodactyly from diseases such as scleroderma. So it's about 3% of the general population, primary Raynaud's, and in families, that's 3 or 4-fold times higher. And if someone has systemic sclerosis, then they can have primary Raynaud's in their family at a higher rate as well. So Raynaud's increases the chance of Raynaud's. People with a connective tissue disease, including scleroderma, also increase the chance of Raynaud's. And so really that's a good pearl to remember, that if you have a patient, say with Sjogren's, they have a higher chance of family members having Raynaud's, even if it's primary. Some of the mimickers are really not good mimickers because Raynaud's should have pallor. And if a patient's never had blanching or pale fingers, don't consider it's Raynaud's. So complex regional pain, they might have puffy fingers, they might be cold, there might be a change in sweating, they might go blue, but they don't go white. Acrocyanosis would be distal cyanosis. Exaggerated cold response. Many people can have mottled hands or feet in the cold. Peripheral vascular disease usually won't have pallor, so they'll be cold. Sometimes it is ischemic, but it's not with pallor, but it's not usually looking like classic Raynaud's. Pulses will be reduced or absent, etc. Carpal tunnel can have numbness and tingling, but it's not obviously Raynaud's. Chilblains are perniosis, are cold changes, usually distally on toes and sometimes on fingertips, which may or may not be associated with Raynaud's. So a person could have Raynaud's and chilblains or just chilblains. Trench foot is really more like frostbite, where there's cold changes. Frostbite, though, you could have one finger that was really damaged from cold, and that finger might later get Raynaud's, but frostbite itself is not Raynaud's. And then you can see some of the other mimickers, but mostly it's the history that sounds different than that triphasic change of Raynaud's. So how do you rule in or rule out secondary Raynaud's? So you would want to do a history on Raynaud's. Is it mild, moderate, or severe? Is it complicated or not? So if it's quite severe and complicated with digital ulcers, you're going to think of a secondary cause. You're also going to ask about a review of systems for connective tissue diseases, and you can think of the diseases lupus, Sjogren's, scleroderma, etc. Or you can just go head to toes, any dry eyes, dry mouth, hair loss, rash in the sun, etc. Inflammatory arthritis, and go down your systems by anatomically. On physical examination, you want to look at the hands a lot. So are there dilated capillaries? Are there digital pits? Does the patient have puffy fingers? You either want to do nail fold capillaroscopy, but for most of you, that's not practical in clinic. So you can use an otoscope, ophthalmoscope, dermatoscope to just magnify periungual area. If Raynaud's onsets in older ages, we think of a higher chance of secondary, and it's actually at both ends. Children less than the age of 12 who get new Raynaud's, it might be secondary, things like systemic lupus erythematosus, or over the age of 40, especially way older years. If you're 70 years old and you get Raynaud's, there's usually a reason for it. And then you want to know, should you investigate patients if you get any hint of secondary? So if there's no hint of any secondary Raynaud's, I would not investigate them. So usually then no blood work is necessary, because you know that if someone has primary Raynaud's and you do an ANA, there's a high chance of it being positive falsely, because positive ANAs are so common. They're up to 3 women in the North America now have a positive ANA. And obviously only 1 in 1,000 has lupus or connective tissue disease. So you really do want to look at the nail beds, but you don't want to do an anti-nuclear antibody or the complete blood count or kidney function, chemical urinalysis, inflammatory markers. You don't want to do any of that without a suspicion. So if you have a suspicion, you'll do minimal blood work or more. If there's no suspicion of secondary, don't do the labs. So these, you can see dilated capillaries. So at the blue arrow, you're looking at just a vascular change on the cuticle. And if you follow it back, you can see some capillary change, and you can see it more on the other finger I'm showing you. And you can see a little bit of shininess. And when you look at this patient, you'd say, oh, lots of capillary changes, especially on the longer finger that I'm showing you. So you'd say, wow, that looks like secondary Raynaud's. And indeed it was. But if I show you the rest of the picture, this patient has rheumatoid nodules. So this was a man with decades of rheumatoid arthritis who then developed new Raynaud's after about 30 years of rheumatoid arthritis. So this is a nice algorithm, and if you want, you can certainly take a picture of any of my talk, but including this. So it really helps you to understand. So if age of onset is, say, less than 15 years or greater than 40 years, you might consider other a workup. You might consider what it might be, connective tissue disease, and there are the labs you might consider. Vasculitis, again, having other hints. Maybe you're seeing a vasculitic ulcer on someone's leg. Cryoglobulinemia, if you're seeing that they're always having distally blue feet and neuropathy. Vascular imaging, if you think it's, say, thromboangiitis obliterans from a smoker, formerly known as Berger's disease, etc. So you want to also say, are there any red flags on the history? So symptoms of connective tissue disease, occupational injury, but then you don't do the blood test workup. You say it's secondary to their occupation. Physical exam, especially the nail fold capillaries, but puffy fingers, etc. So this is just an algorithm you might think about of who would you work up. I received this slide a long time ago from Chris Denton, and it's showing the vasculopathy and systemic sclerosis, where you can see proximally on the fingers the digital arteries on both sides of each finger are mostly gone. And this is a vasculopathy that's also similar to what's happening in the pulmonary arteries, where you're getting proliferation for pulmonary arterial hypertension and scleroderma patients. You're getting proliferation of the media, but you're also getting endothelial changes and intimal changes. So it's very similar, but you don't have to have pulmonary hypertension in scleroderma, but about 15% of the patients have that, but almost all have Raynaud's. So here's some signs of secondary from my clinic that I've taken pictures of patients recently. So in A, you see the dilated capillaries and some hemorrhage. And again, if you see them on the cuticle of the one finger, if you follow backwards, you'll see it occurring in the periungual area. B is a patient with puffy fingers. You can see Raynaud's of that second finger, and she has systemic sclerosis. And C, that's a patient with early systemic sclerosis and puffy fingers. Puffy fingers can stay puffy, though, indefinitely in scleroderma patients with limited cutaneous systemic sclerosis, or they can go tighter over time. And you can see the telangiectasia on the patient D, especially on the lips. Here you can see complicated Raynaud's. So in A, you can see the Raynaud's different colors, but you can see on the palm telangiectasia. You can see there's tapering of that third finger with the Raynaud's in A from old digital ulcers. On B, this is a patient with dermatomyositis goitrans. You can see dry mouth from Sjogren's. You can see hair loss, alopecia from lupus. This patient with very terrible changes here on her toe and blue, and she's lost her nail and an ulcer. So secondary Raynaud's. This patient could have had systemic sclerosis, vasculitis, what have you. In F, you can see a patient with calcinosis that's been opening up from a patient with dermatomyositis. And in G here, this is a patient with systemic lupus erythematosus, but it's hard to tell. It's mostly sparing the PIPs, the rash, but if a rash is bad enough with either dermatomyositis goitrans or systemic lupus, a rash on the hands and fingers, sometimes it's hard to differentiate because it will stop sparing the knuckles or it will start involving the knuckles if it's lupus. So just showing you some of the secondary causes. In H, this is a patient that I'm seeing for severe, but she had primary Raynaud's, and a year later she came back with severe livedo reticularis. There was no use of a heating pad, just livedo has come. So she's obviously evolving into secondary Raynaud's of some sort. And this patient I here has leukocytoclastic vasculitis with her Sjogren's syndrome. So if a person has Raynaud's and it's Raynaud's, what is the chance of getting a connective tissue disease? So it'll be increased if the patient has other signs or symptoms. If there's a positive ANA, especially a centromere pattern. If nail fold capillaries are abnormal. So if someone has either a positive ANA centromere pattern or abnormal nail fold capillaries, 1 in 3 will have connective tissue disease within 5 years. And especially if it's centromere positive, and within 5 years, 1 in 3 will have limited cutaneous systemic sclerosis over the next 5 years. So that's why we need to kind of look at who do we investigate and who don't we. And Raynaud's is common in our diseases. Primary Raynaud's, about 2 to 6% of the population, depending on the studies you read. And Raynaud's is about 1 in 5 patients with rheumatoid arthritis, but we don't always ask. In systemic lupus, it's about 1 in 4 patients. Sjogren's, 1 in 3 patients. Systemic sclerosis, almost everyone will have Raynaud's. And inflammatory myositis, at least 1 in 3 will have Raynaud's, especially polymyositis. So how do we treat Raynaud's? So most people don't need pharmacologic treatment. That's different when we talk about systemic sclerosis, but even in systemic lupus erythematosus and other connective tissue diseases, most won't need prescription medications. So cold avoidance, stopping smoking, so common sense, avoid psychological stress, avoid the cold. Calcium channel blockers would be the main treatment if we need medications. There's topical nitrates, angiotensin II inhibitors such as losartan can be helpful. Fluoxetine as one study. PDE5 inhibitors we use a lot in systemic sclerosis, prostacyclins such as iloprost, which is PGE1. Alpha blockers, although they can certainly give hypotension, but say if someone has BPH, a benign prostatic hypertrophy, and needs an alpha blocker for that and happens to have Raynaud's, it might help their Raynaud's, but that's not too many people that we're treating one drug to help both problems. And ACE inhibitors really don't work in Raynaud's. ARBs do, but ACEs don't. Okay, so what can I expect from Raynaud's treatment? Not a lot. For calcium channel blockers, you can reduce the frequency of attacks by about 30% reduction. So if someone has 10 attacks a week, maybe they'll have 6 attacks or 7 attacks a week. Often the severity of each attack and the time or duration of each attack are unchanged, and side effects are common: hypotension, flushing, headaches, a little bit of peripheral edema, especially if you're using a drug like amlodipine. A lot of people will have a little bit of edema in their around their ankles. And a clinical pearl is, if you increase the dose of the calcium channel blocker, you might get more benefit. So nifedipine, long-acting 30 milligrams, if you double to 60 milligrams, if it's tolerated and there's still a lot of Raynaud's, you might get more benefit, or even 90 milligrams. But side effects can increase as we go up on the dose. So this is just showing from our recent systematic review that we published in November. If you look at PDE5 inhibitors, so sildenafil, drugs like that, this is what you might find: a reduction in the frequency of attacks, again, from 1 attack a week less up to 5 attacks a week less on average. The duration of attacks might go down by at most 10 minutes. The severity of attacks might not change. It wasn't statistically significant, but if 10 is the worst, 0 is no severity. It might go down 3 points, but that's at best not statistically significant. It might not change at all. Pain might go down on a pain scale of 0 to 10. So if it doesn't even go down 1 point, it's really not relevant and it's not statistically significant. And patient global, though, can reduce, which is interesting, that's usually related to pain. The patient global can go down anywhere from 4.5 points on a scale of 0 to 10 to maybe just 2.5 points. So although it can be effective, it is modest benefit, and we use it when calcium channel blockers fail and bad Raynaud's, such as systemic sclerosis. So these are some of the drug targets that you would think about that might help Raynaud's, and this is not too different from somehow when we look at treatment for pulmonary arterial hypertension, but it's not identical. So those are some of the things you might think about. So in a recent review, we looked at management of Raynaud's phenomena, and we've also polled experts in systemic sclerosis. So this is looking in scleroderma, and now looking for both Raynaud's, and then on the next group for digital ulcers. So calcium channel blockers, the pyridine kind, so that is looking at nifedipine, amlodipine, felodipine, drugs like that. If not, PDE5 inhibitors, adding or switching depending on tolerability and benefit. And if not, iloprost would be third line. There's other ancillary treatments that might be used. Green has more randomized controlled trial data. A yellow, just maybe one randomized controlled trial or mixed results. And red, anecdotally being used, but no trials, just case series. And you can see in digital ulcers, it's kind of the same idea, other than bosentan, an endothelin receptor, can decrease new digital ulcers by about 30%, but it does not heal ulcers. Healing for digital ulcers would be calcium channel blockers, intravenous prostanoids like iloprost or epoprostenol, and then looking at some of the other drugs. Preventing ulcers, we'll talk about shortly, but bosentan would be one treatment. So there are unproven treatments, but certainly a digital or more radical sympathectomy surgical has no randomized trials, but certainly can help patients who have severe, like say, gangrene of a couple fingers. A sympathetic block can be helpful. So that's a stellate ganglion block for your hands up in your neck, or a lumbar sympathetic block if your feet are bad. Botox injections has lots of negative studies and some positive data. We don't have really where to use it, how much to use, but they go to the digital arteries of the digits that they want to block. Glucocorticoids do not help. Anticoagulation does not help Raynaud's, but if there's severe recurrent ulcers, I would think of antiplatelet drugs just to get better blood flow, like aspirin. But warfarin, unless if it's APS or things that isn't used. Biofeedback actually has some positive data, only in very few patients who can learn to control their temperature of their fingers by biofeedback and improve it. If we did a systematic review many years ago of complementary and alternative medicine, I think now there's 22 randomized controlled trials, and almost all of them are negative. Obviously, therapeutic gloves of any sort can be helpful. So in other words, wearing gloves that compress your fingers might help. Wearing mittens, it keeps your fingers even warmer, but most of the complementary medicine doesn't work. Lots of small trials where placebo is as good as active treatment. So what does EULAR recommend for Raynaud's? The dihydropyridine, sorry, I said it wrong earlier, dihydropyridine calcium channel blockers, that's nifedipine, drugs like that. If not, intravenous iloprost or other prostanoids, and also considering the PDE5 inhibitors such as sildenafil or tadalafil, and that's sort of graded to worse Raynaud's. Iloprost or PDE5s would be when they're failing calcium channel blockers. Here is one of our older treatment algorithms. Mild or more severe Raynaud's, interestingly, they went through the same algorithm, calcium channel blockers, and they would add or switch a PDE5 inhibitor to a PDE5 inhibitor, depending on tolerability and benefit. Then maybe they would go, if it was more severe, to prostanoids like intravenous iloprost. So they said if people are mild and going down the algorithm, they're probably actually getting severe. Complications, severe ischemia could be acute or subacute, even chronic. Digital ulcers, osteomyelitis or deep infection, ulcer infections, auto or surgical amputation, digital pits or tuft resorption, where you're losing some of the pulp of the fingers, and tuft resorption. So in A, you can see the ulcer, and in the other finger that you see, well, she's lost some of the pulp, so that finger is getting shorter. In B, looking across the top, you can see the pit. In C, you can see amputations from a patient who had severe ischemia from a systemic lupus, systemic sclerosis overlap. On D, you can see gangrene, and if you see it in one finger, we're worried about other fingers, so you can see the second finger is turning dark as well. And in B at the bottom, you can see some of the desquamation, and the patient has developed pits as well, that you can see the one that I've marked on the upper hand, quite easily seen. So here, this is a patient I'm currently following. You can see the severe tuft resorption. She's losing fingertips. There's no padding, and she's losing the bone of the fingers on the x-ray, acroosteolysis. You can see almost all the distal phalanges have disappeared. And this patient is having recurrent ulcers. She's lost lots of her fingertips and continues to have nail lifting, severe pain, and ulcers as she is getting her acroosteolysis. We have to worry about as well as things become possibly infected, to treat infection. So for severe ischemia or threatened gangrene, it's serious. You want to maximize the calcium channel blockers, such as high-dose nifedipine, if tolerated. You want to add or switch to iloprost or use a PDE5 inhibitor. If you can't get iloprost, you might think of Flolan, epoprostenol. Elprostadil, PGE1, doesn't work as well, but could work to get someone out of the crisis. Consider stellate ganglion blocks. You want to control the pain. You want to lubricate those ulcers, not just always dry them out, but you need to treat infection. You might give a barrier like topical antibacterial cream, just to give a barrier for a patient. You might want to sometimes cover it if they're out in public. and infection, you need to treat, whether it's oral or intravenous antibiotics if infection is present, and sometimes it's tough to tell. So the other clue or hint about digital ulcers in our systemic sclerosis patients is they're often multiple. So you can see the ulcer in the top hand there, a little ulcer that's healing. You can see in the second finger of that top picture that she's already lost some tuft from a past ulcer. She lost some tuft or pulp as well at her thumb. On the lower one, you can see 2 ulcers active at a time here. So often they're multiple active in patients. Another clinical pearl is if someone with systemic sclerosis or anyone with Raynaud's who is getting more toe ulcers than hand ulcer, finger ulcers. Think of peripheral vascular disease superimposed, microvascular or macrovascular. Macrovascular we can treat. We can possibly get an angioplasty. So look and feel for the pulses. And if it's microvascular, you can at least treat traditional problems such as high cholesterol, type 2 diabetes, etc. But if it's more in the feet than on the hands, there's vascular disease superimposed, in my opinion, micro or macrovascular. So this is what I do for digital ulcers. So the data mostly are not very good data on our early lines of therapy. So for healing, anything that will vasodilate in Raynaud's might be helpful. Calcium channel blockers, prostaglandins like iloprost, or sildenafil or tadalafil. For prevention, so the healing also could help for prevention, but for prevention, drugs like Bosentan, which in Pakistan you have generics that are far less expensive than in North America, but Bosentan does not heal ulcers. It reduces new ulcers by about 30%. Moderate dose atorvastatin, 40 milligrams a day, in one randomized control trial also decreased new ulcers by about 30%. So statins are also inexpensive and you might want to consider them, but they're not part of any guidelines, just one trial saying in scleroderma they prevented new digital ulcers. What does EULAR recommend for digital ulcers? They say calcium channel blockers. After that, either intravenous prostanoids such as iloprost, and then Bosentan to prevent new ulcers. The other endothelin receptor drugs didn't work, and the other prostacyclins, such as treprostinil, didn't seem to work in one trial, but it was probably worked early, but the healing of ulcers over time was no different. These are some of the systematic review we did years ago showing that you can try to prevent ulcers with nifedipine if you look on the lower part, but it's only studies within Raynaud's trials of systemic sclerosis patients. You can see how small the N was with those with ulcers. So not very good data, but certainly favoring treating ulcers as opposed to not helping ulcers. Sildenafil again, Bosentan will reduce ulcers but not heal ulcers. So the prevalence of ulcers and scleroderma is at least half the patients. So in this study, it was 58%, but about half our patients have digital ulcers ever with scleroderma. If they have one on any day, they often have multiple. So the mean or median number of ulcers, if they come in with them, is 2. But you can have from 0, of course, to many, or from 1 if they have ulcers to many. And 15% of patients on any day with scleroderma will have a hand ulcer. Not always fingertip, it could be ulcers from flexion contractures at their PIPs, but they're very common in scleroderma. So for our 15% rule, everybody with scleroderma almost has Raynaud's. 80% have GERD and or dysphagia. Half have digital ulcers ever, 58% in that other study. This is our systematic review where it was about half. And any day, 15% have a current finger ulcer, of which 15% ever are complicated. Complicated meaning the ulcer has gangrene, osteomyelitis, needs to be amputated, etc. 8 to 15% of your patients have pulmonary arterial hypertension. In early diffuse, 10 to 15% will have scleroderma renal crisis, but just 3% overall of your patients will get renal crisis. 1 in 3 will have interstitial lung disease or mild or moderate or severe pulmonary fibrosis, but in half those patients, it's clinically relevant, 15%. 15% will have inflammatory arthritis, 15% will either have a myopathy or myositis, and 15% will have Sika or Frank-Sjogren syndrome. So it's just a good little 15% rule way of thinking about what's important for our patients to screen for, and especially the bolded ones that I'm showing because we're talking about digital ulcers and Raynaud's. I've adapted this slide from Chris Denton as well. So you want to use your digital ulcer algorithm in helping your patients. So improve blood flow, so vasodilators, give analgesics because often these ulcers are quite severe in pain. Consider an antiplatelet drug such as aspirin. Use antibiotics only if there's infection. Parental prostacyclins like iloprost, advanced vascular therapies such as bosentan to prevent new ulcers, or sildenafil to treat or prevent ulcers, statins, high dose atorvastatin 40 milligrams or medium dose to prevent new ulcers. Debriding an ulcer if it's infected or if it's covering over but deep inside hasn't started healing. So you often have a multi-targeted approach and an approach with other people helping you, such as possibly plastic surgeon, vascular surgeon, orthopedics if we need an amputation. Some wound care nurses can be very helpful to our patients. So in conclusion, Raynaud's is very common. Idiopathic or primary Raynaud's, about 3% of the population. It's usually mild. Even in secondary Raynaud's, it's usually mild, such as Sjogren's or lupus. And vasculitis or severe lupus, you might have vasculopathy, gangrene, etc., that needs treatment. Raynaud's and scleroderma often needs treatment. Pain control is important if people have digital ulcers. Digital ulcers occur in about half our scleroderma patients, both limited and diffuse, often in longer standing disease where vasculopathy is getting worse. Then it's often worse. They can be cyclical. You can have 3 ulcers this rainy, damp season and none for, the next 2 years. So they can be quite cyclical. We want to heal digital ulcers by increasing blood flow. We want to prevent new ulcers by either drugs that increase blood flow or possibly bosentan. If there's an amputation of a fingertip ulcer, chances are you're going to have another amputation, at least a 1% chance every 6 to 12 months of further amputations, because the vasculopathy is quite widespread, of course, in our patients, really involving in general all digital arteries of hands and feet. So I can't do my work without funders and really without thanking the patients as well. So with that, I thank you for your attention.
Hello, 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 hello. Hello, hello, hello.
Ladies and gentlemen, colleagues and worthy guests, please settle down as we begin with our third and last scientific session. We begin this session with a discussion on challenging scenarios in psoriatic arthritis. Psoriatic arthritis presents some myriad complexities that often push the boundaries of our understanding and management strategies. Our speaker will shed some light on strategies to navigate the challenges posed by psoriatic arthritis. Please join me in welcoming Dr. Muhammad Yasir Imran. Dr. Yasir is a consultant rheumatologist and assistant professor in Department of Medicine at King Edward Medical University, Lahore. Sir, please come on the stage and present your talk. Thank you so much. Dr. Yasir.
Assalamu alaikum, Bismillahirrahmanirrahim. Today's talk is challenging scenarios in psoriatic arthritis, comprehensive explanation of difficult cases and innovative approaches. First of all, thank you so much for inviting me for this talk. I want participation from PG trainee. कोई हैं यहाँ पे PG rheumatology के? थोड़े से आगे आ जाएं हैं, आपकी पार्टिसिपेशन चाहिए होगी इसमें ना। इस तरह के केसेस हम वार्ड्स में ओपीडीज में देखते हैं। Case scenario 1. A laborer of 46 years old male presented with itchy papulosquamous rashes on the face and upper extremities from last 6 months. No history of joint pains, photosensitivity, or any systemic involvement. Like there is no respiratory tract involvement, no renal involvement. He was treated with ultraviolet phototherapy but no improvement. Rashes extended to the abdomen and lower extremities also over the period of 4 months. This is a picture of patient. On the basis of these rashes, diagnosis of psoriasis was made and he was treated for psoriasis. After phototherapy, methotrexate was added but no improvement. Later on, anti-TNF inhibitor was also tried but no improvement. बल्कि वो कहते हैं कि जूं-जूं दवा की मर्ज बढ़ता गया. Rashes extended over the period of time, also involved abdomen, back and extremities. तो इसमें क्या हो सकता है अब? What should be the next step? Psoriasis को ट्रीट किया लेकिन इम्प्रूवमेंट नहीं हुई, वर्स होता गया पेशेंट. What should be the next step? Anyone? Before switching to biologics, we did skin biopsy. Skin biopsy findings were marked epidermal hyperplasia, focal interface papillary dermal elastosis, mild perivascular inflammatory infiltrates, focal interface dermatitis. Pathologist कहता है कि ये psoriasis नहीं है. तो these findings favors SLE. जब पैथोलॉजी वालों ने कहा कि ये psoriasis नहीं है, it could be the SLE. We investigated for SLE and later ANA was positive, high titers, anti-Rho was positive. You know कि anti-Rho also present SLE, musculoskeletal involvement in pediatrics, SLE and cardiac blocks. इसमें कैच पॉइंट्स क्या थे कि डायग्नोसिस psoriasis नहीं है, बिकॉज अल्ट्रावायलेट रेस psoriasis के लिए इज अ गुड ऑप्शन, methotrexate इज अ गुड ऑप्शन, बट दीज आर नॉट गुड फॉर SLE. जैसे जैसे रेस अल्ट्रावायलेट को देते गए वो वर्स होता गया. SLE में तो हम सन ब्लॉक को यूज़ करते हैं. Diagnosis was reviewed after biopsy, and it was found it has a psoriasiform subacute cutaneous lupus erythematosus. It is a mimic of psoriasis. It is not actually psoriasis. It is a psoriasiform lesion, which is found in SLE. And when we see the literature, treatment was reviewed, hydroxychloroquine, topical steroid, azathioprine was given, and after giving this treatment, 3 to 6 months, patient started to improve. When we see the literature, psoriasiform subacute cutaneous lupus erythematosus is very rare. 4.5 cases per 100,000 cases, just like SLE. And it is usually diagnosed on biopsy and immune markers. When we see the data of psoriasis, it is common. 60 to 70 cases per 1,000 cases. That's why it was thought first. It is common. And it has a good response, phototherapy, methotrexate, and anti-TNF inhibitors. This is the reference. Now we'll discuss the second case. It is also common, we usually see in OPDs and wards. A teacher of 32 years old presented with swelling and pain of the distal interphalangeal joints from last 1 year duration. No skin involvement, nails are okay. Other joints and systemic inquiry unremarkable. Only swelling of the DIPs, young patient. His lab shows hemoglobin was low, 9 gram per deciliter. Platelets were 127, WBC normal, liver, renal function and urine complete examination all normal. RF factor, anti-CCP also normal. This is the X-ray, it's a blurred picture. It's showing the erosions on DIPs and also on proximal interphalangeal joints. What could be the differential diagnosis? Young patient, involvement of DIPs, nothing else. There is a pain and swelling clinically. What should be the differential diagnosis? क्या हो सकता है जी? Number 1, psoriatic arthritis. Number 2, rheumatoid arthritis. But RF factor is negative. Seronegative arthritis भी हो सकती हैं. With these symptoms, only NSAIDs were given in the beginning with mild improvement. Later on, low-dose prednisolone was added with no improvement. By thinking it could be an inflammatory arthritis like psoriatic arthritis or rheumatoid arthritis. Methotrexate was added, but its response was partial, not a good response. Our differential diagnosis at that time was psoriasis, psoriatic arthritis and rheumatoid arthritis. जब पेशेंट ठीक नहीं हुआ तो उसको रिव्यू किया गया अगेन आफ्टर फ्यू मंथ्स एंड व्हेन री-एग्जामिन्ड along with swellings on PIPs, there were capitations, bilateral basal capitations. Hemoglobin was also low. Platelets were 105. Other labs were okay. अब क्या हो सकता है? अब एग्जामिनेशन किया तो एडिशनल चीज मिली बेजल कैपिटेशंस along with DIP इन्वॉल्वमेंट. क्या पॉसिबिलिटीज हो सकती हैं? दोनों आप कहने को एग्जिस्ट कर रही हैं. ओके, क्या चीज? RA with ILD. ओके, ठीक है, ये भी हो सकता है. लेकिन हमने जब मीथोट्रेक्सेट भी दे दी, उसको सारा कुछ दे दिया, ILD क्यों डेवलप हो गया? हमने ट्रीटमेंट तो शुरू से उसका किया था, इतना वर्स तो नहीं होना चाहिए था. ILD इट्स अ गुड डिफरेंशियल डायग्नोसिस. जब हमने उसका HRCT किया तो इंटरस्टिशियल लंग डिजीज, अगेन कि उसका ANA करवाया तो उसका ANA एंटी DS-DNA was positive. ठीक है. You know, in the past it was considered erosive arthritis is less likely in SLE. But now, after the presence of the good diagnostic tools like MRI, CT scan, erosions is also very common in SLE. And more than 30% of cases have erosive arthritis in lupus erythematosus. These two cases were mimics of psoriatic arthritis, and later on diagnosis was different. केस सिनेरियो 3, ये भी हम बड़ा कॉमन देखते हैं, ये आपको पता होगा इसका ज़्यादातर को. Effective workers of 43 years old male presented with history of big toe pain from last 3 months. Initially pain was mild with good response to NSAIDs. Now from last 10 days pain is very severe. Toe was red and tender. On examination, there was a psoriatic patch on the skull. CRP was 45, uric acid 7.8, RA factor anti-CCP negative. क्या डिफरेंशियल डायग्नोसिस होगा जी? ठीक. और वो तो गाउट हो गया ना, ठीक है, एसोसिएशन होती है उसकी. और क्या हो सकता है? ये पिक्चर थी उसकी. इट वाज रेड, हॉट, टेंडर, पोडैग्रा एंड डेक्टिलाइटिस. उसका सोरेटिक पैच भी था, आपने वो भी ध्यान में रखना है. डेक्टिलाइटिस द कॉम्प्लिकेशन ऑफ सोरेटिक आर्थराइटिस. He was treated with NSAIDs, haloperidol, prednisolone for few days, along with colchicine. Patient improved, but again symptomatic. Partial improvement. It was thought it is not a gout, it might be a dactylitis. Allopurinol discontinued, and he was given methotrexate along with NSAIDs and low-dose prednisolone. But again, there is a partial improvement. Biologics given, etanercept was tried, mild improvement, again symptomatic after few weeks to few months, red, hot, painful. क्या possibility हो सकती है? Actually इस patient को दोनों चीज़ें थी, हाइपरयूरिसीमिया भी था और डेक्टिलाइटिस भी था. हमने एलोपिरिनोल डिसकंटिन्यू कर दी ये सोचते हुए कि डेक्टिलाइटिस है. जब एलोपिरिनोल डिसकंटिन्यू की, उसके भी सिम्टम्स आने शुरू हो गए और दोबारा एलोपिरिनोल ऐड करनी पड़ी उसमें. नाउ पेशेंट इज डूइंग वेरी वेल. देयर आर लॉट ऑफ स्टडीज शोइंग देयर इज हाइपरयूरिसीमिया इन सोरेटिक आर्थराइटिस बिकॉज ऑफ हाई सेल टर्नओवर एंड ब्रेक डाउन ऑफ द न्यूक्लिक एसिड. जब उसको री एग्जामिन किया, री टेस्ट किया, उसका यूरिक एसिड 9.3 हो गया था. This is the last case. Case scenario number 4. A patient, 32 years old, from Gujranwala. She shifted to rheumatology department from dermatology department. He had a complaint of joint pains from last 2 months. Both knees and right ankle were tender, swollen and warm. Biopsy proven psoriasis. There is also history of psoriasis. But there is no history of inflammatory backache, dactylitis, enthesitis, red eyes, any history of oral genital ulcers, altered bowel habits. No family history suggestive of psoriasis. However, history of nail involvement was present. There was pitting. There is also a history of low-grade fever, 9900 in the beginning. He had a fever. Cultures were negative. All cultures were negative. For his psoriasis, topical medicine was given. From last 2 months, he was started methotrexate. Maybe fever because of inflammatory arthritis की वजह से हो रहा, low grade. Methotrexate was added. But fever and psoriasis was not under control. फीवर 100 तक में हर वक्त देखते थे 9900 इस रेंज में उसका फीवर रह रहा था, सेटल नहीं हो रहा था. एक्टिव सिनोवाइटिस बोथ नीज एंड राइट एंकल. नो एविडेंस ऑफ अदर जॉइंट्स और डेक्टिलाइटिस. नेल पिटिंग वाज प्रेजेंट. पासी वाज 14%. No oral genital ulcers, lymphadenopathy, systemic examinations, unremarkable. Blood count, liver function tests, RFT is all normal, but CRP is high. Dose of methotrexate was increased 10 to 15 milligram per week. Patient then evaluated for the start of biologics. Improve नहीं कर रहा था, ना arthritis, ना psoriasis. लो ग्रेड फीवर था, इन्फेक्शन स्क्रीन नेगेटिव थी. ये सोचते हुए उसको बायोलॉजिक्स के लिए प्रिपेयर किया गया है. BC, T spot नॉर्मल, चेस्ट एक्सरे नॉर्मल. Despite increasing methotrexate, his fever, arthritis worsened. नहीं ठीक हुआ उसका. क्या पॉसिबिलिटी हो सकती है? HY is the possibility. ठीक है. Methotrexate stopped. Again, cultures were sent. Culture, blood culture, urine culture, skin swab, all negative. Broad spectrum antibiotics was started, but fever not settled. Later on, infection screen turned out to be negative, fever not settled. Okay, fine. Then evaluated for HIV. On careful examination, there was also a history of high sexual activities, which patient initially denied. Now thrush was also present. Rapid antigen testing for HIV was positive. HIV ELISA done twice, it was also positive. HIV RNA was also positive. As CD count were 350 per mm3. Methotrexate stopped, patient was put on heart therapy. After 3 months of therapy, viral load decreased, fever settled, there is improved arthritis. Probably arthritis HIV की वजह से उसका ठीक नहीं हो रहा था. Methotrexate बंद करने से, हार्ट थेरेपी शुरू करने से इम्प्रूव होना शुरू हो गया. इसकी भी हमने स्किन बायोप्सी करवाई थी और उसकी फाइंडिंग्स थी पैराकैरियोटोसिस, डिमिनिश्ड ग्रैनुलर लेयर्स, dilated blood vessels, thinning of subpapillary plates, intermittent parakaryocytis, perivascular infiltration of the lymphocytes, the presence of occasional neutrophil aggregates in the epidermis. हमने सोचा कि कहीं ये psoriasis फॉर्म ही जिस तरह पहले आ गया कि ये वही ना हो, लेकिन it was psoriasis. और the histological features of HIV-associated psoriasis might be identical to classic psoriasis. However, diagnosis may be difficult. In HIV-associated psoriasis, there are few T cells. Dyskeratotic keratinocytes and lymphocytoclasses, but plasma cells are common. Since plasma cells are easily detected on the skin section, stained with H and E stain, the presence of psoriasis, presence in psoriasis skin biopsies should be, presence of यहाँ पे miss हो गया, basal cells usually यहाँ पे लिखना भूल गए, presence of basal cells should arouse the suspicion of HIV. एक तो T cell कम होंगे उसमें और दूसरे basal cells होंगे उसमें. This is all for 4 cases. Now take home message is always review the case when patient is not improving. Always re-examine, consult with other specialties and senior, and there is no alternative of history and examination. Thank you so much.
Thank you so much, sir. Moving towards our last talk of today's conference, a topic of utmost importance in rheumatology. It is crucial to recognize the stark reality that many individuals around the world face significant barriers in accessing essential rheumatologic treatments due to various resource constraints. Today, we hope to explore innovative strategies and practical solutions aimed at bridging this gap. Our eminent speaker, Dr. Bilal Azim Butt, will offer his insights and experiences, which will undoubtedly inspire us to take meaningful action in pursuit of better rheumatologic care. Dr. Butt is consultant rheumatologist and assistant professor in Department of Medicine at Fatma Jinnah Medical University, Lahore. Sir, please come on stage and present your talk.
Thank you. Thank you so much. Bismillah ar-Rahman ar-Rahim. First of all, I would like to thank the organizers for giving me the opportunity to stand here and talk to all of you. I'm really grateful to Professor Tafazul and his team and all the Rheumacon organizers. So I'll talk about treatment strategies for rheumatic diseases in resource-limited settings. I'm Dr. Bilal and Head of Department of Rheumatology at FGMU. I don't have any disclosure, but there are several disclaimers I'd like to announce here. Firstly, all these treatment strategies that I'll tell you are expert opinions or suggestions. They may not follow the guidelines or recommendations that you read in books. And most of the patients are, all of the patients are actually real patients, and the scenarios are actually real scenarios that we face in public sector hospital like Fatma Jinnah Medical University. Next statement जो है, इसको ज़रा first, I'll tell you a few learning outcomes. The first outcome will be to appreciate the mindset of treating patients not as disease, but as a complete human being. Whenever we treat a patient, we should look at the patient as a complete human being, not just as a disease. उसकी disease को treat नहीं करना, पूरे के पूरे patient को और बंदे को treat करना है. Then the learning outcome is to understand the difficulties that arise while treating such patients. And lastly, to know suggested strategies in resource-limited settings, both in terms of access to care and treatment modifications. Last जो है, जब हम presentation बनाते हैं तो we are told कि आप yellow color और dark colors use ना करें, वो eye के लिए बहुत irritating होते हैं. लेकिन मैंने specially ये color इसलिए yellow में लिखा है ताकि आप सब लोगों की आंखों को irritate हो कि this is to suggest that our system, we should work, जिसके पास जितनी power है, work to improve the system in such a way that our patients do not have to rely on the second option for anything. Our system should not beg to follow the things which are not state of the art. So beggars can't be choosers. So therefore, we need to improve our system, improve our healthcare to reach at a level where we can provide state of the art treatment to every patient. So let's move on. I have a few cases. First case, she's a 55-year-old widow diagnosed as seropositive rheumatoid arthritis 10 years back. Came to our rheumatology OPD with flare of arthritis. She has many poor prognostic factors for rheumatoid arthritis. She has no siblings and her parents are not alive. She has one daughter who is married and she is homeless and never even made a national identity card. So look at all the problems that she has. These are her hands. So when she came to us, she was taking 15 milligrams of methotrexate per week with prednisolone and hydroxychloroquine. What modifications we did, we increased her methotrexate to 20 milligrams, gave her a short course of steroids, continuous hydroxychloroquine, and asked her to follow us up with the labs. On follow-up, she didn't get her labs because she was not affording for the labs. She was still hurting, RA was moderately active, she took medicine in adequate doses but could not afford the labs. What should be done now? Fellows, हमारे इसमें बताएं कि we gave her methotrexate full dose, she didn't improve. ये एक guidelines हैं. These are the latest guidelines by American College of Rheumatology which suggest that patients with poor prognostic factors, which she had, should go straight towards adding a biologic or a JAK inhibitor. If there are no poor prognostic factors, add a second conventional DMARD. She falls in this category. But there were several limitations. She was non-affording for biologics, JAK inhibitors, even for labs. She had no CNIC and no family support. फिर क्या करना चाहिए इसके साथ? हाँ. So what we did, इसमें option ये था, we added a second dose conventional synthetic DMARD like sulfasalazine or leflunomide and followed up the patient. These were not according to the guideline, but it was a feasible strategy for such patients. Now there is a little data on this also. There is a trial, record trial that showed that non-inferiority of triple therapy compared to biological agents in terms of efficacy. Triple therapy was a first-line cost-effective option for patients who fail methotrexate compared to biological DMARDs. And this was the evidence. This was published in 2021. Another study showed that higher doses of methotrexate in combination with prednisolone or with another combination of DMARD like sulfasalazine or leflunomide reduces the percentage of patients that require biologic therapy. This was also published in 2014. So take-home message is, if the patient is non-affording, you can switch to, you can add a second agent. This is not according to the guidelines, but evidence has shown that it can be efficacious and it can be equivalent to biologics. Now let's move on to our second case. A 37-year-old divorced lady has 2 children, comes from a family that does not accept zakat, developed Raynaud's, skin tightening, joint pains, epigastric pain, burning and dyspnea 3 years back. She lived in a village near Lahore and went to several local doctors for these 3 years, who gave her symptomatic treatment like NSAIDs and PPIs. When she came to us, she came with her mother, with whom she lived after divorce, and she had similar complaints. These are few of the pictures, not her actual pictures, but she had most of these findings. Unfortunately, she's not alive. She had skin tightening, ulcers, decreased mouth opening, Raynaud's. CT में क्या नजर आ रहा है? Fellows को बता सकते हैं? Bilateral ground glass appearance. So what does she has? A scleroderma with interstitial lung disease and NSIP, non-specific interstitial pneumonia. So she was given calcium channel blockers, proton pump inhibitors, and mycophenolate. So what happens? She comes back after a few weeks. She cannot afford mycophenolate. So she didn't take mycophenolate, told that it is too expensive. So she had poor medical compliance due to affordability. She was switched to azathioprine because it is a cheaper option. On further follow-up, she was taking azathioprine and steroids, but there was no improvement. So what can be done now? These are the latest guidelines. ILD, if you have read that, these are the guidelines of treatment of interstitial lung disease, first in systemic sclerosis. First-line therapies preferred and additional, and glucocorticoid low dose can be given. So, इसमें क्या limitations हैं? Compromise access. 3 साल से she was going to some local doctors near Lahore, but she was undiagnosed. Cost of medicine is an issue, and as she was not of a family that does not accept zakat, so Baitul Mal option was not also there. And she was of childbearing age. अब कोई आपके और we convinced her. She was divorced. She said that she is not planning to remarry. So we switched her to cyclophosphamide and gave her cyclophosphamide. She was much improved. Later on, she developed tuberculosis and other things, but her interstitial lung disease improved. And there is evidence, first of all, to how to improve the access of care. 3 saal tak she was going to local GPs but didn't improve. There was a study done which showed empowering of family physicians by training them in rheumatology can be an effective tool to fight unmet needs. A statistical significant difference was found between the pre and post-course assessment of this program. This was done in Lahore by Dr. Saira and team and was published in 2020 in Clinical Rheumatology. So if they have done it, we can do it too, and we can empower our family physicians to improve the access to care. Now coming on the drugs, data shows that both MMF and cyclo were equally effective. In fact, cyclo is, I think, a little more effective in stabilizing lung function in patients with scleroderma-induced interstitial lung disease. The efficacy of MMF with respect to FVC and DLCO improvement is comparable to that of cyclophosphamide. Now let's move on to our case number 3. 22-year-old girl diagnosed with JIA. 3 years back, her illness started about 7 to 8 years back when she was 12 to 13 years old, but it was diagnosed just 3 years back with severe joint pain. When she came to us, she was already taking methotrexate 25 mg per week, hydroxychloroquine 400 mg per day, sulfasalazine 2.5 grams per day, and prednisolone 10 mg per day. She was compliant to treatment, but her disease was still active. इसमें क्या कर सकते हैं? वो वैसे नजर आ गया था शायद. इसमें तो ये फुल हमने किया ये कि fortunately we got her enrolled in Baitul Mal and she got a Etanercept. She was given 50 milligrams per week through Baitul Mal. But हुआ क्या? She improved initially. But जैसे होता है कि जब गवर्नमेंट चेंज होती है तो फंड बंद हो जाते हैं. So the Pakistan Baitul Mal fund stopped and she had limited number of injections. Now she started hurting again and she came back to us. What can be done now? इसमें ये देख लें. These are the guidelines that show that if it is there is no improvement, you could add a biologic or switch therapy. इसमें हमने वैसे ये किया. पहले limitations देख लें. Limitation of funds, follow-up labs, because she was on biologic, she couldn't afford that. So what we did was that we increased the duration of the Etanercept injections. जैसे पहले वो 50 milligram once a week ले रही थी, we increased it to 10 days. Or another option was कि we can give her 25 milligrams of injection per week. So either reduce the dose or increase the interval. क्योंकि ऐसे था कि बैतुल माल से उसके इंजेक्शन बंद नहीं हुए थे, but if we were asking them to give 10 injections, they were giving 5 injections. So Etanercept tapering can be done without losing efficacy in RA, psoriatic, and AS patients, and this was shown in a data in 2023. Patients with RA who have achieved low disease activity on Etanercept plus methotrexate, continuing both is superior to placebo, and reduced dose was also more effective than placebo drugs. This was shown in a study in 2016. And lengthening of the treatment interval, जब हमने देखा, we found out this, that lengthening of treatment is actually better than reducing the dose of the drug. So when we thought कि उसकी 25 कर दें या 50 कर दें, so the better option was to give her 50 milligrams but increase the interval to gap the period in which the drug was not available. This has also been shown in a data published in 2015. Now our next case, this is the last case, 35-year-old male with psoriasis for 3 years, presents with arthritis affecting the large and joints and inflammatory back pain. He was started on methotrexate but developed transaminitis. They were sent to me, मैंने उसको low dose दोबारा start की, but he again had transaminitis. And then alternate was tried like sulfasalazine, he had a reaction to that. These are actual pictures of the patient. ये आप इसके rash देखिए on the back, on the feet, on the legs. So he had real active skin lesions and arthritis was also active. इसको हमने थोड़ा सा convince कर लिया. He was a little bit affording. So he started secukinumab 150 milligrams subcut monthly without loading dose. आपके पास भी ऐसे पेशेंट आते हैं real time when you are limited by things और आप फिर कोई you try to find out a way where you can accommodate all the things. So we didn't load him, didn't give him 300 milligrams, gave him 150 milligrams subcut monthly without loading dose. He improved a lot, but he could only afford it for 3 months. Next year हुआ कि he lost his job, he was not affording for that anymore. So what were the limitations here? The cost and the drug side effects. इसमें हम क्या कर सकते हैं? इसने बैतुल माल से इसने भी कहा कि मैं बैतुल माल से नहीं कर सकता अफोर्ड. कोई और ऑप्शन है आपके पास? इसमें वैसे हम भी क्लूलेस थे. वैसे reduce dose हो सकती थी और increase interval हो सकता था. Fortunately or unfortunately, he was lost to follow up and has not come back. So the strategies here can be to either reduce the dose or increase the interval. Evidence has shown that 45.7% of chronic arthritis patients receiving low-dose biologic therapy after achieving remission at standard doses do maintain a good control of the disease. And the feasibility and efficacy safety of gradually increasing the dosing interval. इसमें भी ये है, do not reduce the dose, but increase the interval. And modified dosing schedule of secukinumab with gradually increasing the interval is still feasible. It was shown in a study published in 2022 in Dermatological Therapy Journal. Just an introduction, you should know that there is a huge impact of rheumatological diseases on the quality of life of the patients. There is a disparity, unfortunately, जैसे मैंने वो पहले वो शो किया, there is a disparity between resource-limited settings and the developed world. What are the constraints? High treatment costs, lack of infrastructure, like inadequate facilities, shortage of rheumatologists. What approaches can be done? Education and awareness. Education of the doctors, awareness of the general public, so that they know when to reach a doctor and which doctor to reach. And doctors can be educated who can go to far areas and practice rheumatology there and improve the patient's quality of life. Collaboration and partnership. Several NGOs are there, pharma companies, we can ask the government agencies to do something to improve the collaborations and partnerships in order to improve the access to care and improve the availability of these drugs to the patients. Telemedicine is a very good news that has came up in the COVID era. We can practice telemedicine in rheumatology, like tele-rheumatology. APLAR has also published guidelines on that. In that way, a patient in a far area can be linked to a doctor here in big cities, and treatment and advice can be provided. Affordability and accessibility can be improved by stressing on the government or the companies or the DRAP to have a control of the drug pricing. And we can do community-based clinics to improve the accessibility of the patients. Teams can go to different communities and detect and diagnose patients there, and then call them up in tertiary care setups to improve early diagnosis and improve quality of life. From my point of view, from my side, few strategies that I can recommend are, you can combine DMARDs instead of giving a biologic agent or a JAK inhibitor. You can use cheaper and effective alternates. You can increase the interval or reduce the dose. थोड़ा सा data मैं बताऊंगा. In FGMU, we see about 300 to 400 to 500 patients per month. Most of them are from low socioeconomic status. Most of them cannot afford expensive drugs and biologics. So what we do, we have Baitul Mal service there, we use that, or we have several NGOs or other things we can do that. There is a success story which I want to share with you, which is Arthritis Care Foundation. It is a good foundation. It is a success story of giving treatment to patients and improving access in resource-limited settings. I am honored that my training was also sponsored by Arthritis Care Foundation, that I am here in front of you and telling you all this. So we can do a lot of things to do our part in these things, in improving the care. So what are the take-home messages? Know your patient as a whole, identify the constraints, decide treatments keeping in mind all the factors, work to increase the awareness and education, plan to modify and adjust, do not stick to guidelines or do not be too strict in treatment options. And lastly, be the one to make the change. You can make the change. You can find out things. You can make NGOs or some other things which you can do to improve the access and make patients' life easier and improve their quality of life. And this is a memorable picture when we inaugurated our rheumatology department at Fatima Jinnah Medical University. इसमें कुछ लोग हैं which are really my mentors, like Professor Faisal Masood, Professor Nigat Mir, and all the team, Professor Sajid Nisar, Professor Sumaira, Professor Ahmed, सारे लोग. It was a memorable day for FGMU when this was done. Thank you. And if there are any questions, I would be happy to answer.
Thank you so much, sir. Now starting with the interactive session of panel discussion. Today we have Dr. Umair Javed, who will be the moderator for this session. Dr. Umair did his training from Shaikh Zayed Federal Postgraduate Medical Institute. He is ULAR certified and now working as a consultant rheumatologist in Indus Hospital. Sir, please kindly come on stage and moderate this session.
Thank you. Assalamu alaikum, everyone. After lunch, I think everyone is dozing off a little bit. So, a little bit more time. This is the last session of today's conference. I'm honored to moderate this session, and I want to congratulate Dr. Tafazul, Dr. Aflaq, to organize this session. And I want to invite our panelists on the stage. First of all, I want to invite Dr. Shakib Qureshi. He is an American board certified rheumatologist. Sir, please come on the stage. Next is Dr. Masim Afzal, Head of Department, Rheumatology Department, Gulab Devi Hospital. Our third panelist is Dr. Syed Ali Rukh Pirzada. He is Assistant Professor in Qaid-e-Azam Medical College, Bahawalpur. And the fourth panelist is Dr. Ashraf Ali Khan. He is American Board Certified in Infectious Disease. Sir, please come on the stage. And Dr. Khalid Parvez Babar will be joining us online. He is an Associate Professor in University Medical and Dental College, Faisalabad. This is our first case. 23-year male student resident of Lahore, admitted via OPD on December 2023 with complaint of worsening cough from past 2 weeks. This patient has left ear discharge which was present from past 8 months, and it was scanty yellowish in color associated with ear clogging and left ear hearing loss. Patient saw numerous ENT specialists for which antibiotics were prescribed, followed by brief improvement in the above mentioned symptoms. Hello. The patient was having worsening cough from past 2 weeks. This was the presenting complaint. And in HOPI, patient was having left ear discharge from past 8 months, which was scanty and yellowish in color, associated with left ear hearing loss. Patient took numerous antibiotics during this course. Second complaint was joint pain, which was present from past 7 months, and it involved small and large joints bilaterally, involving MCPs mainly, associated with swelling, redness and tenderness, with early morning stiffness of less than 30 minutes. The cough started from past 2 months with small amount of blood-tinged sputum and not associated with any constitutional symptoms, wheezing or dyspnea. At this time, 2 months back, patient was again managed on lines of lower respiratory tract infection. Now 2 weeks back, patient developed hemoptysis along with the cough, along with facial pain, which was localizing to the paranasal sinuses area, along with blurring of vision with watery discharge from eyes. He first presented in department in September 23. Available treatment options were discussed with them, but the family wasn't compliant. The patient visited rheumatologist and they started mycophenolate mofetil at the dose of 2 grams per day along with prednisolone 40 mg per day. So the what other key areas in HOPI should have been explored in context of above mentioned symptoms? Because in rheumatology we are facing autoimmune diseases and they don't usually present every time with the joint pains. Sometimes physicians find it difficult that what the disease is going on. Dr. Mason, please, if you can.
Hello, Assalamu alaikum. This history, which is quite a chronic type of history, it all started with the ear discharge and then cough and hemoptysis and then inflammatory joint pain. From the history, obviously we know that something chronic going on, and then when we see such type of history, we think about because the patient's infection is not resolving with the antibiotics, so we should think about other causes like vasculitis and tuberculosis and tumors and foreign bodies, etc. So because this history is directing us toward the vasculitis from the rheumatology perspective, so obviously we need to explore a little bit more, ask the history of any nasal discharge, nasal bleed, any nasal crusting, ask about any mouth ulcers, and hemoptysis you have already told. And then we should see if patient got any signs of rash, purpras, and if he's getting any hematuria, getting any preorbital or periorbital or facial puffiness. So systemically we should ask all the related questions to find out whether the patient was, or if there is any history of TB contact, history of weight loss, history of loss of appetite. So all these things will, that will direct us toward the right diagnosis.
Okay, thank you, sir. So there was no history of persistent rhinorrhea, epistaxis, nasal crusting, any bluish discoloration of fingers, and there was no history of any shortness of breath. In chest, there was only symptom of cough with hemoptysis. There was no pleuritic chest pain and wheeze. There was no frothy urine, no history of any numbness of hands or feet, and no oral ulcers, rashes, photosensitivity, and skin tightening, and no proximal muscle weakness symptoms were told. Patient was not diabetic or hypertensive. Past medical history was not remarkable for tuberculosis. Family history, there was no history of any autoimmune disease in this patient and no history of any asthma. Patient, although took shisha consumption, vape use, and cigarette smoking. I want to ask Dr. Shakib here that this was a young gentleman, 23-year age, and nowadays IV substance abuse is being commonly taking place. So we have heard cases that sometimes these agents can also mimic vasculitis. They can cause nasal crusting and they can mimic ANCA-associated vasculitis. So please, sir, give your opinion on the drug history in these young cases.
Yeah, so shisha, I'm not sure about, but I've seen cases of cocaine-induced vasculitis. So cocaine along with levamisole can be pretty toxic.
Right, sir.
And it can cause a picture very similar to Wegener's GPA and stuff. The difference is that typically you can have both CNCA and PNCA positive, and you can have actually both MPU and PR3 positivity too. So, but obviously those patients have clear-cut reasons to have that kind of a clinical picture. Shisha, I'm not sure about actually.
Right, sir.
So it's not that popular where I work actually, so I don't know. Maybe the local data would be different.
Okay, so this patient was denying cocaine abuse and alcohol. In drug history, patient took NSAIDs and analgesics during this course. There was multiple courses of IV antibiotics. So I want to ask, we will go to the general physical examination. Patient was having normal blood pressure, respiratory rate was 24 per minute, pulse was 92. There was gum hypertrophy with a rash on the elbows which was maculopapular and non-blanchable rash which was likely a vasculitis. There was no jaundice, lymphadenopathy, cyanosis and clubbing. So what other systemic examination findings we can look in this context? Dr. Ali, please.
Hello. Thank you. I would like to check his chest and local examination of the nose and pedal edema, periorbital puffiness, as there is multi-system involvement, paranasal sinuses and respiratory tract as well. And you have told me that he is having the history of the hematuria as well. So related to kidney, I would like to extend my general physical examination to face and other signs and symptoms of the renal failure, especially ascites and pedal edema especially.
Okay, sir. Thank
This
you.
gum hypertrophy, there is a condition called strawberry
Yes.
gums. Strawberry gums can happen with GPA, I think.
Right.
I think there are some malignancies which can do the same. So I think these two things will come to my mind.
Right, sir. So in the systemic examination, there were no crackles in the chest, no veins or bronchi, and there was no murmur. CNS examination was normal. There was no focal paresis, and planters were downgoing. Currently, at the moment, there was no active synovitis identified, although the patient was giving history of small joints and large joint pains. On the admission, TLC was raised 15,000, normal platelets, ALT, AST were normal. ESR was 94 with CRP 149 and procalcitonin was also raised. Creatinine was normal, Hep BC were negative. Urine DR this was unremarkable and COVID test was negative. Sputum culture though came positive for MRSA. This is the X-ray of this patient. So here I want to ask a question from Dr. Ashraf Ali Khan, who is ID specialist. So this young gentleman has symptoms of likely autoimmune disease with vasculitis likely, and sputum culture is positive. So at the one end we have to treat the infections, and at the other end we have to treat the autoimmune component. So how could we balance these two different perspectives?
Assalamu alaikum, and thank you for inviting me to this conference and to this panel discussion. So, मेरा ख्याल ये है कि there may be two layers to this problem. इसको कोई underlying subacute या chronic illness भी चल रही है, something like an autoimmune disease. But on top of that, maybe he has MRSA pneumonia that can look like this actually. I mean, it may all be MRSA pneumonia. But I really struggle to think that, he wasn't given MRSA treatment. I mean, he must have gotten Targocid, he must have received linezolid and what have you. Because, if he went through multiple courses of antibiotics, he might have been given that. So that makes the situation even more complicated to think whether the MRSA is a colonizer on top of the GPA, or is it true infection? His PCT wasn't all that elevated. It was 1.1 to 0 point something at one point. So I may leave the MRSA alone, but I would also try to find out what was going on with him. Is he spiking fevers? Is it possible that because of all the IV infusions that he received, maybe he has MRSA, endocarditis, and he's embolizing to the lungs from the right heart, endocarditis. That's a possibility. From infectious disease point of view. So I would definitely try and get him off antibiotics for 48 hours and repeat blood cultures and see if he grows that. And if the consideration is strong, such as if he has any murmurs, then I would also do an echocardiogram.
Okay. That's
TB testing?
Sorry?
TB testing was negative?
TB test later on was done, that was negative. Initially, when patient presented with hemoptysis, at that time COVID testing was done, and then later on TB test, that was negative.
Fungal testing?
Sorry?
Fungal cultures?
No, fungal cultures were not sent at that time.
Because these cavitary nodules bother me.
This is the HRCT test showing multiple cavities and non-cavitating nodules with CT PNS showing mastoid air cell opacification with destroying of bony septas. Patient ANA, DSTNA were negative, C3, C4 were normal, and ENA profile came out negative. Patient CNCA's levels were done. It was significantly raised, more than 200, and PNCA was negative. Our diagnosis is like granulomatosis with polyangiitis with ear and upper respiratory tract infection and chest involvement. Kidneys were spared along with MRSA infection. What other steps, management steps, like Dr. Ashraf Ali Khan Saab said that we have to treat the infection first, and after treating infection, we also have to look for the other sources like echocardiography for endocarditis. Then we can treat the autoimmune component. In keeping with high disease burden, concurrent infection ID specialists were consulted. Clindamycin was started in this case. Patient improved clinically. His CRP, procalcitonin later on start getting normalized, and then low dose immunosuppression was started under cover of antibiotics. So methylprednisolone was given 125 mg per day with total dose of 1.5 gram, and first dose of rituximab injection was given 500 milligram. As he was also experiencing facial pain, pain management department was consulted, for which piroxicam, tapentadol and pregabalin were advised. He was discharged later on MMF and prednisolone with follow-up dose of second dose of rituximab after 1 week. Patient again admitted after 1 week in January 2024 with massive hemoptysis before the second dose of rituximab was due in this case, along with dyspnea and desaturation. In this time, patient was admitted to the ICU, and HRCT was showing multiple infiltrates in the chest, could be likely due to pulmonary hemorrhage. Injection methylprednisolone was started at that time with 1 gram per day dose for 5 days. IV immunoglobulins were discussed with the family, but they were not willing at the moment, as it is an expensive option in our setups. At the time they consented, after 5 days, patient clinically start getting improved and later on shifted to ward after stabilization. Prior to discharge, second dose of rituximab was planned, but pulmonologists suggested to defer the second dose, suspecting the chest infection, as raised TLC along with persistent cough and hemoptysis. After 1 week of this episode, patient again developed sudden massive hemoptysis and dyspnea, and at this time he could not make to the hospital and he died. I want to ask Dr. Shaikh that in this context, what gaps are there which are present in this case, and how can we modify the patient disease course during this time?
In my opinion, I think my suspicion for infection is pretty high compared to even the GPA presentation. So I think any attempt to get the biopsy of those lung nodules, whether it's, or maybe a bronchoscopy with bronchial washing, should have been obtained. I think he was relatively strongly immunocompromised too. I think he was given rituximab and then followed by Celcept also. I typically don't combine them together unless it's the last resort. In my opinion, I think TB or fungal infection, given the fact that they have cavitary nodules, and obviously an echocardiogram, as you mentioned, should have been done way earlier than later, because vasculitis picture the subacute bacterial endocarditis can also produce all the symptoms of vasculitis typically. Yes, ANCAs are strongly positive, and that's one thing. So, but I think clinical picture, in my opinion at least, there is a strong suspicion of infection.
Okay. For infection, but we often see that MRSA is often colonized in GPA cases in the nose, and in this case, culture came out positive. And there are case reports that sometimes it can flare up the disease in stable GPA patients. I want to ask Dr. Khalid that what is your experience in these cases? Should we do routine screening in these GPA cases to detect these colonizations? What should be done? Dr. Ashraf, please. Sorry.
Checking for colonization is not available everywhere. I think in the West they are doing MRSA PCR, for which the result comes back pretty quickly. But in an acute setting, if a patient is presenting like this, I don't know if I would do MRSA screening. I mean, it depends on the service. You know, if the rheumatology service does this as a routine, then yeah, I would favor that. If you find out that they are MRSA colonized, you could decolonize them with the use of mupirocin and with the use of chlorhexidine baths. Unfortunately, immunocompromised patients who are colonized with MRSA become recolonized again after decolonization. So I think it's something that we can try and then just screen them again to see if it's gone away. Other than that, you know, you would have to just treat the infection as it comes.
Okay. Thank you, sir. We have a drug approved. Sorry.
HRCT repeat. उसपे क्या findings थी?
There were multiple cavities and nodules in the HRCT chest.
No, repeat HRCT chest.
Sorry?
Repeat HRCT.
There were ground glass haze in the chest and along with alveolar shadowing. So we were suspecting pulmonary hemorrhage as the HP dropped to about 2 units at that time and patient was desaturated.
I think Plex should have been done at this stage of the time. It would have benefited the patient in terms of infection control as well as ANCA-associated vasculitis presentation. Both of the things would have been covered with Plex, plasmapheresis. If patient was not ready or patient attendants were not ready for the IVIGs.
Okay. But the current guidelines which we see, sir, there is more role of IV immunoglobulins told in these cases.
If patient attendants were not affording for the IVIGs, then Plex should have been done at this stage of the time.
Okay, right. I want to ask another question from Dr. Massam that in treating GPA cases, we see these patients have disease damage component as well as a disease activity component. So in managing these cases, how can we differentiate between these two aspects in this case? In generally, sorry.
What's the question again?
In GPA cases, these patients have active inflammation, active ongoing damage, and these patients often have past inflammation which has caused disease damage in this case, for which findings usually came on positive on repeated scans, and they are usually not responding to the immunosuppressant medications. So when a patient presents to us, so how can we differentiate between these two aspects, that the patient is having actually active disease at the moment, or the disease is in remission and the symptoms are due to the past damage? For example, we see in SLE cases, nephritis cases, patient whose proteinuria is not getting settled after immunosuppressant medications. That is not getting normalized along with immunosuppressant medication updose. So
obviously, if there is a proteinuria can stay there for some time, and with the treatment, it should improve. In case of SLE, for example, if we see we check for if there are any casts in the urine, for example, red cell cast or granular cast or anything like that. We also check the disease activity with the help of immunological markers like complements, anti-dsDNA testing. So we check the disease activity like that. Obviously,
yes, sir.
Actually, you want to ask what should have been done to check the disease activity? Is that the question?
Yes, often we see that C-ANCA level don't usually correlate with disease activity that well. So, clinically, how other findings which we could see which could help us in this case?
ANCA levels gets higher when the disease activity gets higher.
Okay.
It is proportionately increases with the disease activity.
Okay, sir. Let's move to our second case.
One question I would like to ask.
Yes.
For a comment from the panelist. That the same question I would ask as Umair has said, that this patient specifically had lowering ANCA levels while on treatment with mycophenolate, mofetil and steroids. But later on, with trends going down, the patient started having hemoptysis. So that also led to the important thing in mind that whether it was an infection or a disease burden. First, I would like you people to comment on that.
Second, the question is that why the ANCAs went down?
ANCAs went down.
Yeah, I mean, like ANCA's role is controversial, whether it goes up or down with the disease activity. It can be variable in a patient. So that's why it's not like included in the guideline that you always check ANCAs for the disease activity. So ANCAs in an individual patient can mean something, but it is not something that you rely upon. I think again, I think the question he was trying to get at was that how do you measure a disease activity in a patient when the changes are chronic or you always see them the same. I think it's a clinical condition which is important. For example, in this patient, as he was saying, if these cavitary nodules were like a month old and then you had a partial resolution or slight resolution, but the clinical condition was not improving, then you go with the inflammatory markers. Like has the SED rate improved, has the CRP improved, has the anemia improved, has the white cell count gone down. So you look at the whole clinical picture rather than one subset of, I think, part of the puzzle. I think, was the autopsy done and did you ever find the answer or no?
No, sir, autopsy was not done.
Secondly, just another part of it that this patient, when presented to us second time in December, end of the December, so he was also having a very overburdened infection. And with infection and infectious disease specialist input, she was of the idea that both needed the treatment. So Dr. Ashraf, with a low dose of pulse therapy, I think so, 125 milligram is also not a low pulse. It's a very high pulse, but we wanted to give the patient 1 gram.
Did you mention about bronchoscopy with lavage or like any cultures to be obtained?
Sir, cultures turned out to be MRSA.
No, with bronchoscopy. Like
bronchoscopy wasn't
bronchial
done.
lavage or something?
It wasn't done. Pulmonology didn't go
that
for
would be the next step. Typically, pulmonologists would go with the next step if you're highly thinking about an infection, just to find out what kind of an organism. What do you, Ashraf bhai, don't you think like with cavitary nodules, fungus and TB would be pretty high on the list?
It becomes very complicated with the underlying possibility of GPA, because if he's having hemorrhages, then that's more it's more consistent with some necrotic element to his disease, which is more likely to be the GPA itself. Having said that, TB also causes hemoptysis and necrosis. There are certain other necrotizing pneumonias, including MRSA, that causes necrotizing pneumonias, and hence the cavities, and hence the pneumatoceles. So it's going to be really hard to decide, and we're going to have to rely heavily on the BAL, as Dr. Shakib was saying, and or sputum cultures, if they were available. Now, I understand that in a patient who's hemorrhaging, those studies are not reliable or even available. So it's a tough one. I mean, you can look at the PCT and the rest of the clinical picture and try to figure out whether this patient is presenting with an infection or with a vasculitic process.
Actually,
it's tough. I mean,
this patient's family was so much convinced that ANCA levels are going down, and so the disease is improving. So it was very difficult for us to convince them that it is other way around. And I think so they have denied plasmapheresis, IVIGs as well. So that was the turning point at that time that we missed this patient. Over to
if the MRSA grew during a previous culture, I wouldn't rely totally on treating the MRSA itself. The treatment should probably be broader than that and include community-acquired pneumonias and atypical pneumonias and such before we have any cultures available, if that. So I think something like linezolid plus piperacillin tazobactam would be the way to go. I mean, this patient could also have multi-drug resistant gram-negative organisms because of having been on multiple antibiotics. So treating him for those is a consideration, using newer antibiotics like Zavicefta or combination of Zavicefta and Estrionam. But that's a whole other chapter, you're opening up. But you have to rely on the cultures, basically.
Thank you, sir. Also, there are multiple studies coming on for finding new disease biomarkers in GPA, like IgG4 positive plasma cells ratio, which are there are multiple studies coming on. So let's see if there are any new marker come in the future. Now we are going to proceed to our second case. First. So this is a 31-year male, unemployed, resident of Pakpatan, admitted via OPD on August 2023 with the complaints of worsening pain in multiple joints from past 6 months. Joint pain started about 3 years back, involving small joints of hands, involving bilateral second and third MCPs, and large joints including bilateral shoulders and knee joints, along with swelling of left little finger and right middle finger, and whole finger was involved at that time, about 2 months back. Joint pains were gradual, additive, non-migratory, with early morning stiffness of more than 1 hour with function class 3, along with swelling and limited range of movements. It was associated with skin rash, which appeared about 1 year prior to joint symptoms, and there were silvery scales present on this rash. There was no history of any back pain, DIP joint pains, first CMC joint pains. There was no history of any visual changes, no symptoms of respiratory, GI or genitourinary tract symptoms in this case. So there were no ulcers, malar or discoid rash, photosensitivity and alopecia, and no skin thickening. There was no history of any loose stools or blood-containing stools, no IV drug abuse history. Patient was taking on and off analgesia and low-dose steroid from past 2 to 3 years. Symptoms worsened about 6 months back, along with worsening of multiple joint pains, along with dactylitis. So consulted rheumatologist about 6 months back, for which tofacitinib was prescribed 5 milligram BD, but the patient was not responding to the tofacitinib. Past medical and surgical history was unremarkable. Family history, there was no psoriasis in family. There was no history of any smoking or alcohol in this patient. In drug history, patient was taking prednisolone 10 milligram per day along with methotrexate 15 milligram per week and tofacitinib 10 mg per day from past 6 months. Examination, patient was widely stable. An extensive rash present on the chest, shins, elbows, knee and scalp with psoriasis score 13.2, which was quite severe. Along with onycholysis and hyperkeratosis of nails, lymph nodes were not palpable and there was no jaundice, cyanosis or clubbing. This is the rash in this case. It has scales present on this rash. These are the pictures of the legs. On examination, wrists were swollen along with bilateral knees, along with dactylitis of left little and right middle finger. DEPSA score in this case was 44, which was showing high disease activity in this case. These are the pictures of the hands showing dactylitis with swelling of whole digit. Rest of the systemic examination was unremarkable. In labs, ESR was raised, CBC was normal, CRP was 24, creatinine and LFTs were normal, Hep C was B and C were negative. So the diagnosis is psoriatic arthritis. Patient tofacitinib was started and secukinumab was started with 150 milligrams subcutaneously every month along with methotrexate 20 mg per week. For analgesia, delta-cortil low dose was being given. Patient improved after 3 doses of secukinumab, injection Frizerone, and soon after patient again went into relapse with worsening of multiple joint pains, along with worsening of skin disease. To date, 5 doses have been given and patient disease is not stable. So I want to ask Dr. Massam that please tell what next management plan could be there to deal this case.
First of all, patient was started on tofacitinib and he hasn't responded. So the recommendations are to first try, if patient is not responding to the disease modifying drug, to start the biologics. And normally we start with the anti-TNF. However, if there is a skin involvement, we start with the IL-17. IL-17 is preferable because this is a plaque psoriasis and disease burden is quite high. The normal recommended dose is 300 milligrams of secukinumab. So my question is, what was the dose?
Patient was not given induction as patient was not affording. So 150 milligram dose was given every month.
Okay. So next step should be actually to increase the dose to 300 milligrams.
Right.
And if again there is no appropriate response, then we can always change the biologics to anti-TNF or IL-12 to 23 inhibitors.
As in the previous lecture, Dr. Ali told that there are studies which are being done on secukinumab without induction dose and with induction dose. Yes, the best should be to give the induction dose, but in those patients where induction is not being given, often studies show that disease response is coming late in these cases. Dr. Shakib, I want to ask that if you want to add on this point, that how normally we should see the response after 3 months in these cases. Should we delay to check the response like we are 5 months have been done, and should we wait some time more in these cases?
I mean, this is one of those cases I think where again I would have tested HIV too. That is a kind of a standard we check on everyone. new onset psoriasis or a rapidly progressive psoriasis. So HIV should always be one of those things that you rule out before you embark on further immunosuppression. But I think Messam was correct in that sense that obviously there is a delayed response expected, but I think the dose escalation like to 300 milligram, and I think he continued methotrexate or he stopped it?
Yes, he was taking methotrexate.
Sorry?
He was taking methotrexate.
He was given methotrexate. And I think there are also kind of those ideas about combining some low-grade kind of oral molecules such as, he could have had Tesla ka dusra naam kya? The one we were just talking about? Apremilast. So maybe a combination of Apremilast along with, if the dose escalation cannot be done due to unaffordability, maybe we can combine Apremilast, which I think in Pakistan is not that costly as compared to biologics.
Right.
So that would have been one of the maybe potential strategies along with the topical treatment that the dermatology can offer you.
Right.
I think it will probably take multi-medication care approach. And I don't think there is another IL-17, there's not another biologic in Pakistan, correct me if I'm wrong. I don't think we have IL-23s, right?
Yes. Currently IL-23 is not available. From Dr. Ali, I want to ask that in clinics we often see this patient as this patient was having high disease activity, DEPSA was 44, and like the sir said that response to the secukinumab or any other biologics is not coming, but the disease is still high, disease activity is still high, but it has in the response criteria patient has shown active response like DEPSA has fallen down, but the disease is still active to some extent involving 1 to 2 joints. So what we should do in these cases further, generally speaking?
Actually, in this case scenario, we can increase the dose if patient is affording. 150 milligram once monthly it was being given to the patient. It can be increased to 300 milligram once a week, once a month. If still he is not responding well to the treatment, then as very rightly said Sir Shakib Saab, one should check for the HIV co-infection. If it turns out to be positive, then it should have been treated with ARTs. Then a patient would definitely be responding well to the treatment. But the lesions in this patient are very typical for the psoriasis. If they would have been like rashes, reddish or papillus squamous, then we should have gone for the biopsy of these skin lesions. So as we have seen variants of the papillus squamous variant of SLE rash as well.
If it was Yasser's case, it would be lupus by now, right?
Yes. So these two cases have already been discussed by Dr. Yasser. So I think we should go for the HIV. If not responding to 300 milligram once a month dose of secukinumab.
Okay. Thank you, sir. Thank you.
And second option is etanercept. That can be tried.
Okay. Thank you. That's a wonderful insight. So with this, I want to conclude this session, and I want to thank our panelists to be here and give their feedback on these cases. Thank you, sir.
Thank you so much. I would like to request our panelists to please remain seated. Professor Dr. Tafazul Haq Mahmood and Dr. Iflaq Rashid, please join on stage to present shields to our panelists and guest speakers. Professor Dr. Ashraf Ali. Dr. Mason. Dr. Mason Afzal. Dr. Ari Rukh Pizral. Dr. Shakib Qureshi. I would like to request Dr. Umair Javed to please come and receive his shield as moderator of our last interactive session. Thank you so much for the panel discussion. Moving on to guest speakers. Dr. Shakib Qureshi, thank you so much for your talk. Dr. Bilal Azim Butt, thank you so much for your enlightening talk. Thank you. Moving on to our very special guest of honor, Professor Dr. Mahajibeen Masood. Please come on stage. As our very special guest of honor. Thank you, ma'am, for being here with us throughout the conference. Now I would like Dr. Aflaq Rashid to please give Professor Dr. Tafazul Haq Mahmood Lifetime Achievement Award and Chief Organizer Award. Thank you so much, sir. Now I would like Dr. Tafazul to please give Dr. Aflaq Rashid Award for the convener of this session. Now I would like to call Dr. Adnan Akhtar to please come on stage for organizing this massive event. I would like to call Dr. Hussain Shakil. Thank you for your contribution. Dr. Kaisar Farooq, thank you for your coordination. Dr. Fatma, thank you for your efforts. Dr. Aftab Alam, thank you for a beautiful recitation and your efforts. Dr. Asadullah Nawaz, thank you for your presence. Dr. Ali Shabazz, thank you for your hard backstage work. Dr. Ahad, thank you for your media publication. Dr. Kashif Azim, thank you so much for your efforts. Dr. Mohammed Zulkarnain, thank you so much. Dr. Myra Khalil, thank you so much for co-moderating this conference with me today. Dr. Ariba Qureshi. Okay. I would like to now invite pharmaceutical company representatives to please come on stage and take their awards for sponsoring this conference. Thank you so much for your efforts. I would like to call them one by one. For Pfizer company, I would like to call Gohar Javed. Thank you, sir, for sponsoring this event. For Novartis, I would like to call Dr. Vakas. Thank you so much for your contribution. For Frezron, I would like to call Dr. Abdurrahman. From Gentech, I would like to call Mr. Mubashir Malik. Thank you so much, sir. From Matrix, I would like to call Rana Shakil Ahmed. For Tuzman Healthcare, I would like to call Mr. Muhammad Rafiq. For Mactor, I would like to call Mr. Arsalan Ali. From Getz Pharma, I would like to call Dr. Nadeem. Mr. Nadeem, please come on stage. For MedArt, I would like to call Mr. Naveed Zia. Naveed. For Hilton, I would like to call Mr. Masood Ahmed. I would like to call a representative from Roche and Click to Print. Please come on stage. Roche, please come on stage, as well as Click to Print. Farosh. I would like to thank Faletti for allowing us to host this wonderful event at their venue. I would like to call Khurram Hasim Akhtar. And Rizwan Bhatt. I would also like to call Muhammad Anas for handling our IT department. This brings us towards the end of our conference. I would like to thank Professor Dr. Fazl Haq and Professor Dr. Aflaq Rashid, as well as our esteemed guests, panelists, guest speakers, and guests of honors. Thank you for making this a successful event. I thank you all for your participation and enthusiasm here today, and we shall hope to see you all again next year. Thank you so much.